name is Sadat sir, Dr. Sudharani madam and Dr. Indira madam, scientific chairpersons for this today's session. I also welcome Dr. Arna Samath madam and Dr. R. Narasimha Rao, Railway Hospital Organizing Chairpersons for this PG clinics. I invite you all for the art for the lightening of lamp. I invite Dr. B. Janardhan sir to give his welcome address, followed by Dr. N. Ramesh sir.
Good morning to everyone. I welcome you all for this PG clinics for the benefit of the postgraduates of the Telangana state. After a break of 2-3 years, we could able to hold these PG clinics for the benefit of you. Make use of it because all the senior faculty members are here. They sacrifice their Sunday today to benefit you all people. Do attend all the sessions and make use most of it. Wish you all the best. Now I invite Dr. Ramesh sir to address the panel.
Good morning, greetings to all the dignitaries on the dais, students. It's a great privilege on behalf of Telangana State TSID Institute Committee. I welcome you all for today's clinics. So we have a tradition in Telangana State. We have been organizing this exclusive focus session for the education of postgraduate students from all medical colleges, and this year after a lull of maybe 2 years, so we have the opportunity at Central Hospital. We are holding this. I am grateful to the management of Southern Railways and Hospital Alapada as well as the medical department in charge, Principal Chief Medical Director's office for this rare occasion. And we all know that this kind of the education that we have been receiving in our graduation and post-graduation courses, that is asking questions and replying, giving adequate answers. This system of question answer started some more than 2,400 years ago. Socrates' principle of learning things. So we all, during our postgraduate days, the basic learning we get from ward rounds and OPD as the cases come. So seniors will ask the questions and juniors would like to give their answers through their reading as well as hearing and observing from their course of training. So the essence of post-graduation training, by the definition of National Medical Council, is that these students at the end of 3 years, DBS students, once you come out, you pass out, you should have basic skills to understand, appreciate, to define and appreciate the medical health problems related to DVL specialty in the community, right? And address these issues, health issues, by using latest state-of-the-art methods of diagnosis and treatment. And these principles should be akin to the and promoting, seem to be promoting the science and technology. Okay, so through research and constant training, that is the basic understanding of PG learning. So throughout your 3 years career, it is not difficult if you are very sincere, attending OPDs and ward rounds, attending and doing whatever you are asked by your seniors, including taking history, simple history, recording the basic signs and symptoms the patients are exhibiting, and the standard mode of treatment, applying it under the supervision of your seniors and teachers. So, but examinations are always, formidable. Any examination for any student at any level. So his or her personality before appearing examination will always be shaky. Because the simple reason is the most foolish examiner can ask more than any wisest student can answer. You got the point? So you should not be worried about your performance in the examination. If you are sincere for 3 years and going through the rigors of training, our DVL specialty has got very good schedule of training, both theory and practical, right? So if you are sincere enough, and you should not be worried about any of these facing the examination. And today we have our immense experienced experts in the field of DVL. They will make it rarest of the rare cases you encounter tough examiners, the way they behave with you, that scenario also they will create. And the simple as well as tricky questions they will put in such a way that to elicit best out of you students. You should volunteer for this kind of examination environment. This is only going to make way for your better improving your personalities. See, there are 3 aspects of development during the course of your medical education in general and post-graduation in particular. There are 3 ways they say to develop one's dimension of understanding an issue. One is the psychomotor skills. Psychomotor skills are the practical way of doing things when it is required. The intervention is a must. For example, applying your basic BLS methods or advanced life-saving methods. When it matters, you should be able to do that and get the desired result in the community. Similarly, monitoring of cases in the wards, acute cases, acute skin failure cases, or any cases that you admit, you have to monitor periodically and give the therapy. So, all those practical aspects, and as well as the affective modality, that means your personality, apart from the technical knowledge that you will gain in the form of theory, learning theory, ultrastructure, and various types of manifestation clinically, and correlation between the clinical manifestation and histopathology. The personality, each of us are different. Highly qualified, highly competent student goes out and he may not have very good private practice, but he may be good in his teaching skills in the hospital or college level. So one has to have a combination of good interpersonal relationship. They should maintain good relation with higher-ups and contemporary people and patients. We should respect the privacy of the patients and instill confidence in the patients. So all these qualities which go in the personality development of a student also should be learned while you are undergoing this 3 years training. It's not just the technical knowledge about the subject. It is the personal behavior in the community, your aptitude for research. And you should also develop at the end of 3 years training the skill of teaching basic things to PG students or paramedical students. Even after completion also, the people who work with you, whether in institutes or private practice, you should be a role model to them. You should be seen as doing right things, what you are actually propagating, what you are trying to teach to others, you are actually doing it yourself. So it's a big thing, 3 years of time. It's not just book reading, mind you. It's not just book reading. You need to follow so many things, and all these things will be taught in the last 3 years. And here you will get a glimpse of all these parameters that you should develop during the course of it, by the time you end the 3 years training. And you should also have this knack of placing the research work that is being done. You yourself should be able to start some projects by yourself. The thesis work that is given to you is make you to understand the methodology for going for research, and after the completion also, you should, even in private place or private practice also, remote places also, you should approach your case studies such a way that basic research you should be able to publish even in remote areas also. And also you have to analyze, you should have those tenets of capabilities to understand and give a the rating to the periodicals and research work that you find in journals, how good they are. That critical evaluation is very important, and that critical evaluation also you will learn through these question and answer sessions. 3 years of training, and today we are going to have 6 hours of training question and answer sessions. And most of you, not only those who are presenting cases, I wish people in the audience also be attentive. That's very important. It's very easy to get diverted when you are not right in front of examiners. So this art of staying at the moment is also, we are making you to get exposed. And there are about 10 prizes. There are 5 sessions, as you know. Each session, the best performing student and the second best performing student for each session we will choose. We have an expert committee of 3 members here. Without any prejudice, we are going to give 10 prizes today. So my best wishes to all the students, and it's a great fortune for me. The medical colleges, HODs, as well as the students were able to be brought here, encouraged, inspired on a Sunday to be present here. I'm very grateful to all the HODs of the medical college. Thank you very much for this opportunity.
Without any further delay, we start with the first case. So all the dignitaries, please occupy off. I invite the chairpersons for this session, Dr. Narasimha Rao Neta sir, HOD, Gandhi Medical College, EVL Department, Dr. Sudharani Madam, Professor, Gandhi Medical College, Dr. KSP Vaishnavi, ma'am, Dr. Vijay Bhaskar sir, and Dr. Shivaram Reddy sir to chair the first session. Now I call upon Dr. Ten Modi, PG from Gandhi Medical College to present her case. I invite Dr. Sivaram Reddy sir to chair this session. The duration of this session is 45 minutes. Please.
Good morning, one and all. I'm Dr. Taimari and my colleague Dr. Ramya from Gandhi Medical College are going to present a long case today.
Go ahead.
Sit down. You feel that it is an examination, okay? Whereas students, we are the examiners. Very good morning, all of you. It is just like exercise for the final year students. How commonly you are going to conduct the examination. The way you have to understand, you are not exposed for the examination. This is where examiner will assist the students. He knows the basic things are not having, he knows are not one thing. If he knows how much level he is having, the average, above average. These things, average and above average, there are not, we will see. Depending upon that, we will ask simple questions. In standard expected questions, the patient student is extraordinary. You want to give more marks before for the 1 or 2 questions for the rare questions and for the giving the higher marks. That is the assessment. All mixture of questions will be there. We will basically must concentrate on the basics. If he knows basics, he will push up to pass. His blunders, if he does, always he will be in this too. That's why always any student attending to the examination hall should be very makeup and all things. Many people should not become like that. This is like ideal student. The iron, apron is all required. Accessories required for the examination must be brought. He should always be quiet and calm. He should always be question to answer. He should not go beyond the whatever he knows. Should not be elaborated. Should be precise. We want to examiner will expect. You have gone telling something, you try to do some other things. We will always think so. These things, basic things, you must keep it in mind. And all of you put the attention. What basic things, what required, what the fundamental things we are concentrating upon that. Please listen.
Already, good morning everyone. Sir explained about the pattern. And one thing, just now Ramesh sir announced 10 prizes are there. This is not the only presenters, this is for the other students also. So please all of you attempt it and participate in active participation. To participate actively. It's not the only presenters. Sir, it is for the entire students.
You should also ask 1 or 2 questions to the audience also.
Please.
Yeah, don't answer. They don't answer. Answer from them is not satisfactory. You can same question to the audience also.
A 52-year-old male auto driver by occupation came with chief complaints of fluid-filled lesions all over the body since 1 month and painful oral ulcers since 1 month. History of present illness. The patient was apparently normal 1 month ago. Then he developed few clear fluid-filled lesions initially over the back, which gradually progressed in size and number to involve his scalp, face, chest and arms. The fluid-filled lesions ruptured spontaneously in a day or two to form raw areas and showed little tendency to heal. The patient developed raw painful areas in the mouth since 1 month. The lesions had little tendency to heal and gradually increased in size and number, making swallowing difficult. There was no history of fever or malaise, no history of itching, no history of lesions over other mucosa like eyes, nose, genital. Yes.
While you are presenting, I can ask any moment of presentation. Actually, always examiner having difficulty. Okay. Why you ask for this thing? what you want to know? What part you ask for that?
So, as like the patient has complaints of fluid-filled lesions, so it is going into the favor of blistering disorders. Few blistering disorders have associated itching, like in coming to the pemphigus group, IgA pemphigus, pemphigus herpetiformis, these conditions are associated with itching, and in pemphigoid disorders, villus pemphigoid, dermatitis herpetiformis, these conditions are associated with itching.
So you want to exclude those
Yes, to exclude the other
other
conditions.
conditions. Very good. Regarding the occupation, before that,
Yes.
we asked for the age. What is the inference for the age?
So age, usually the pemphigus, the age of the onset is around 50 to 60 years in the world. In India, there is an earlier age of onset, 30 to 40 years. So the patient fits in that age group, so he is around 52.
About people is there, what you want to think of?
So the prognosis will be poorer if it is an elderly age group.
These older patients.
More older, more than 70 years, we need to think of bullous pemphigus.
What is the significance of occupation here? Krishna Das is there. Auto driver.
He is an auto driver, sir. Here it is not significant, but in case he is a farmer, so there is a condition called biochemical pemphigus or contact pemphigus, where because of the contact with the organophosphorus pesticides, there is development of pemphigus lesion. So that is the significance of occupation.
Okay.
Another thing to mention, no history of palms and soles involvement. Is it significant in vesicular disorders?
Yes, no. There is a variant of pemphigus and bullous pemphigoid, which is dyshydrosiform type of pemphigus and bullous pemphigoid. And also drug-induced pemphigus, there is palms and soles involvement, and other conditions like bullous drug eruptions, also palms and soles involvement. So to rule out.
So what is the importance of photosensitivity and joint?
So that was to rule out systemic lupus erythematosus. There is also a bullous variant of SLE. So for that we've asked for photosensitivity and joint pains. And also porphyria cutanea data where there is associated photosensitivity.
Okay.
What is this?
Ultimately, you ask alternate candidate, one candidate, and both. Maybe it's exposed by one candidate. Essentially, equal opportunity.
Yes.
What is the significance of diarrhea here? Why should we ask?
In some disorders like dermatitis herpetiformis, they are associated with diarrhea. So that history was asked to rule out.
Likewise, patient is loss of weight.
Weight loss mainly to ask if any any concurrent malignancy is there, because in some blistering disorders like paraneoplastic pemphigus, they are associated with malignancy, and in bullous pemphigoid also there is association with malignancy. So to look for any association with malignancy, we have asked weight loss history.
Other thing is, one thing you have forgotten, regarding the fever, why should we ask fever?
Fever to know the general condition of the patient, and if any secondary bacterial infections are there, especially in case of pemphigus vulgaris, the patient might present with fever and malaise.
What is in all these things, you know that we should always keep the whatever suspecting, expecting, differential diagnosis points to be explained in this stage, so that we can identify the suspected provisional diagnosis by history itself. So all of you must understand these things should not be missed during the history taking. Okay, negative points also, whether it is positive or negative, whatever it must be mentioned and dated.
So another thing you mentioned about history of drug intake. What is the significance of to know about drugs, in particular vesicular bullous lesions? Because they are thinking in favor of vesicular bullous.
There is a drug-induced pemphigus also, in which mainly there are two types: the thiol group induced and the non-thiol group induced, mainly the phenol groups. So some drugs can induce pemphigus, especially D-penicillamine is most commonly associated with it, and captopril. So these are the inducers of pemphigus. They induce pemphigus. So once we remove the inducing agent, the disease automatically resolves.
What other anti-epileptic drugs?
Calcium channel blockers, beta blockers can cause. These come under the non-thiol and non-phenol group.
Apart from pemphigus, what are the other things you want to explore? Drug intake you asked. Apart from
Bullous pemphigoid also have drug-induced conditions.
and other things.
Bullous pemphigoid is also commonly caused by like oral hypoglycemics like DPP-4 inhibitors and AC inhibitors and ARBs, and also diuretics like furosemide. And also to rule out bullous drug eruptions, we've asked for drug intake.
What are the bullous drug eruptions? What are the different variants?
Bullous FD fixed drug eruption and erythema multiforme.
State some severe forms.
SJS and toxic epidermal necrosis.
Mucosal lesions, why do you ask history about the mucosal lesions?
Mainly in pemphigus vulgaris, to differentiate the under pemphigus, if we are considering, if we want to identify which it comes under which clinical variant, in pemphigus vulgaris the mucosal involvement is there. Even in case of pemphigoid disorders, mucous membrane pemphigoid has a severe mucosal involvement.
What is the percentage of involvement of mucosa in pemphigoid disorders?
In pemphigus vulgaris, it is almost all 80 to 90% cases it is involved. In case of bullous pemphigoid, only 10 to 30% cases show mucous membrane.
Which are the other disorders like which mainly involves the mucous
The bullous disorders. Even in paraneoplastic pemphigus, we have recalcitrant oral stomatitis and other mucosa involvement. In case of pemphigoid disorders, mucous membrane pemphigoid, linear IgA disease also shows around 70 to 80% of mucosa involvement.
What is the relevance of drug intake in this particular case? Drug addiction. Drug addiction. In this particular case, depending on the history, is it necessary? Is there any possibility of bullous eruption in this particular case?
He has not given any history of drug intake prior to this, sir. He is on actually regular diabetic medications, metformin and limify. And this is since 5 years, sir. The condition which he has presented with fluid lesion since 1 month only, and there was no change of any anti-diabetic or anti-hypertensive drugs, sir. So we don't think it is drug induced.
Yeah, because chronic bullous eruption is not a part of generally drug eruption.
Yes.
Next carry.
So to continue with the history, treatment history, patient was on tablet prednisolone 20 mg for the past 10 days. And past history, he is a known case of diabetes since 5 years on tablet metformin 500 mg and tablet limifride 1 mg twice daily. He is not a known case of hypertensive, tuberculosis, bronchial asthma, epilepsy or coronary artery disease. And there is no history of any similar complaints in the past.
Stop please. Here, what is the significance of hypertension, tuberculosis, bronchial asthma, epilepsy, CAD? What is the significance here? What should be asked here?
So one thing is because few antihypertensives, like I've already mentioned, like propranolol and captopril, diuretics and AC inhibitors and ARBs, they can induce even pemphigus vulgaris and bullous pemphigoid. So one is that, and the other is we might plan for immunosuppressants and steroids. So like basically steroids, so then there can be, there is a chance of risk of hypertension. So that is why we are ruling out if he is a known case of hypertension. And coming to tuberculosis, again as we...
Short and sweet, don't give stories. Question to answer. Tuberculosis.
Tuberculosis, so we need to rule out if there is any latent infection. There might be reactivation after we start treatment. And epilepsy, because phenytoin and phenobarbital also can cause drug-induced pemphigus, so that is why we are asking.
So, is there any role of bronchial asthma here? As a routine we asked,
Yes, routine
importance is there.
Routinely we are asked.
So, here, as you said, prednisolone already been given, but Still patient got the reasons, getting the reasons. Okay?
So,
Next carrier.
coming to the personal history, the
Regarding
patient-
past, is there any relevance asking about the HIV or any other immunodeficiency development? History of is it relevant or not?
I think there is more chances of secondary infection and opportunistic infection. So other than that, there is no exacerbation of pemphigus conditions.
But in the patient who takes on HIV or HIV, there will be common
Drug reactions.
So you must ask about the history of exposure and history of positive, history of any HIV positive, there or not. Should be asked. So you should not miss it. Any conditions with HIV with different stages like AIDS, vascular lesions, presentation could be there. So this history definitely must be helpful. Okay?
Please, next.
First,
Next one. Next. You go to directly pediatrics examination. Yeah. Yes.
To
Summarize the findings.
To summarize, a 52-year-old male auto driver by occupation came with chief complaints of fluid-filled lesions and raw areas over the back, chest, scalp, face and arms, and painful raw areas in the mouth with little tendency to heal since 1 month. His general physical examination was normal.
Go to direct
Systemic
pediatrics
examination was unremarkable.
Can I interrupt? So you have completed your history. From the history, you have come to some provisional diagnosis. Before going to examination, what do you think it is?
Based on the history, my first provisional diagnosis is pemphigus vulgaris, sir, because the patient is complaining of fluid-filled lesions with and associated oral ulcers also, so painful oral ulcers.
Okay, so if the oral ulcers are there and some lesions on the skin, it should be pemphigus, or how did you come to that diagnosis? Any other positive findings suggestive of pemphigus?
The history that it ruptured on their own and they have little tendency to heal, we can consider pemphigus vulgaris.
Even bullous impetigo also can occur, no? Bullous impetigo with aphthous ulcers can also be diagnosed.
Age group, it fits into the age group more towards 40 to
Yeah,
60.
you tell the exact order. Why did you think of pemphigus?
From history, the age group is in between 40 to 60 years. On exam, we have mainly history of asymptomatic fluid-filled lesions containing clear fluid, and which rupture on their own and with little tendency to heal. Spreading erosions.
So most importantly, it is spontaneous.
Spontaneous
There
rupture.
is no history of prior history of trauma, nothing. Spontaneous occurrence of this cells, not healing at all.
Yes.
Coming to the cutaneous examination, there were multiple erosions with crust of variable sizes, smallest measuring 0.5 by 0.5 centimeter and largest measuring 5 by 4 centimeter, distributed symmetrically over the scalp, face, chest, upper limbs, axilla, back, abdomen and thighs. Multiple, around 15 to 20 clear, flaccid bullae and few pustules of variable sizes, smallest measuring 2 by 1 centimeter and largest measuring 3 by 4 centimeter, was noted over the trunk, elbows, wrists and dorsal aspect of the hands. A thick adherent crusted plaques were also noted over the scalp.
Quickly you mentioned, how do you say it's flaccid twist on the examination?
The surface will appear wrinkled, it won't be tense. The surface will appear wrinkled.
What's the definition of crust? Next one, next slide. So it's a basic person, still should know what is crusting.
It is a dried up serous pus or blood exuding. Blood is especially, like blood usually is scab, but crust is usually serous or pus.
What is erosion?
It's a superficial loss of the epidermis.
What is the erosive ulceration?
Erosion is mainly a superficial discontinuity in the epidermis, and ulcer is a deeper discontinuity with a deeper aspect involving a deeper dermal dermis.
Total or partial?
So does it deal with the scarring or completely it's in the normal fashion?
If deeper dermis is involved, there is a chance of scarring.
Like now your whole ulcer involves the dermis. So how does the lesions heal?
They heal with scarring or some skin changes will be seen because in the dermis we have the collagen and elastic fibers. When remodeling occurs, there will be scar formation.
Now here you mentioned little tendency to heal. So which are the other conditions which don't heal, which heal spontaneously?
In bullous pemphigoid, there is spontaneous healing of the erosions will be seen.
So scarring is seen in bullous pemphigoid or pemphigus?
Mainly scarring is seen in mucous membrane pemphigoid, that is also called the cicatricial pemphigoid, that is associated with scarring. Neither pemphigus vulgaris nor bullous pemphigoid are associated with scarring.
Next.
These are the clinical pictures showing the erosions covered with crust and few flaccid bullae over the wrists and the dorsal aspect of the hands. In our case, the upper body was predominantly involved and the lower part was relatively spared. You can see crusted plaques over the scalp, face. Multiple ill to well-defined erosions of size ranging from 0.5 by 0.5 cm to 2 by 2 cm with few lesions covered with whitish slough that distributed over bilateral buccal mucosa and palate, and crusting was noted over the lips. These are the clinical pictures showing erosions over the palate and buccal mucosa. Even the left side was involved. The genital mucosa, nasal mucosa and conjunctiva were normal. Palms and soles were normal. Nails were normal. Nikolsky's sign was positive, and the bulla spread sign, the bullae extended beyond the marked margin with an angulated border.
What about the Nikolsky sign?
Nikolsky sign on there are two types. One is direct and marginal. Direct one is on giving lateral pressure over bony prominence, there is erosion created.
Bony prominence of normal or?
Normal appearing skins. And marginal is around the erosion or bullae in the normal appearing skin. When the lateral pressure is applied, an erosion is created.
Where the Nikolsky sign is positive, false positive.
False positive Nikolsky sign or Sheklerov sign is seen in pemphigoid group of disorders, sir, where the remnant of the roof, when it is pulled, the erosion keeps spreading. That is seen in pemphigoid disorders.
What about the TN and other term?
That is pseudo-Nikolsky sign, sir, or otherwise known as epidermal peeling sign. There, the peeling occurs not because of the acantholysis, but it is due to the keratinocyte necrosis. It is seen in burns, SJS and TENS.
Burns and cold burns or burns. What about the triple S? What is that?
Staphylococcus scalp skin syndrome.
So what is the other Nikolsky? What is microscopic? Just elaborate about other types of Nikolsky, like microscopic.
Microscopic Nikolsky, it is when there is no vesicle present, we can induce a vesicle by applying pressure with the eraser over a normal appearing skin. This will induce a microscopic slit, so we can take a biopsy from that area, so the slit can be visualized histopathologically. And,
What is dry and wet Nikolsky?
Wet Nikolsky is when in the initial stages of pemphigus, when Nikolsky sign is elicited, just raw erosion will be seen, which is the wet Nikolsky.
What is the significance of dry Nikolsky?
Dry Nikolsky indicates the lesions are healing, going towards healing.
What is indirect Nikolsky sign?
Indirect Nikolsky sign is also called as the bulla spread sign. It's also called as the Lutz sign. In this, it is mainly elicited by the bulla is marked with a pen, and then a lateral pressure is applied from one side of the bulla, and the bulla's extension beyond the marked margin is noted. In case of pemphigus group of disorders, we see angulated borders. In case of pemphigoid group of disorders, we see rounded borders.
Did you mark here? Where did you elicited that?
We have elicited one over the arm. A small bulla was taken.
Here, what is the other name called?
Bullous Stetson is also called as Lutz sign.
What are the other names?
Another sign is the Asbo-Hansen sign. It is similar to Bullous Stetson, but it is elicited over a small vesicle, and the pressure is applied perpendicularly instead of lateral pressure.
Go to the next one. Two slides before, just show me the picture. Because already now you came to conclusion that you are telling it's favor of pemphigus. See here, what is the reason for predominance of that scalp involvement and upper face?
Main scalp involvement, there is desmoglein 3 is more predominantly seen in the outer root sheath of the hair follicle. Especially in the terminal hair, the outer diameter is more compared to the vellus hair. So because of more diameter, there is more desmoglein 3 present in scalp. So there is scalp predominance in case of pemphigus vulgaris.
Can you tell what is the reason for positive Nikolsky sign in scarlet skin syndrome?
The exfoliative toxin acts like a molecular scissor and it predominantly cleaves the desmoglein 1 cell rather than 3. So we have superficial blisters and no mucosal lesions.
There are so many after oral ulcers, no?
Yes.
You told there is no asymptomatic lesions, so he doesn't have any problem in swallowing, taking
Sir,
oral.
asymptomatic fluid-filled lesions over the body, sir.
The
The oral lesions, it was painful he had difficulty in swallowing.
What are the other difficulties he has because of those oral ulcers?
There is superimposed candidiasis also, sir.
Okay. And
Associated pain. Painful
so that
oral.
is called painful. Painful deglutition, or what do you call that?
Or diaphagia.
Candidiasis, can you show exactly where is the candidiasis? You can point out with your finger.
So it's whitish slough we've seen.
So on examination, how will you make out whether it's candidiasis or not? Or just some white
So
exudate?
if we try to wipe it with a saline gauze, then the membrane will be
You have done that?
pseudomembrane will be separate.
You have done it?
Yes.
How could we differentiate from the leukoplakia?
So that will be white thick adherent plaques, and it cannot be removed easily, and there will be associated bleeding also.
Regarding in case of fungal, and otherwise plaque, how could you clinically differentiate from that? Something is different. Morphologically, while removing the plaque,
Like in case of candidiasis, the plaque can be easily removed, sir.
after that,
And there will be bleeding noted.
Noted. Point you are noted. Next, proceed.
10 minutes.
Total, you give the provision as per the history and examination, you have done, isn't it? Now give the total provisional diagnosis, you must give complete diagnosis. You want to complete diagnosis or differential diagnosis? What would you like to give? Which one your impression?
We would like to give provisional diagnosis of pemphigus vulgaris with superimposed oral candidiasis.
Patient is on treatment.
He was started on prednisolone 20 mg 10 days prior before he came to our hospital.
Is under treatment or stop treatment?
Now we have increased the dose and plan for pulse therapies. So, before coming to the diagnosis, once we've made the provisional diagnosis, we have done bedside tests, and we need to go with Zan smear over the lesion, and then we need to perform a biopsy, both a lesional and perilesional biopsy for HPE and direct immunofluorescence respectively.
So what do you see in Zan smear?
In Zanxmere, in case of pemphigus vulgaris, we will see rounded acantholytic cells with increased nuclear cytoplasmic ratio and perinuclear halo rim of eosinophilic cytoplasm, showing morning edged cells. In case of pemphigus foliaceus, we will see smaller and fewer acantholytic cells which are less rounded, cuboidal to diamond shape, with small nucleus and more of cytoplasm. Vulgaris.
Which other conditions Zanxmere is performed?
Other conditions. It can be performed in the vesiculobilous disorders and other than that infections, viral infections like simplex and zoster, and then it can be performed for molluscum contagiosum, leishmaniasis, and Haley disease and Darier's disease. And also in malignancies it is performed in disease.
Then in direct immunofluorescence, what do you see? How do you perform?
A perilesional biopsy is taken within 2 cm from erosion and it is stored in either NS or Michael's medium and it is transported, and direct immunofluorescence is done. Over the specimen, fluorescent conjugated antibodies are added and it is observed under fluorescence microscopy. In case of in our case, we are considering pemphigus vulgaris. We got the report of fishnet intercellular deposition of IgG and C3 in fishnet or chicken wire appearance.
So before that, DF, what were the biopsy findings? How many biopsies do you take?
Two biopsies from one lesional from a fresh vesicle and one perilesional for direct immunofluorescence.
What is the histopathology findings?
On histopathology, there was a suprabasal split with row of tombstone appearance of the basal cells.
What is row of tombstone?
Row of tombstone, the basal cells, there is a separation of the basal layer from one cell between the keratinocytes of the basal cells, but they are intact, their connection with the underlying, with the basement membrane is intact. So the individual cells are separated, but their connection with the basement membrane is intact.
How do you differentiate histologically from Haley disease?
Haley disease, they have a few acantholytic cells and there is a separation of the cells from each other, but their still intact connections will be present. They will give a appearance of dilapidated cell wall appearance.
See, what are the sites? One you told perilesional for DIF. What are the other source what else you take apart from skin?
We can take a hair sample also. The telogen hair can be taken and DIF can be done over that.
What else?
Mucosal biopsy also.
Yeah, still some more.
Zanxmere also, there are reports in which Zanxmere also can be, over Zanxmere we can do DIF.
Zanxmere, it's about in early pemphigus, about 40% in the cases they get. So what about indirect immunofluorescence? What is the relevance in pemphigus group of disorder?
It mainly it identifies the tissue-bound antibodies in which the serum or even the blister fluid can be taken from the patient, and a substrate is used, usually like a monkey esophagus can be used, substrate, and then immunofluorescence is done. This is also mainly to identify the tissue-bound antibodies. This is useful especially in cases where biopsy cannot be done, especially in children. Then indirect immunofluorescence can be used.
What are the other tests after DIF? Any other recent investigations?
Any other tests?
ELISA can be done where we can find out the circulating IgG antibodies against desmogens, and also immunoblotting and immunoprecipitation techniques.
What is the importance of ELISA here? PCR, ELISA, what is significant?
Circulating antibodies can be measured, so that we can measure the disease activity.
That is more important. Another thing is, you told that 2 samples must be taken. One is the regional and periregional. One condition where we can go for the normal skin for the biopsy. What is the purpose of taking the normal site for the biopsy? Which condition? Plus disorders, as we told, many differential diagnoses. Hepatic, dermatitis, hepatic forms. Is it correct or not?
Yes, dermatitis.
Next, any slides are there? This is the last one.
Can you tell the composition of Michel's medium?
So it contains ammonium sulfate, magnesium sulfate, potassium citrate, and pistil mucus.
Suppose you don't have Michel's medium with you.
Yes, so we usually send in normal saline, sir, which can be sent up to 36 hours.
Just normal saline.
And even if you want to,
So first the Michel's medium, if you have normal saline with us.
so Michael's medium that can be used, like we can store the sample up to 1 to 2 weeks, sir. And even more if you want, we can freeze dry it at 4 degrees Celsius and send the samples.
No, when you are having a easier normal saline, why you are going with the Michel's medium? 36 hours you can reach the lab, right? That is 1 day.
Mainly for peripheral areas where you can't.
It is not the normal saline, freeze, frozen normal saline. You have to pour in normal saline. The must flask which contains that. Hope you are doing it or you are using Michel's medium.
What figures we are taking, that's what he is asking. Not simply taking biopsy. What is the procedure, how you are sending the?
No.
Oh.
We use normal salines.
Okay, time is very less, then what other investigations? So now you take the conclusion, even for DIF and everything, it is suggested of pemphigus. So how do you manage this case?
After performing all the specific investigations, we need to do all the routine investigations also.
Routine, what routine investigation? You want to admit or you want
Yes,
to treat an outpatient?
we need to first admit the patient, do the routine and specific investigations, and then plan for the treatment. So this cases comes under moderate to severe type,
What are the severity scores in pemphigus? Not only pemphigus, in Buller's disorders. What are the different types of severity scores?
Pemphigus disease activity index, pemphigus area severity score, and autoimmune bullous skin disorder intensity score abscess, and Karnofsky score in case of bullous pemphigoid, Saraswat score.
So here, what is the severity? Is it
Comes under moderate pemphigus, more than 5% body surface area. So actually, like the definition of moderate pemphigus is more than 5%. Yes. Moderate to severe symptoms. The lower body is relatively sparse. Only up to the groin it is involved.
So what are the various drugs used in? So people going to treatment one, what are the variants of pemphigus?
Pemphigus vulgaris, pemphigus vegetans. Again, it has two types, Newman and Halope type. And pemphigus foliaceus, endemic type of pemphigus foliaceus, Phobos elvaga. And pemphigus erythematosus, pemphigus herpetiformis, IgA pemphigus, which is again of two types, subcorneal pustular dermatosis type and intraepidermal neutrophilic type. And drug-induced pemphigus, neonatal pemphigus. These are pemphigus tuberculosis. Paraneoplastic pemphigus.
So what are the features of paraneoplastic pemphigus?
In paraneoplastic pemphigus, the skin is presents with polymorphous cutaneous lesions and also recalcitrant.
You should.
Okay, paraneoplastic pemphigus, it presents with, if there is recalcitrant oral stomatitis, we should suspect paraneoplastic pemphigus, and if there is any underlying malignancy, we can suspect paraneoplastic.
What are the different types of lesions you find, cutaneous lesions?
In paraneoplastic pemphigus, we can see pemphigus vulgaris-like lesions, bullous pemphigoid-like lesions, erythema multiforme-like lesions, lichen planus-like lesions.
So what are the criteria? What is the name given for the criteria?
Old criteria is Arhardt's criteria, the current criteria is the Camisas criteria. In this there are 3 major and 3 minor criteria. If all the 3 major are present or 2 major and 2 minor are present, it is considered positive.
What is the histopathology of, does it differ from routine pemphigus vulgaris?
Yes ma'am.
Yeah.
Other than like the suprabasal split and like toe of Thompson appearance, there is also basal keratinocyte necrosis, lichenoid interface dermatitis, macular degeneration is seen.
What is the DAF findings in paraneoplastic pemphigus?
DIF, it shows both intercellular deposits and also linear and granular basement membrane zone deposits.
Cause other deposits other than intercellular.
It is because of the antigens in paraneoplastic pemphigus. The antigens are BP antigen 1, desmoplakins, enmoplakin, periplakin, plectins, desmoglein.
What is the gold standard investigation for confirmation of
Indirect immunofluorescence with rat bladder epithelium over rat bladder epithelium is given. Immunoprecipitation, where the proteins are precipitated, major proteins of desmogleins, there, desmoplakins, and
among the all different type of variants, which is more difficult to treat?
paraneoplastic pemphigus and pemphigus vulgaris are.
What's the complications of pemphigus? If you don't treat, what happens?
There's risk of septicemia due to secondary bacterial infections and even risk of pulmonary embolism is there.
What about barrier function first? Before going to sepsis, barrier
Barrier function is lost, so there's electrolyte imbalance.
Coming to the treatment, because hardly I think 2-3 minutes are there. So, treatments, what are the different treatments available?
So first,
But this particular case, how do you treat?
so we would like to plan with systemic steroids as there is so much body involvement. So prednisolone around 1 to 1.5 milligrams per kg per day is planned, and we need to continue it till disease control is
What are the
achieved.
general measures before going to the steroids? General measures.
General measures, first we need to admit the patient maintain good oral hygiene, and IV fluids and IV antibiotics, and barrier
So many prostate lesions in throat. Then
emollients and dressings. We can also use Condis.
anything else?
We can use Condis compress, potassium permanganate compresses, and also gentian violet can be applied
These
topically.
banana leaf dressings in vesicular bullous disease.
We can autoclave the banana leaves and use it for dressing.
Coming to the specific treatment, you mentioned one is steroids.
The first line is systemic steroids, ma'am. Prednisolone 1 to 1.5 milligrams per kg per day. It is continued till the disease control is achieved. In case if the patient is not showing any improvement in 7 days, we can increase up to 50% of the dose. Increment can be done.
Is it 7 days? Only 1 week you are expected to take it. Within 1 week you get the response?
No, ma'am. This is up to 3 to 4 weeks. It takes time. Disease control is till there are no new lesions appear. We wait. We continue the same dose of steroids of 1 to 1.5 mg per kg. After that, then we have the starting of the consolidation.
What about immunosuppressants? You want to start simultaneously or you want to give gap of some?
We want to start simultaneously after adequate investigations are done. We would like to start simultaneously, like azathioprine or.
So is it conventional steroids are better? Have any chance of pulse therapy?
Pulse therapy is considered better because it is for short course, high dose steroids are given, and the side effects associated can be avoided with conventional
What are the different
therapy.
types of pulse? What we are calling?
We have the dexamethasone, cyclophosphamide pulse, dexamethasone,
Standard.
dexamethasone, cyclophosphamide pulse, and dexamethasone azathioprine pulse.
In this case, can you make any modification to the pulse therapy? In this case, or you will give the routine DCP pulse.
Routine DCP.
Patient diabetic.
Diabetic. Yeah, we would like to add 8 units of insulin to the infusion every day.
8 or 10? 10.
So what is the rituximab? Yes. What is the rituximab? Role of rituximab?
Rituximab is now considered as the FDA-approved first-line therapy for moderate to severe pemphigus. It is a chimeric monoclonal antibody against CD20.
So what is the
Dose main protocol, rheumatoid arthritis protocol is commonly followed. 1 gram is given, 2 doses are given 14 days apart. Then maintenance dose every 6 months.
What are the other drugs apart from steroids, immunosuppressants? rituximab, any other are there? Role of dapsone and others.
Dapsone, other immunosuppressants other than azathioprine is cyclophosphamide, mycophenolate, mofetil can be used. Other newer therapies like TNF-alpha antagonist, infliximab, etanercept can be tried. And even acetylcholine receptor agonists like pyridostigmine bromide and 4% pilocarpine gel is. And newer therapies like desmoglein 3 peptides, IV infusion.
Thank you. So because of shortage, because we exceeded the time, but still I want to tell something. Many things they have asked, because here we just confined to pemphigus. Okay. So what is chrysotherapy in pemphigus? Chrysotherapy. Anybody? Anyone? Bullous SLE, how do you differentiate from this classical pemphigus vulgaris? One of you can answer. Anybody?
All seniors can answer it. Anybody can stand up.
Other pages from
And
Osmania.
what is the role of vitamin D3? Means vitamin D3 status in pemphigus.
Only 2 have attended from Osmania.
Because so many things are there for long person discussion, but why we confine only to pemphigus? If you deviate from pemphigus, so all bullous disorders means we don't get time. Another thing, starting from the beginning, so many things are there. Examiner can ask anything, desmoglein compensation theory, why the mucosal lesions are predominant and other things, and the coexistence of pemphigus with herpes infections. That is, so many papers are there. When the pemphigus patient is not responding to standard therapy, sometimes they ask for HSV serology. Like that, some persons are there. And avascular necrosis in pemphigus group of disorders. Not only pemphigus, it is commonly seen in SLE, wherever you use steroids. So that is also is a commonly asked question. Avascular necrosis, vitamin D3 levels and their role, and conversion of steroids. How do you dexamethasone conversion to betamethasone? That formula you should know. And all the stages of pemphigus. And the recent one, something they said that chimeric autoantibody receptor T cells, engineered T cells and something, those are the things. And role of acetylcholine receptors. And some people they presented topical pilocarpine and pyridostigmine for the mucosal lesions. And how do you treat steroid-induced psychosis? Or how you differentiate from protein psychosis and steroid myopathy versus myositis, and this what is that? Azathioprine, thiopurine, methyl transferase. So many things are there. Just all these things also you should aware of these things. Thank you.
Some comments. Suppose if you ask the same question, this is not the examination problem. We are training for a mock examination. We are training the students. So if they cannot answer the questions, the answer and the question and answer key should be there for our presentation.
Yes, sir.
And
Yes.
from here on afterwards.
So, yes, sir. These are the things just commonly asked question and repeat for them.
If they cannot answer, you must provide.
Yes, sir. Yes, sir.
No, you can pass on this
Yes, sir.
the whole thing to these people afterwards.
Yes, sir. No, these are the
Time is
things
not limited,
we
no.
can ask.
I
Yeah.
am not
Okay.
asking you the time constraint. So time constraint is there, so you can pass on.
Why these points are there means sometimes you answer routine, all the routine questions, majority will ask. If you answer simple questions, they will go to the next stage. That is the only thing I want to convey. And examiner wants only basics only, always.
We seated there only, because 5 of you are there in the stage. All. Yeah, thank you, Dr. Kane and Dr. Amit.
Telling the answer is easy. Telling the work is important. Then only you can know.
Now
The answer you can remember better. That is my idea.
Now I call upon Dr. Snigdha and Dr. Shruti from Mallareddy Medical College. The spotter.
Introduce yourself.
Good morning everyone, I'm Dr. Snegha and this is my PG Dr. Shruti. We are from Malareddy Medical College.
So they
Snigdha and Shruti.
Dr. Snegha and Shruti. I'm Snegha. Shruti.
Project the slide.
Well-defined erythematous plaque is seen with superficial silvery white scaling, and the second image is showing irregular coarse pits over the nails. Of varying sizes, pure T size and pure large. The maximum size is around 5 to 6 centimeters.
What is your diagnosis?
Chronic plaque psoriasis.
Why do you consider it as a psoriasis?
The typical lesions are well-defined erythematous plaques because
Cause of pitting in psoriasis.
it is because the involvement of proximal matrix. So there's parakeratosis and the layers are removed off, leading to irregular pits.
Shruti, why are the scales white?
Because of the air trap between the layers of the skin.
So what is the type of?
Alopecia areata, lichen
How will you
planus,
differentiate alopecia areata?
there will be fine pitting, sir, in alopecia areata, and regular pitting. Here there will be coarse and irregular pitting.
Regular means any specific pattern or something?
It's scorched appearance in alopecia areata.
How many pits are significant?
Normally in psoriasis around 20 pits are seen. If arthritis is also present, more than 30 pits.
What are the other differential diagnosis if you see those plaques?
Related to the pits, only the plaques.
Tinea corporis can be considered as one of the differential diagnoses. Nummular type of eczema or discoid eczema. That is
Other papular stomachs.
other papular.
What are the other papular stomachs?
Pityriasis lichenoides chronica. Pallus.
Closer close to that lesion. Well-defined angular plaques, scaling.
Secondary syphilis can be
Good. Can
Pityriasis rubra pilaris,
any chance of lichen planus? Other
but lichen planus.
Any drug eruptions related?
Papillosquamous type of drug eruption.
Any possibility of peer?
Can be found, but the scaling is peripheral scales are seen usually, the folded type of scaling is seen.
So consider it is a chronic plaque psoriasis.
You consider lichen planus, leprosy. That's the reaction.
Subacute lupus.
Subacute lupus erythematosus. Psoriasiform type of SCLC.
What are the other main changes you see in psoriasis?
Pitting is the most commonest change, followed by onycholysis can be there, subungual hyperkeratosis can be there, splinter hemorrhages can be seen, Oflex phenomena can be then brownish yellow spots are seen because of the parakeratosis involving the nail bed. There can be a leukocyte of the nails and complete opacification of the nail plate can be seen. Yeah.
What is oil drop sign?
It's also known as Salzman patch. No? It is because of the hyperplasia and hyperkeratosis involving the nail bed. You see an yellowish orange spot.
You want to do any tests to confirm your diagnosis?
We can do a Gratach test, sir, wherein in psoriasis the scales are usually used and they're removed when we scrape the lesion with the edge of a slide. On scraping, we can see the basement membrane or the stratum mucosal, and the red mucosal layer is seen, which is known as Berkeley's membrane. Red pinpoint spots are seen. On further scraping, it leads to bleeding. So this is known as Auspitz sign. So these are the questions.
Shruti, what is the spelling of Berkeley's membrane?
Belkley. Bulkley.
What is the other phenomenon you find in psoriasis? So we are considering this plaque psoriasis. So coming to the plaque psoriasis discussion, what are the phenomena you see in psoriasis?
Cognos phenomenon. It's an isomorphic phenomenon. It's induced by cutaneous trauma. You will see similar lesions in other areas. Is cutaneous.
What is pseudocarpus?
And molluscum contagiosum, the lesions can occur at the site of trauma.
That is due to?
Inoculation.
Ortho.
Inoculation at the site.
You have told secondary syphilis also, no?
Yeah.
How do you clinically rule out secondary syphilis?
Secondary syphilis, clinically, sir, usually there will be deep dermal tenderness will be there.
How will you elicit that?
With the blunt end of a pin, we
Or a matchstick? What do you do?
on the lesion, we just touch it the lesion. So in case of secondary syphilis, there will be tenderness.
If you touch, it goes to deep dermis. Then what?
Prick the lesion.
What is
You
the
don't
sign?
prick.
Bushki on and loose.
What about palm cells?
There will be
Sir, he asked about this.
there will be white sign, hyperpigmented markings seen on the palms and soles.
What is the
Right
cause
side,
of the
yes.
bushkila? Why is there tenderness?
Mask. This is the neck look.
You can try. What is EAO?
Otherwise, we can ask cardiac and they keep the program. What is reverse cavernous?
It's also called Dribnan's phenomenon. Normally, psoriasis is reversed, like in pressure areas like wrist and pressure clothing.
Because of vasoconstriction at the pressure sites, the lesions of psoriasis disappear at the sites of the pressure.
What is Warnock's ring?
Warnock's ring, usually post-treatment or if you psoriatic plaques on clearing, there will be a hyperpigmented patch around the lesion. This is because of the deficiency of prostaglandin E2 at the site. In treated cases, usually it's corticosteroids.
How do you want to treat that case?
This case was based on the extent of involvement will decide, sir. It seems to be more than 10% of the body surface area.
In this picture, you are not able to make, but based on those pits, anything.
You can go for oral therapy, sir. Systemic therapy.
What is the importance of pits in psoriasis? And
Associated arthritis.
Psoriatic arthritis.
when do you think arthritis will count some number?
More than 30 pits with this signature. Usually 20 pits in this psoriasis is the most common type, followed by guttate psoriasis. Elephantine psoriasis, which is of two types, rheumatoid and osteitis type. Pustular psoriasis, which is again of localized and generalized type. Localized, it's palmoplantar pustulosis and acrodermatitis continuopelopathy. Generalized, the most severe form is Wardenburg disease, followed by exanthematic type, annular type, impetigo herpetic
What are the
form.
different topical treatments for psoriasis? Different topical, various topical agents.
Emollients are a must. Topical steroids. intralesional steroids for nail psoriasis specifically, and calcipotriol, vitamin D analog, and vitamin A analogs like tazarotene can be given. Diazolam and Coltar can be given, and this Gokerman's regimen is application of crude coal tar for 24 hours and removal of the excess of the coal tar with mineral oil followed by UVB radiation.
So types of phototherapy, psoriasis, which one you want to take?
If it's normally UVB is preferable. If it's guttate psoriasis, narrowband UVB must be given.
What is the cause of bleeding? You told hospitals and bleed.
Capillary damage.
And
There's parakeratosis, acanthosis, presence of Munro's microabscesses, there's neutrophil extrusion, and in pustular type you can see pustules of Kojoch.
Characteristic parakeratosis, mom, followed by acanthosis, there will be Munro's microabscess, hypogranulosis, spongiform pustules of Kojoch, and there will be camel foot reticulous or club-shaped dermal papillae, and vascular, increased capillary vascularity in the papillary dermis as well as papillary dermal edema.
One person. What is the role of systemic steroids in management of psoriasis?
They're not the first line, ma'am. Usually in case of pustular psoriasis in pregnancy or any immediate intervention is required, then we go for psoriasis, systemic steroids.
Yeah. Next.
Good.
Thank you, Dr. Snigdha and Dr. Shruti. Now I call upon Dr. Sada Diksha and Dr. Rojita from Kamineni Medical College.
Good morning, myself Sada Diksha and my co-PG Rojita from Kamineni Institute of Medical Sciences, Nakirpalli. On examination, white to yellow color discoloration of nails noted with subungual hypokeratosis and leukocythemia also. What's your onychomycosis, proximal and also distal lateral sites, distal and lateral subungual onychomycosis. Proximal also involved in distal and lateral. What is onychomycosis? It is brain infection with dermatophyte and non-dermatophyte. How do you differentiate onychomycosis from tinea ambra?
Please take out the mask. It's not here at all. Keep your close to your
Onychomycosis is synonymous tinea ambra.
Difference between tinea ambra and onychomycosis. It's not synonymous.
Already you told me, you revised that one. Already you told onychomycosis is dermatophytes as well as non-dermatophytes.
No. Only dermatophytes. Tinea rubrum, tinea mentagrophytes are intradigital and epidermal sclerosis.
What are the non-dermatophytes which cause onychomycosis?
Aspergillus species, Cytidium zimidatum and Hylineum, and also Scopulo Candida albicans and Candida
The question we ask now, how do you differentiate tinea ambra from non-dermatophytes? How you tell clinically? Apart from nail plate, anything else? What are the other findings?
Periangual inflammation is seen with non-dermatophytal, and in candidial paranoia is also seen.
Any color disturbance, color change of color, which color, and nail plate changes.
In onychomycosis, white to yellow color nail changes is seen. And with non-dermatophytal, surrounding inflammation is seen along with nail changes. And mostly distolateral sites are most commonly involved.
What are the types of onychomycosis?
Distolateral subungual onychomycosis, proximal subungual onychomycosis, endemic superficial white onychomycosis, and total nail dystrophy.
What is the 20-nail dystrophy?
20-nail dystrophy, where all the nails are involved. Rough nails are usually seen, and
Lichen planus, what else?
Cause.
But in age need not be involved, and less number also causes
Causes of
Epidermal spacious.
audience also can answer.
Causes of 20-nail dystrophy.
Lichen planus, atopic dermatitis, alopecia areata.
Very good. From which college?
Your name?
Hitanshi Rao.
How do you want to confirm your diagnosis?
KOH mount, onychoscopy, culture,
What is
and
the percentage of specifically nail
What is
plate?
KO?
potassium hydroxide. 10 to 40%. For fibrous we can use 10%, and for the nail plate we can go for around 30 to 40%. And on direct microscopy we see hyaline septate hypha with also.
So what is the advantage? With 10%, how much time you wait? 40%, how much time? There are certain difference.
10% 10 to 20 10% 10 to 20 minutes, and for 40%
But nail.
nail 2 to 4 hours.
40%.
40% 20 minutes.
Nail, not skin.
So the examination of the keratin.
For the nails, how much time?
For skin 10 minutes, and for nail 2 to 4 hours.
So if you use 40%, it's half an hour answer enough. Okay. That is it. Okay, one is KOH now. Anything else? What are the findings of onychoscopy?
We can see onycholysis, spiked patterns, and also longitudinal ridges can be seen, and also yellow color to white color discoloration is seen.
What about culture? Which culture medium is required for confirmation of diagnosis?
Saffron dextrose agar.
Components of FDA.
It includes 40 grams of dextrose, 10% of peptone and agar.
That you diagnose it as vancomycin, Setinia anva. What is the treatment? Is it topical or systemic? How do you treat this particular case? So consider it as a tinea anva.
Based upon the number of lesions,
Yes, see this case. Your case only, na? How do you treat this tinea anva? How do you treat?
So the total number of nails involved are 5. Five nails are involved greater than 50%. So the oral antifungals will be the choice of treatment. So we can give pulse therapy for terbinafine. Terbinafine is the preferred choice of treatment. So it can be given in a pulse of terbinafine 250 mg once a day for 1 week.
Pulse therapy. You are telling
Pulse
pulse
also
therapy.
can be given, and also it can be given as daily session, continuous
So
session.
in conventional, how much you give? And in pulse, how much you give?
250 mg daily once is for continuous regimen. 250 mg BD is for pulse regimen.
Is it same for fingernails and toenails?
It's same, ma'am. Duration changes.
What is that? How many pulses you give for fingernails?
So, itraconazole, 2 to 3 pulses are given for fingernails, and 4 to 5 pulses are given for toenails. 3 to 4 pulses. In a month, we will treat for 1 week, ma'am. So it will take around 4 to 5 months. So 4 weeks of treatment.
So what is the topical agents you know? For that, what is the topical?
Cyclopyroxalumin, 8%
What is the
can be.
special preparation done? Is it ointment, cream or anything?
Nail lacquer.
What is the percentage?
Cyclopyroxalumin is 8% nail lacquer, and emerolfine is 5%. It consists of 25% of the active component. So we emerolfine is applied once a weekly daily over the affected nail and left off. And cyclopyroxalumin is continued daily for all through the week. And
what are the newer topical antifungals for nails? Nail lacquer?
Water soluble cyclopyrox hydro compound can use.
Apart from cyclopyroxalumin, any newer antifungals you know? Pardon? Efinaconazole, very good. One more? Very good. Who is name? I think you can tell your name.
Tell your name.
Efinaconazole is tablet rollers.
Medicine.
Medicine. And any surgical procedures apart from antifungals? Any roll up lasers?
Lasers can also be done, ma'am. Initially, we can do if the partial nail involvement is there, we can do partial debridement, and if the total nail involvement is there, we can take off the nail by surgical or chemical methods.
Thank you.
Audience, what is the advantage of lacquer? You can just apply ointment, no? Or you can use lacquer to nails. Once it evaporates, the function starts, right? It penetrates deeper. No?
Itraconazole pulse can be given, ma'am. Itraconazole pulse in the 400 mg per day for a week, for a month. It should be continued for 2 to 3 pulses. Terbinafine pulse and fluconazole pulse can be given. Fluconazole pulse in 300 mg per week. A single dose can be given. It should be continued based upon the treatment results. And this can be combined with topical medications or surgical procedures as required. Or sequential therapies can be.
Other pulse therapies, like azithromycin pulse, other pulses.
For acne, erythromycin 500 mg thrice weekly for 3 weeks can be given. Versicolor starter, fluconazole 150 mg weekly once can be repeated up to 6 months.
Thank you.
Thank you.
Thank you, Dr. Sada and Dr. Rajita. Now I call upon Dr. Rahul, Dr. Monica and Dr. Susmita from Bhaskara Medical College.
Sir, only two.
Good morning everyone, I am Dr. Sushmita.
Describe the lesion. Sir, blades.
There are multiple ill-defined to well-defined depigmented patches over extremities, over dorsum of bilateral hands and bilateral feet.
What's your name?
Monica.
Yours, sir?
Sushmita.
What is your diagnosis?
Vitiligo.
Just vitiligo.
Acral.
What are the other types of vitiligo? Classify vitiligo, general classification.
Localized vitiligo, generalized vitiligo. Localized is further classified into focal, segmental, and mucosal. Generalized is classified into vitiligo vulgaris and vitiligo universalis. What is segmental vitiligo? It follows the dermatomal line.
Meaning of
Loss of absence of melanocytes.
Vitiligo is a Latin term. Initially, it was thought to be a
difference is there between the two. Both are same or different? Here it is looking like larval skin with depigmentation. There it's looking like little bit erythema.
erythematous depigmentation along with scaling are seen.
So what does that mean? Here it is absolutely normal skin. There erythema and scaling is there. What does it indicate?
Early vitiligo signs.
Patient is already made a treatment. So sun damage is there, scaling, that phototoxicity is there.
Near the differential diagnosis for that.
Post-inflammatory hypopigmentation.
Is it hypo?
Infectious conditions includes Hansen's disease.
In this case, how do you think, other than vitiligo?
Any connective tissue disorder, because scaling is there, erythema is there.
Erythematous, scaly, depigmented plaques of the nose.
Systemic lupus erythematosus. Discoid lupus.
In spotters, you cannot make whether it's systemic or not. You can think of DLE, discoid lupus.
What is unstable vitiligo and stable vitiligo? When will you say?
Progression. Patients are localized only based on this appearance. So how do you treat this particular case? For this trichrome vitiligo, you have trichrome vitiligo. What is trichrome vitiligo?
Hypopigmented areas in between normal skin and the depigmented skin.
Trichrome. Tri means three.
Hypopigmentation, depigmentation, and a normal pigmentation.
Quadrichrome vitiligo.
You tell in Mike what you want to tell.
Quadrichrome.
Includes hyperpigmentation also.
Perifollicular hyperpigmentation.
Dermoscopy, does it have any role diagnosis of what are the dermoscopic findings in vitiligo?
Use mic, they should hear. Audience should hear your questions also.
What is leukoderma? What is vitiligo?
Leukoderma is? It's a depigmentation of skin?
Yes.
Caused by
Chemicals.
light. Suppose you put
Benzyl.
what is the chemical cause for that? Why does depigmentation occur over the degree area? Anybody in the audience? Very good.
One at a time.
Everybody. Use mic.
Leukotrichia.
Enumerate, there are almost 7%.
Site of involvement. Starting from the site, you can tell.
Site of involvement, mucosal involvement, and leukotrichia, unstable vitiligo, and segmental vitiligo. Poor prognosis. Equal vitiligo has a poor prognosis.
Any one of your other poor prognostic factors of vitiligo? One of you can get up and tell.
Early onset of there, family history is there, then acral vitiligo, bony prominences, then
Associated condition.
associated autoimmune disease like thyroid is there. Segmental also mucosal involvement. Segmental good problem.
Medical therapies.
Topical therapies. Corticosteroids, calcium urine inhibitors, and calcium. Vitiligo area severity index.
How do you treat this management?
Phototherapy.
Is also any types.
Nanoband UVB or
Broadband.
broadband.
Uva therapy here. Uva therapy. So what are the different types of psoriasis?
8-methoxycerylin, 5-methoxy, and trimethoxycerylin.
What is Uva sun? Psoriasis. UVA. Sunlight is the source. You told narrowband. Anything? Recent ones. If it is localized lesions, you want to go for narrowband. Apart from narrowband, what is there? More focused treatment. Now, what is the targeted phototherapy? That is known as. Any names are given for targeted phototherapy? Audience, what is the targeted phototherapy? Excimer laser. Yes. What is the wavelength of excimer?
The wavelength of narrowband.
What are the surgical modalities you know in the vitiligo? Just say What are the systemic drugs used in vitiligo? Recently, so many immunosuppressants that are using. There's other than methotrexate, cyclosporine, oral menopause, good.
Okay. So, so Sudharani and Vijay Bhaskar should be there. Sudharani and Vijay Bhaskar, we will put it. So, we have selected these members. First, long case presenters, both. Please come. Not, this is not time. Veena Manzu. I'm parent, not Kaptanga. Sorry. I cannot spell that. Then next is Ramya. Please come. And next is Snigdha.
And we have selected from the audience universally. So these people will ask, decider these two people will decide.
One round of questioning.
Whosoever not answers that question disqualified. One question. Till they answer this thing, these rounds will go on. Till we decide two people.
Difficult question. So what is Venereologists type vitiligo? Venereologists type vitiligo.
One should answer. If she cannot answer, no. You answer the question. If it cannot answer, you pass on.
What is rainbow?
No. Let them answer the question. Come on. All of them. No answers from anybody.
What is rainbow phenomenon? Audience also can try.
No, audience.
It's negative coordinates phenomena. At the sites of trauma, psoriatic lesions disappear at the site.
They disappear.
So you just start there.
What is butterfly sign? Butterfly sign. Not necessary.
Dermatologists, spelling of the back in the butterfly area, spelling is.
So you stand there. Next.
What is the side effect of cyclophosphamide?
First, coming to the
Most common and most dangerous non-metal.
hemorrhagic system.
So how do you treat that?
We give mesnas
What is the full form of mesna?
to mercaptoethane sodium sulfonate.
Again, come again.
Mercaptoethane sodium sulfonate.
It's an oil. Sodium.
Sulfonate.
Very good.
She also goes to that. Good time.
How do you treat neurosyphilis?
These three are supposed to. So general persons have only this topic.
Only anything. Decide.
How do you treat neurosyphilis?
Yeah. Okay.
Injection benzoyl penicillin.
No.
Benzoyl penicillin.
Can you try the dose also?
So
You can.
you can come and I can they answer one. They will tell first and second.
Sir, other incomplete, sir. She is also incomplete.
Still, part is correct. Part is correct.
So telling benzoyl penicillin is blunder.
Blunder.
You should not telling.
Yeah.
She told me.
Yes.
Why not benzoyl penicillin? She was telling benzoyl penicillin, both are penicillin.
It doesn't penetrate the blood-brain barrier.
Cross of elimination.
These two are linked up.
First and second it is said.
But she didn't get accomplished in this class. There only, yeah, you answer.
What is Bayet sign?
Please take the mask.
Hyperpigmented macular lesions of the palms and soles, they have peripherally arranged scales. That is
Where else do you see?
Sir, in that question also she didn't answer. Then how do you eliminate this?
No, that leave it to the teacher.
Okay. Because next person we went to challenge. That's okay, sir. Suddenly we went to second question.
What is garlic sign?
Small size.
What is garlic syndrome? Very good. What are the components of garlic syndrome? Very good. Odontogenesis.
Seizures.
Jaw.
Sir. Over. Great action. Thank you. What's your name?
Good morning all. I'm here to announce about PQT call which is going to be conducted in Kamineni, Nagarpalli, and it is very overwhelming to see you all here, PGs. So, and mainly about registrations. Registrations are open and it's only 500 for PGs and 800 for others. So abstract submission here. The email ID is given so that you can submit. Like its last date is 16/8. Yeah, abstracts are for papers and posters. I request all to attend and present their papers. We also have a transport facility, bus facility, so to avoid that you have to inform us prior only. And shortly we will announce the brochure to you and then come to your departments. And we also give a phone number so that you can avail transport. Yeah, you can make a payment. We have a counter and we also give a receipt. Okay? Registrations are open also. Yeah, thank you.
For the latest guidelines of NMC, you have to present a paper in the conference. So you can use this opportunity to present a paper. This is a conference. Okay.
I thank, from TSIADVL, I thank Dr. Narasimha Rao Neta sir, Dr. Sudharani ma'am, Dr. Vaishnavi, Dr. Vijay Bhaskar, and Dr. Shivram Reddy. I call upon President TSIADVL, Dr. N. Ramesh sir, and Dr. Janardhan to hand over mementos to him. Sir.
Lights on. Lights.
Light closed. Light.
उधर के लाइट्स का नहीं राइट लाइट्स ओपन करो ना
Dr. Narasimha Rao Neta sir, Dr. Sudharani madam.
Excuse me. Excuse me.
Dr. ASP Vaishnavi.
Sir. Pull it back. Pull it back. Come back.
Dr. Vijay Bhaskar. Dr. Vijay Bhaskar.
Excuse me, sir.
Dr. Shivaram Reddy, sir.
Madam.
Without much wasting time, we go for the next session, session 2. I call upon Dr. Yashashri and Samiha from Usmania Medical College, and to chair this session, Dr. Indira Madam and Dr. Sudhavani Madam. Dr. Indira Madam. And also Dr. Raja Narasimha Rao sir, Dr. G.K. Prasad sir, and Dr. D.V.S. Pratap sir, and Dr. Adna Samar. For this.
Good morning everyone. Myself Yashashri Dungarwal and my G. Samiha from Osmania Medical College, Hyderabad. Today we are going to present a case on connective tissue disorder. The patient's name is Norma Dasa. It's 21 years of age. He is hailing from Golikoda, Hyderabad, and is a welder by occupation. Next slide, please.
Next slide.
21-year-old male, welder by occupation, hailing from Hyderabad, came with chief complaints of tightening of the skin of fingers since 1 year, white-colored lesions over both his forearms since 6 months, and complaints of difficulty in swallowing since 2 months. Patient was apparently alright 1 year back when he noticed tightening of the skin of his fingertips of both his hands, which gradually progressed to the elbows in 6 months. He had a history of preceding swelling of fingers and gave history of bluish discoloration of fingers on exposure to cold, with each episode lasting for 2 to 5 minutes. He had 2 to 3 episodes per week. The patient later developed difficulty in opening his mouth. He has no history of difficulty in eating or swallowing liquid or solid food. There is no history of blackish discoloration, distal ulceration or loss of fingers. No history of frothy urine, no history of joint pain, no history of morning stiffness, cough, shortness of breath, chest pain, no history of palpitation, bloating, abdominal pain, no history of oliguria, edema of feet and swelling around the eyes. He gives no history of headache and visual disturbances. No history of dry mouth, dry eyes, no history of tingling and numbness of hands and feet. Patient gives no history of photosensitivity, oral ulcers, any rash on the face, no history of seizures, difficulty in combing hair or buttoning shirts, no history of difficulty in speech, no history of swelling of body, no history of darkening around neck, back and chest. Drug history the patient has taken.
What is the relevance of body urine?
They have renal
renal involvement in connective tissue disorders. There will be proteinuria, which we can see as proteinuria. The patient has taken some unknown medication from a private doctor with no improvement of the lesions. He has no past history. He is not a known case of diabetes mellitus, TB.
Private friends, they are not
He gives, there was no family history of similar complaints. His personal history, bowel and bladder habits were normal, his appetite was normal, sleep was normal, and he has no addictions.
Coming to examination, general.
no what is important to smoking or alcohol in this case?
Because the patient has Raynaud's phenomenon, smoking can aggravate Raynaud's phenomenon.
See, when you are presenting a long case, if you come, when you come to this stage, what are the main chief complaints, what are the chief complaints in this patient?
Tightening of the skin,
Yes.
and bluish discoloration of his fingers, and white colored lesions over his forearms.
Next, you said something else.
Difficulty in.
Yeah, you should elaborate all these 4 complaints first. Then you take out the positive history, and then take out the negative history. And at the end of the history, you should make a small synthesis. So and so patient gave you these complaints. So these are the positive features and these are the negative features. And by the time you complete the history itself, you should come to a certain conclusion which system you are feeling and what are the things you should go for. Then you should make your general examination and specific systemic examination. That is the moment. So you said there is difficulty in walking.
Yes.
So what was did you elaborate on that?
Not difficulty in walking, sir. Difficulty from rising from a sitting position.
Yeah,
He was giving.
you can elaborate on that. What type of difficulty he had?
Proximal muscle weakness.
Anything else was there?
No, sir.
Is he tripping while walking?
No, sir. He has no difficulty in walking. He has no difficulty in raising his hand or combing his hair.
So he is able to take the
Yes, sir.
particles from.
Yes, he has no difficulty.
That means he doesn't have any problem.
Proximal muscle weakness.
No problem.
No, sir.
Only getting up from
The sitting position was only from.
the lower limbs it is involved.
Yes, sir.
It has not involved the upper limbs.
Examination, general examination. Patient is conscious, cooperative and well oriented to time, place and person. Average to well built and nourished. Pulse was 82 per minute. Blood pressure.
Don't say average, either well built or averagely built. Cannot be averagely well built.
Patient was well built and nourished. Pulse was 82 per minute. Blood pressure was 110 by 70 mm per mg. Respiratory rate was 16 per minute. Peripheral pulsations were present. Pallor, icterus, cyanosis and edema were absent, and there was no lymphadenopathy.
We need not read all that unless there is some to show something.
Okay.
Let's see the ventilator now.
General examination, it was normal. Coming to cutaneous examination.
Next slide.
Tight, taut, shiny skin was present on the zygomatic area of face. There was inability to retract the lower eyelid. There was pitch wick-like nose present. There was difficulty in mouth opening of grade 1. No telangiectasias were seen. Ingram signs. Ingram sign, that is inability to retract the lower eyelid. Then tautness of skin of hands extending till elbows was present. Bilateral flexion deformities of hands present. Loss of contour of pulp of fingers present, that is mesotannic sign. Then stellate scars and punctate scars were present without ulceration. Salt and pepper pigmentation was present over the bilateral forearms. Multiple hypopigmented lesions were present over the retroauricular area and the dorsum of both hands. So this is the image. We can see the shiny appearance of the face with the pinched big nose appearance. And we can see the hypopigmented patch is present over the second image over the fingers and retroauricular area. And we can see the hands sandpaper pigmentation, like salt and pepper pigmentation and tightness of the skin. In this classically we can see on both the dorsum of the hands salt and pepper pigmentation, that is multiple hypo and depigmented areas. And on the last image, you can see that the contour of the pulp of the finger it is lost, and it has become rounded. That is rounded fat sign or mesotiny sign. Palms and soles were normal. Oral mucosa was normal. On nails, we saw periangle telangiectasias and capillary dilatation and dropouts were present. Scalp was normal. So we have done capillary. In this, we can see nail capillaroscopy. In the first image, you can see normally we have capillaries which are hairpin structure, usually of 20 micron. But when they become dilated, like more than 50 micron, it's called giant or mega capillary. So in this, you can see the capillaries.
Point taken, point out. And then you have seen naked eye examination, or you have really used this thing.
So dermoscopy we have used. Dermoscopy.
Previously we used to do something else.
Ophthalmoscope also can be used.
Which do you, dermoscopy?
Yes, sir, dermoscopy.
Fine.
So here you can see this hairpin-like structures will be there, but here they are dilated. And in between, we can see here no vessels we can see. So these are capillary dropouts. Here also we can see this dilated hairpin-like capillaries with in between a vascular area that are capillary dropouts. Coming to systemic examination was normal and peripheral sensations were also intact.
Okay. Separately, what is the provisional diagnosis?
So my provisional diagnosis is limited type of systemic sclerosis in indurated states.
Indurated?
Stage.
Okay, how do you say it is limited systemic sclerosis?
So because the thickness which is there, should first of all it should cause metacarpophalangeal joint to call it the systemic sclerosis, and it is limited to till the elbows only, and face is involved. It has not involved up to trunk involvement. So it is limited. If it involves trunk, it will be.
And one question is, suppose you say it is cutaneous systemic sclerosis or systemic sclerosis. Only cutaneous system is involved or other systems are also involved?
No, it's only cutaneous.
But you said cutaneous model.
Yes, sir. Like limited systemic sclerosis also.
Opening the mouth. Yes, because swallowing.
But you said swallowing, no? I remember.
Difficulty in opening the mouth. Not difficulty.
Opening the mouth, yes. Not difficulty in swallowing. Okay. Sir?
First, regarding the diagnosis of systemic sclerosis, is the patient fulfilling the criteria for systemic sclerosis? Yes. ACR criteria and ULR criteria. What are ACR criteria?
There is ACR ULR criteria, like recent criteria by 2013. One sufficient criteria is there, that is skin thickness should cross the metacarpophalangeal distal to, that is 0.9. So if that one single criteria, it is sufficient to call it as systemic sclerosis. Then there are other criteria, like in hands there are two criteria, coffee fingers or sclerodactyly. One of the which is present will take coffee finger 2 points and sclerodactyly 4 points. Then we'll see digital ulcers or pitted scars are present. If digital ulcers 0.3 and pitted scar 3 points. Then we'll see telangiectasias, Raynaud phenomenon, pulmonary arterial hypertension or interstitial lung disease, and then we'll see the antibodies. So 3 antibodies, anti-centromer antibodies, anti-topoisomerase antibodies, and RNA polymerase antibodies.
Coming back to these things, you said this Raynaud phenomenon? Yes, present. So only is limited systemic sclerosis still. That what is the relevance of this Raynaud phenomenon?
So like you can differentiate. If preceding its long history is there, so it will be limited. They have preceding long history. They will present first as Raynaud phenomenon. While diffuse, they can directly present to us with Raynaud phenomenon, or can later also.
No, can you dilate on that? Rust syndrome you have excluded?
Yes.
How did you exclude? Because Raynaud's phenomenon is there.
Raynaud's is there, but no calcinosis is there, sir. No esophageal dysmotility is there, and no telangiectasias are also not there, sir.
Then
we cannot exclude, sir. Patient didn't give any history, but we have to examine. Yes, sir. We cannot rule out.
and then next in the history he said he is not able to get up. He said what? that is not elaborated because limited systemic sclerosis is limited cutaneous sclerosis is going to say that he cannot unless you have some mixed activities or something.
Yes, sir. We have to evaluate, sir. Like only legacy complaint, hands and all, that proximal muscle weakness he didn't give. But we have to evaluate investigate on antibodies only.
On examination, I will elaborate it. He is getting up. What's the reason? You are not mentioned about it. Only in the complaint you are mentioned.
Yes.
But whether you have incident, he is actually able to get up or not able to get up, that you are not able to get up.
Musculoskeletal examination should be.
Musculoskeletal examination, you are not done. One more thing is, you said body is there.
No history of protein.
No history of
Once you say he is not able to get up in complaint, you have to evaluate the musculoskeletal. That is not given at all.
Then the other thing is the patient on treatment?
No, sir.
Because not able to get up, the lower limbs are cutted by this organ. That is the steroid induced myopathy or something you have to think of. Whether he stays clear, whether he is not taking treatment with steroids.
No, sir. He told he was taking some medications from outside, sir, but he didn't have it for all drugs.
This is the first step they have come to a conclusion or made the diagnosis of limited systemic sclerosis.
Yes, sir. Yes, sir. Outside he was just being treated by some Ayurvedic medications he told sir he was taking, but he didn't have any sleep what he was taking. So then he came to us, then we evaluated him and then we did all investigations.
Investigation.
Yes.
Did you take the biopsy?
No, sir.
Only dermoscopy.
So, routine blood investigation, antibodies we have done, sir. Antibodies we did, sir. Like the centromer antibodies, it came positive, sir.
So antibody, total antibody are only.
No, sir. All tag and titer, in the profile and titer, both we did, sir. Complete investigation. Whole antibodies, sir.
Right. Whole antibodies.
Whole antibodies, all antibodies. And the profile. And the profile.
No further presentation
No, they are completed. Thank you, sir.
Please go back by one slide.
Go back by one slide.
Back by one slide. Differences between limited cutaneous and systemic cutaneous. Diffuse cutaneous, sir.
In limited, skin involvement will be till like elbow or knee joint, ma'am, along with face involvement. In diffuse, a trunk will also get involved. In limited, prior a long history of Raynaud's phenomenon will be there. Here, like acute history will be there. Then visceral involvement, it will be more in diffuse sclerosis. And pulmonary arterial hypertension, it is more in localized, but renal crisis and malignancy chances are more in diffuse. Then again antibodies, anticentromere antibodies in localized, and topoisomerase and RNA polymerase 3 in the diffuse.
Prognosis which is good.
Localized has good prognosis, limited has better prognosis.
If it is associated with PAH, limited associated with PAH, then the prognosis is
Bad, like higher chances of mortality is there.
limited. Also you see systemic involvement, but the severity is less.
You were describing the hands, you said something here.
Hands.
When you describe the hand in this slide, what do you tell about the hand?
So like the skin was like it's appearing little tight and you can see some hypopigmented lesions there.
You are saying skin over the hand is tight, and then you are saying palms are normal.
Forearm.
You said forearm.
Forearm.
This slide you said skin over the hand is tight.
Forearm.
When you think palms are normal, you cannot say.
So skin over the forearms tight or not? Then only pigmented changes or
No, sir. Pigmentary changes also and skin is tight also, sir, till elbow, forearm.
forearm. Then your limited systemic sclerosis, whether we can take it or not. And then acrofacial is also down side is possible.
So like some place like till elbow and till knee joints, sir, along with like facial involvement will be limited. But if it extends above elbow and knee and involve trunk also, then we'll call it as diffuse.
But
what is intermediate systemic sclerosis?
Now like sir, new IDVS table they have given like 3 types: limited, intermediate, and diffuse. So they have told like limited till metacarpophalangeal joint and limited and face. Then intermediate till elbow and knee along with face and neck involvement without trunk involvement, and diffuse if along with this even trunk is involved, then it will be called diffuse.
So one more entity is added, that is intermediate systemic sclerosis. That explains this case can be, you can call it as intermediate systemic sclerosis.
So you want to revise your diagnosis? Revise diagnosis?
No, it is according to books. IADVL mentions that root and other books do not mention about. It classifies only into 2 types.
Limited, only recent IDVL 3 types they have given. Limited information.
No. ADVL is Indian book. Rook is
And
standard
this case
book.
also very well fits into that intermediate type where the face is involved till elbows involvement is there and without any system. I mean clinical changes.
Or you can say I'm Indian, I follow Indian book only. Okay.
The squatting posture,
No, that is, they are not very clear. I have told. I have asked that question. Whether it is steroid-induced myopathy or dermatomyositis. I meant to say.
Tenderness, proximal muscle tenderness.
Like no proximal muscle tenderness. Only he was telling that he was having difficulty in squatting. So it might be like associated because proximal also we asked for hands and all. He was not telling. No tenderness also it was there. So like it can be normal myositis.
Can it be a bone origin like joint origin?
No, the thing is you have already
21 years.
No, you have then antibody, total antibody is there. So in that no, that any antibody that would be exclude dermatomyositis?
Yes sir, like TIF-MI2 antibodies and PMSCL also sir, polymyositis.
Did you do any muscle enzyme assay?
Yes, sir, everything normal, sir. Reactive kinase and LDS were not elevated.
Not no muscle biopsy. Not that.
See, in this particular case, as Madam said, it is falling in the intermediate spectrum. So, to rule out the systemic involvement, what are the bedside things you do? Head to toe. Then you go for profiles. Then you go for investigations. Then you come to a complete diagnosis. First is your provisional diagnosis. You put the slide of time. Probably you would have gone further.
Initially, we should assess the skin thickening. We should assess based on modified root and skin score. We should assess the skin thickening. We should do name-fold capillaroscopy. And for ruling out any lung involvement.
But then this is the dermatologic examination. I want to say, how do you rule out systemic involvement one by one?
Chest examination.
What are the systems you want to check?
Pulmonary involvement. We can check this for chest expansion. There should be a normal expansion of 2 to 5 centimeter. And then we can do a 6-minute walk test.
We'll examine chest examination. Normally it is 6 centimeters, sir. Then we'll examine at the end of maximum inspiration. Here it should be 6. Other, like if it is like less than 5 centimeter, 3 centimeter, it is significant, sir. Then we should see bilateral air entry, sir. If any lung involvement, like interstitial fibrosis article, so bilateral equal entry will not be there.
What do you say clinically? Bilateral basilar fibrosis.
Basilar. So creps will be there. Bilateral.
Vessels you will get well-proved type of preparations. Madam has pointed on important thing. So if there is a pulmonary hypertension, what happens? Let's hear loudly. These 3 things minimum you should see. See for the chest expansion. Look for the gravitations and look for peak. These 3 things. Gastrointestinal system. Bedside what you do? To be a small swallow test.
Swallow.
No. It's all solid.
Just we'll ask them.
Or ask him specifically.
Anything will give
Do we have
liquid or solid?
Yes, liquids. Are you not able to eat chapatis? Are you not able to drink liquids?
Vowel sounds. Vowel sounds we can use it.
Abdominal distance of the patient might have
Attendance, what do you see?
Rubs with tendon friction rubs will be there. We'll ask them to move the joints
and see.
and we'll give the hands. So if cramps are there, we can feel the cramps. Again, serious also we need to examine, sir, like murmurs and all. Musculoskeletal, we should ask them to do the normal activity, like for muscle weakness, we can ask them to go like pull your hands fully up, squat test, and then comb head and rest test, combing, buttoning.
Yes. And do the gait examination, arm examination, all those things. But keeping any other list is that. That's it.
That's a ketone model.
Simple test, let's say. But we do just check for all. Hip test.
Test.
So this is preliminary examination. Then you can go for further investigations. So what are all the antibodies and what are all the correlates? Systemic correlates.
Lung function test.
Diffusion capacity of carbon monoxide will be increased, and later post-vital capacity will also be decreased. When we look the ratio FeV1 to FVC, it will be normal in restricted type. Right axis deviation we see normally in ECG.
No, it is hair splitting examination like limited system or intermediate. Does it matter for the management or prognosis or anything?
Yes, limited one has better prognosis. There will be less organ involvement as compared to the type 2 intermediate. Intermediate has more organ involvement but lesser than diffuse.
That's what I have asked. So next thing is how do you proceed with limited system and how do you proceed with intermediate? Is there any difference between management, not prognosis?
The skin involvement is limited, so we can just treat the patient with topical steroids and
Only doctors said there are two things involved in systemic sclerosis. One is stenosis, the second is vascular enzyme. So both the things you have to tackle. So how do you tackle both?
With limited involvement, we can ask the patient to apply emollients, topical steroids, topical calcineurin inhibitors. If there is itching, we can give symptomatic treatment. Pova therapy can also be tried. And for vascular involvement, this Raynaud's phenomenon, first we should educate the patient about avoiding trigger factors like cold exposure, caffeine, smoking, and deworming techniques like hot water soaks, paraffin soaks, and maneuvers like windmill maneuvers and frisbee maneuvers. We have gloves and socks also. There are lesser number of episodes, lesser than 5. You can start them on calcium channel blockers or angiotensin receptor blockers. But if the patient has history of gastroesophageal reflux, we should avoid calcium channel blockers. And then they have much more severe effect. Why? Because they will decrease the esophageal sphincter tone. So there will be more chances they will aggravate the germs. So we should give ARVs, and if they have more than 5
drug of choice, calcium usually used, commonly used.
Commonly we use what? What about when the esophageal involvement is there, by which drug?
Proton pump inhibitor we should start with like pantoprazole or omeprazole. We can also give H2 antagonists like ranitidine. Probiotics can be given for the patient, and if they have prokinetics like metoclopramide, domperidone can also be given. If the patient gives a history of constipation, we can give non-stimulant laxatives.
Phosphate. Phosphodiesterase.
Yes, sir. In vascular phosphodiesterase inhibitors, we can give if the patient has digital ulcerations, like sildenafil, tadalafil, IV prostacyclin analogs like iloprost, and endothelial receptor blockers like bosentan can be given if there is digital ulcerations. And statins and antithrombotic therapy should also be started for the patient.
Any role of pentoxifenone?
Yes, even if like digital ulceration, we can give pentoxifenone also.
What is mechanism?
Vascular, like it will cause vascular dilatation, and it will if ulcerations are already there, we cannot give, but it will prevent new ulcer formation. It will prevent the that endothelial or vascular vasoconstriction and all. It will prevent.
what is Raynaud's syndrome?
Primary Raynaud's syndrome is known as Raynaud's disease.
Like there are two types, primary and secondary. Primary, no cause is there. That is Raynaud's disease, ma'am.
What is the cause? What is the abnormality in primary Raynaud's?
Like it's like exposure to any cold, emotional stress, ma'am.
Vascular
instability, but there will be no ischemic or vasculopathic changes. And in secondary, due to some other causes like connective tissue disorders or other obliterative disease or carpal tunnel syndrome, like other causes, or even drugs also. So they cause this vascular changes, ischemic changes, vasculopathies they will cause, and due to that they will have Raynaud's syndrome.
Which sex?
Females are more common, ma'am.
In both
female, but primary is more like 20:1, ma'am, and in secondary 4 is
very high incidence.
Very high incidence in primary.
And emotional factors are
emotional factors in both, ma'am, but more in primary, ma'am. Emotional factors, cold, stress. So, Raynaud crisis is an emergency.
Raynaud's crisis.
Renal hypertensive crisis also, sir.
Renal hypertension.
Scleroderma renal crisis. Renal crisis. Hypertension.
Anything gastric.
Yes, a perforation of the GI.
Dilatation and perforation. How do you treat scleroderma renal crisis?
She start the patient on ACE inhibitors immediately.
That's a deep drug of choice for scleroderma renal.
And other antihypertensive can also be given to control the BP, like alpha blockers can also be given. And if the Ilopros also is helpful. If the patient still does not respond, we should.
Having said Iloplast, where are the indications of Iloplast in the management of scleroderma? On a whole.
Yes, sir. For Raynaud's phenomenon, ulcerations, and for pulmonary artery hypertension, and for renal hypertensive crisis also we can give Ilopros.
What are the pseudo-sclerodermatous conditions and how do you exclude one?
So all conditions which mimic scleroderma, like scleromyxedema, scleroderma. They are exposed to pesticides, mining occupation, and silica, exposed to silica, organic solvents, adhesives, cement.
Any drugs?
Yes, sir. Bleomycin, endoxazine, cocaine can also cause scleroderma.
Tryptophan, ergots also, sir. Oral contraceptives also.
Much more important. Any procedures in about scleroderma? Is it
exposure to gadolinium
So you would radio contrast dyes who are using
that is radio contrast. Which type?
gadolinium type.
Gadolinium type of radio contrast drugs they can use as scleroderma.
What are the other disorders where you see sclerodermatous changes?
like all scleroderma.
Apart from that, any dermatological diseases?
Amyloidosis also because
mixed edema,
eosinophilic patient.
Graft versus
progeria.
Chronic or acute?
Chronic. And even progeria, scleroderma and progeria, genodermatosis, progeria is amplified.
Then we have difficulty for solids or liquid first.
You have liquids. Because solids form it will go, it will stimulate those sphincter, ma'am, so they'll allow it to pass. They'll have more towards it.
It's right, there is some specific area we want to
Mr. Badal, what is the typical skin biopsy?
In early stages, we see more of inflammation. There will be more lymphocytes around the adnexas and around the blood vessels and dilatation of blood vessels. In early stage, there will be mostly pale staining collagen bundles will be seen. Towards the indurated stage, there will be closely packed collagen bundles seen all over the lower dermis and can extend to the subcutaneous tissue. There will be intimal proliferation, obstruction of the vessel, and lesser inflammatory infiltration will be seen. And there can be epidermal atrophy also.
What about the adnexate?
Adnexate will be absent or they will be trapped. Endocrine glands will be trapped because of the collagen deposit. They appear to be in a higher level also.
Then system-wide, what are the manifestations? For example, skin manifestations. What are the changes you see in the skin?
In skin, starting from face, ma'am, there will be tight dots.
That's okay. Sclerosis is one thing. Tightening of the skin will be there. What else?
What loss of eye, like wrinkles and all will be there.
Yeah, that is over. Next, any other pigmentary changes?
Pigmentary, like diffuse pigmentation, hypo and hyperpigmentation can also be there. And
What are the common sites you see?
Pigmentation of face, upper tongue, and even on the fixed face you can see. Telangiectasia also we can see, ma'am. Edematous changes will be there. Calcinosis we see. Ulcers we will see. Scars we can see. Punctate or skinnet scars. And
Any mucinous changes?
Yes, papilla nodular
Acrocalcoclastoidosis type of changes on the periphery and the ulnar and radial aspects of the fingers. So, and that is cutaneous. Next. What?
Lymphatics.
yes, lymphatics also is a lymphatic obstruction due to sclerosis can also happen and lymphangiectasias can also be seen.
Cycling paper.
Yes.
What are the other conditions you see?
Dyskeratosis universalis hereditaria. And acropigmentation dohi we can see. Xeroderma pigmentosa we can see and
even repigmentation of vitiligo we can see.
What are the various type of pigmentary changes you see?
diffuse hyperpigmentation we can see more on the sun exposed areas and sort of hyperpigmentation and depigmentary changes followed by
Similar to vitiligo, you see some white patches. So these are the three pigmentary changes you see. Now coming to next system, pulmonary is the commonest. Almost all the patients will have pulmonary. Patients will come with symptoms. In 1/3 of the patient come with symptoms, 1/3 you see on investigations, and then further investigation identified in the other 1/3. So what are the manifestations, pulmonary manifestations?
Most common we have interstitial lung disease. So patient will present with dyspnea, dry cough, and chest pain. We can also develop pulmonary artery hypertension. And
Basal cups?
yes, basal cups.
Okay, PAH and
interstitial lung disease.
ILD are the common manifestation. Next, GI manifestations.
There will be dysphagia and GERD, gastric
Any tongue disease in
macroglosia and decreased movement of the tongue because of sclerosis of frenulum. And
What is the difference of macroglosia?
Amyloidosis also we can see.
What is the, how do you differentiate? Hemorrhoid. Can go for stain?
Yes, common red stain you can do.
What is that? This staining process called? Takes another.
The apple green white.
How? Management?
The investigation, what are all the investigation you get in a flow one? All the investigation.
Routine blood investigation, CBC, ESR, CRP, Then urine analysis, 24-hour urine protein, renal function test to rule out renal involvement. To rule out liver involvement, we can do LFTs. And muscle enzymes, creatine kinase, LDH, ANA titers, and autoantibodies can be checked. And to rule out pulmonary involvement, we can do chest X-ray, pulmonary function test, HRCT, and ECG, 2D echo, cardiac MRI to rule out cardiac involvement. If the patient has contractures and ulcers, we should do X-rays of the joint and MRI of the joint. And also pus culture and sensitivity should be sent. And to rule out to assess the gastric symptoms, we should do 24-hour pH manometry, barium follow through, and endoscopy and colonoscopy can be done.
See, in this upper endoscopy, we have a specific feature of this one. What is that called?
Caves,
watermelon stomach.
gastric
It's quite classical of
So we can start with the phosphodiesterase inhibitor and IV electrodes and endocrine receptor blockers.
this is what we do that. So in this particular case,
What is the cause of death in suspension?
Most common interstitial lung disease followed by pulmonary artery hypertension, cardiac manifestations, and renal hypertensive crisis.
What are the poor prognostic factors?
Male gender, old age, if they have diffuse skin involvement and multiple visceral involvement, they have interstitial lung disease at the time of presentation, anemia, elevated ESR, proteinuria. These are the
which type of ANA this?
anti-topoisomerase has a worse prognosis.
Antibodies. What are the antibodies associated?
Centromere
Anti-centromere
antibody,
antibodies.
RNA polymerase III antibody, and topoisomerase SCL17.
In children, what is the prognosis in children?
More good prognosis. We see more of
What are the differences between adult and childhood?
more diffuse skin involvement will be seen, and Raynaud's phenomenon, musculoskeletal phenomenon will be more. They have more chance of developing gastric and pulmonary complications, less chance of developing renal complications, and the skin involvement will be more insidious and subtle. Better prognosis.
Pregnancy. What happens in pregnancy?
There will be decidual vasculopathies, so they might have miscarriages and preterm deliveries to be seen.
Postpartum, it is normal, usually not so many changes. But this
What becomes worse?
Raynaud's will improve and gastric GERD will become worse, renal complications and pulmonary
Abdominal
complications.
distension of the GI symptoms will be.
What is the level you take the
T4 level.
for it? That
The level of liquid.
Thank you, Dr. Yashashree and Samiha. Now I call upon Dr. Keerti and Dr. Meera to present a spot. Please, chairperson, please continue.
Good morning, sir. Good morning, ma'am. Myself, Dr. Keerti, DFA student, Railway Hospital, Nagpur.
Dr. Meera, PhD hospital.
Describe the lesion and give your diagnosis. Sign differential.
So the picture shows multiple discrete purple polygonal plain top papules and plaques with minimal scaling and fewer erythemata. Fewer erythemata. Flat tops, dry and grey colored lacy pattern is seen on the surface, which can be called as Wilhelm's trials. They are more prominent when made moist with cedar oil or liquid paraffin.
So when they are not, lesions are not clear, some device to use and make it. Dermoscope. Wood slab. Okay. Next, what do you say? Which type of this thing? You said what is your diagnosis?
The picture is suggestive of lichen planus.
Lichen planus. Which type of?
Eruptive lichen.
Eruptive lichen. Or generalized lichen? Generalized lichen. Generalized lichen. Acute or chronic?
Acute lichen planus.
Acute lichen planus. How do you differentiate between lichen or eruption? Because there is generalized lichen. Lichen or eruption, lichen planus.
Lichenoid eruption, more hypertrophy is there and more thickened lesions.
Truncal involvement will be there.
Yes.
More of truncal involvement, and it even involves the extensor aspects. And
LP is
no mucosal involvement.
idiopathic LP is flexor and lichenoid is extensor. Photo distribution.
Then oral involvement won't be there. I mean, mucosal involvement will be absent. Pruritus won't be there.
Yes. Now you go for
Histopathology, it will be there in lichen planus. Sorry? Tracking with then, according to on histopathology, lichen planus, it shows like mild hyperkeratosis, irregular acanthosis.
So there is mild hyperkeratosis, irregular acanthosis, and wedge-shaped focal hypergranulosis with the base pointing upwards. Multiple basal cell degeneration is seen with colloid bodies and sawtooth appearance of retail ridges and pigment incontinence in the dermis. Band-like lymphocytic infiltrate along the basement membrane.
So what are the differences between lichenoid and lichen planus? Starting from the upper layer you start. A lichenoid eruption, what do you see in the stratum corneum? Parakeratosis. Lot of scaling. The morphology is lichenoid eruptions are psoriasiform and eczematous type of lesions. So you see a lot of scaling and parakeratosis will be seen. Okay, next.
Colloid bodies.
Colloid bodies, where do you see in lichen planus?
Lower epidermis and
in the basal layer, whereas throughout the epidermis
is in lichenoid. And the infiltrate is diffuse in lichen planus and patchy in lichenoid.
No, both. It is band-like only. Only the the cells.
Cells are different.
What are the cells?
Predominantly mononuclear infiltrate in lichen planus.
Lymphohistiocytes is lichen planus, whereas you find because plasma cells
in lichen.
that's causing lichen planus.
Anti-tubercular drugs such as rifampicin, anticonvulsants such as phenytoin, isoniazid, phenytoin can cause, carbamazepine can cause, and antihypertensive drugs, beta blockers, ACE inhibitors.
Anticonvulsants like phenytoin and diuretics like thiazide and spironolactone. Then calcium channel blockers like amlodipine, heavy metals like gold, mercury, and arsenic. Then antimalarials like chloroquine, quinine.
Brisiofalin causes are used in the treatment. Brisiofalin
Is used in the treatment.
Used in the treatment can cause also. It's a therapeutic paradox.
Five P's are pruritic, purplish, plain, polygonal, papules and flakes.
Some more P's.
Some more P's are there.
Which is persistent
with hypertension.
Post-GM pigmentation, pterygium.
Seen on the penis.
What are the types of lichen planus? Types.
Actinic lichen planus, atrophic lichen planus, annular lichen planus, bullous lichen planus.
Lichen planus, bullusum, and then bullous lichen planus, and then what are other different diagrams for bullous lichen planus?
Bullous lichen planus, differential is the lichen planus pemphigoides, sir.
How do you get this?
In bullous lichen planus, there is an exaggerated basal cell degeneration. There is a pronounced max close of space which resembles a subepidermal bulla. And in lichen planus pemphigoides, it's the coexistence of both lichen planus and bullous pemphigoides in the same patient.
Basic.
Clinically, how is distinction?
Bulla, what happens to bulla? Whether it is limited to
Bullous lichen planus, it will be present on the previous lichen planus or nearby locations. In pemphigoides, it will be even on the normal skin.
What is the antigen in pemphigoides? Bullous lichen.
PP 118.
Yeah.
Same as bullous pemphigoid antigen.
What are the oral types? Oral.
Papular, reticular, atrophic, erosive, ulcerative. Ulcerative type.
Which type of malignancy?
Squamous cell carcinoma.
Why do you get malignancy in
Overexpression of cyclones.
Cyclosis means to overexpression.
one more?
CV mutations.
What is the C? Semic is whether it is proto-oncology or tumor suppressor. Because we don't get in psoriasis, but we get in lichen planus because this proto-oncology gets stimulated. So that's why we are more prone to get cancers in lichen planus, patients in lichen planus.
What are the syndromes associated?
symptoms associated?
Inherited Riccardi syndrome, which contains triad of non-cicatricial alopecia of the axillary and pubic region and multifocal cicatricial alopecia of scalp and follicular lichen planus. And another one is Greenspan syndrome, which has a triad of hypertension, diabetes, and lichen planus. Then vulvovaginal gingival syndrome.
What are systemic associations?
Systemic association associated with diabetes, hypertension, Crohn's disease, ulcerative colitis,
Herpes infections. Hepatitis C and hepatitis C infection.
That is C.
Vaccines?
Hepatitis B vaccine.
Any recent vaccine?
COVID.
COVID.
COVID, which vaccine?
COVID, the H vaccine. COVID, there are so many other.
Pfizer vaccine, especially there are reports of lichen planus following Pfizer vaccine.
Oral IP, oral steroids.
Oral steroids.
generalized LP, generalized acute LP, oral LP, nail lichen planus, and bullous LP.
Nail changes in LP.
Nail changes.
Longitudinal splitting and ridging of the nails, distal onycholysis and pterygium formation. The proximal nail fold gets fused with the proximal part of the nail bed, and there can be subannual hyperkeratosis.
Mesonegia striatum.
Pterygium means back pain. Moss.
Okay.
Thank you, Dr. Deepthi and Dr. Meera.
Good morning. I'm Lakshmi Shami and my co-PG Shrija from Medicine Institute of Medical College.
Yes.
So this shows multiple well-defined skin-colored papules and erosions present over the web spaces and the dorsum of the hand. And the first picture here, we are able to see the papules and erosions. This is also papule, the web spaces. And here also exfoliation. And these are erythematous papules, and these appear to be nodules on the
Appear to be nodules on the glands or on the scrotum?
Here on the scrotum, this is the nodules.
Okay.
Diagnosis? As per the clinical features, the diagnosis is scabies.
Scabies. So, is there any pathognomonication to say it is scabies or it is?
So, burrow is a pathognomic feature, characteristic feature.
Is it?
Not here, but
To make it clear, what do you do?
Indian
Indian ink and or
tetracycline.
tetracycline.
Fluorescence.
Fluorescence. How do you say just apply it then next?
So tetracycline solution, it is poured on the lesion and excess is wiped with alcohol swab. And then under the wood slump we examine the lesion. And then there is greenish fluorescence which is seen to highlight the burrow.
Greenish or yellowish?
Yellowish.
Tetracycline you are not saying.
Yes.
Greenish or yellowish? Yes. Indian ink, how do you demonstrate?
Bluish color appearance on when we apply it over the burrow, then the burrow becomes more prominent.
No. Then what you pour with? Just to identify the burrow, you are putting Indian ink. So Indian ink you have to see, and then next what you do to make it prominent. The whole thing is blue color. The whole skin. How do you do? You have to clean or you have to wash or something like that. Normal skin have to be
Cleaned with saline or alcohol swab, so that only the burrow is visualized.
Yes, that's the point.
The ink retained in the burrow will become make the burrow brown.
Average size of the burrow.
It is 0.5 to 5 mm size.
It starts from where it ends where? It starts from where which layer?
Stratum corneum.
That's it. Can't mass medium it can go, but can people say still it can go deeper?
Go deeper.
Deeper.
So end pin says a black point. What is the main pin? And at the end of the burrow, you see some black point. What is the name?
Delta sign.
No, that is different. It is different. That is no. Not the burrow. In the burrow you will have what are the contents of the burrow?
You can see the mite along with the eggs and also skybala.
Skybala.
That is the feces of the mite.
See what she says is at the point there are two types, two ends of the burrow. One end of the burrow indicates bite of the mite. That you will see crust, hemorrhagic crust. The other end of the burrow is blind. Cannot see.
Life cycle of skin.
So an adult mite, the female mite and the male mite, they mate with the burrow, and after that the male mite dies, and the female mite lays eggs which hatch into larvae.
How many eggs?
Approximately 50 to 50.
No, 50 to not a single mite.
3 to 4 eggs. 3 to 4 eggs
eggs
per day. On its life cycle, it's almost 50 to 80 eggs.
Yes.
And after hatching, it hatches into three pairs of larvae. In about 50 to 53 hours now. And later, 3 days.
3 days.
And after that, it transfers into protonym, which takes about 3 days, and then tritonym, another 3 days, and from tritonym to the adult stage of larva.
How does the adult mite look?
It is translucent. It has 4 pairs of legs, with the anterior pairs having dorsoventral flattened and oval shape. Ovoid shape.
Why should we know all these things? We are not zoologists. Why should we know life cycle of
We are
this?
to identify.
We identify and the treatment purpose also it serves. What is the treatment purpose? Serves.
To know whether the
No, some are in the adult stage, ovicidal and larvicidal and insecticide. So drugs, so we have to decide and then we have to see, repeat the treatment. And the next host. What is the importance of host? It can it can complete its life cycle in
completely in obligate parasite, it can complete its life cycle in humans only.
in single host.
Single host.
That means untreated scabies, how long it lasts?
Lasts for months together.
Months. Why didn't you say what is the other name for scabies?
7 years.
But then why do you
But
say?
usually it is due to the herd immunity that cyclical, periodical appearance of this.
Cyclical is one.
Yes.
The complete life cycle in single host that untreated cases cannot be cured. So I have to intervene with the treatment.
But the clinical
Cycle is
diagnosis.
30 years. Ultimately cycle is 30 years.
Types of scabies.
Clinical types of scabies.
No, just start with clean. Start with
Scabies of
clean.
flea.
Classic.
Classes.
What is classic scabies? What is the distribution? What is cycle of February?
Cycle of February is an imaginary circle drawn joining the prominent parts of involvement of this disease. Starting from the web spaces, the wrist flexors, then elbow flexor, axilla, then periareolar region, umbilicus and the groin.
Next type.
Infantile scabies. Then we have a crusted scabies.
Infantile, what is the difference between adult scabies and infantile?
There's scalp, face, head involvement more seen in the infants. Also, eczematization, impetiginization can be secondary infections are common. Palms and soles also more lesions are seen. And also vesicles, vesiculopustules are common in this type. And along with that, nodules also are more commonly seen.
Eczematous lesions. Eczematous lesions are
Eczematous.
Why?
Why palms?
Why palms and why eczema is common in the infants?
Secondary infections more due to this.
So, tell me the treatment of animal scabies.
Endoscopy findings.
Okay.
Endoscopic findings, we can see nodal sign, that is the presence of furrows, jet contrail sign, that is the advancing mite and the other end, and also delta sign, hang glider sign.
Under the low power, we can see circumflex V-shaped French letter right sign.
Is there any class of this Norwegian skills grading? There is a grading of Norwegian skills depending on 4 parameters. The mind is moderate and severe depending upon the number of days of biometric.
How does Norwegian scabies differ from normal?
The number of mites are more.
No, clinical.
Clinically,
When do you suspect?
there's severe crusting.
Where?
Palms and soles
Yes.
are the most common sites.
Palms and soles are the most common
And
site.
severe crusting.
Yes.
It's seen mostly in immunocompromised.
Psoriasis formation.
Psoriasis
Hyperkeratosis.
Treatment.
Topical agents like permethrin.
Drug of choice.
Permethrin is 5% permethrin. It's 97% efficacious. So the drug of choice is permethrin. And oral agents like ivermectin. 0.2 mg per kg body weight.
2 mg.
200 micrograms.
Tablets or?
Strength.
3, 6, 9 and 12. 12 available strengths.
Other topical agents.
There is some mite-borne diseases. Most important nowadays we are facing.
Mite-borne.
Mite-borne like dust mite can cause atopic dermatitis. And apart from that, we have walking dandruff, Chietiella, and then phimosis, ventricosis, which causes cotton like rash, and then Demodex follicular.
There is mite-borne fever, anything?
Mite-borne fever.
With rash.
Rashes.
Rickettsia.
After the admissions in medical wards. I think reflex mite-borne.
Other topical agents.
Other topical agents like benzyl benzoate 25%.
Ideally, how much should be there in the body?
BP lotion. For benzyl benzoate.
Benzyl benzoate should be for 24 hours, ma'am. 3 applications within the 24 hours.
72 hours. 12 hours. Overnight, 3 days. 3 consecutive days.
Complication.
Of benzyl benzoate. Contact dermatitis or disulfiram-like reactions when patient takes alcohol.
Irritation, bad odor.
Yeah, malodor and also contact dermatitis.
And within how long it should be there?
8 hours minimum of contact periods overnight.
How do you treat a child less than 2 months age?
Permethrin is advisable.
Less than 2 months.
Less than 2 months.
Sulfur.
2%
of permethrin.
Pregnancy.
Sulfur.
Drug of choice.
Permethrin.
Permethrin.
GABA, voltage gated sodium channels, ma'am. The types of the voltage gated sodium.
Condition where you use oral or
Pediculosis and
COVID.
Wind up, please.
No,
This is Dr. Anju from Pratibha Institute of Medical Sciences.
Next slide, please. Please describe the lesion and give your diagnosis and differential diagnosis.
In this image, we can see multiple hyperpigmented vacuoles and patches. Patches are
Color of
brownish, hyper, symmetrical over the malar areas and also on the nose and also on the above the eyebrows, supraorbital region. And also perioral pigmentation seen around the lips, whereas in the filter we have mild pigmentation and also below the chin.
below the chin. Okay, your diagnosis.
Diagnosis is melasma.
Melasma, simple melasma or because type of melasma?
What type of melasma?
Centrofacial melasma.
How many types of classification are there?
We have 2 types of classifications. Based upon the location, we have centrofacial, malar and mandibular, of which the commonest is centrofacial. And based on the Wood slab examination or the location of melanin pigment, we have epidermal, dermal and mixed.
Histopathologically?
Histopathologically also we have epidermal, dermal and mixed.
What is the meaning of melasma?
Black spot.
You also answered.
What are the causes of facial melanosis? Why causes? Why causes of facial melanosis?
I can do this.
No, facial melanosis.
Like a place pigmentosis. This is physiodermal serum. Post-inflammatory hyperpigmentation. Post-inflammatory hyperpigmentation.
Might close your mouth.
Don't reach
Age, spotted.
Here the questions also.
Very bro.
Be loud. Fourth piece, melasma.
Fourth piece, melasma. UG question, undergraduate question. Don't know. Pregnancy, pills, photosensitivity.
Etiology, melasma.
Hormonal
Be little louder.
and the genetic factors also is there, and skin type they both common in like 4 to 6 dysphatic skin types, like multifactorial, like genetic, environmental.
Any endocrine disorder which can cause?
Thyroid
Disorder. Any deficiencies that can cause?
Websites.
Gene deficiency and
Big buns. Kidney statement is 5% hydroquinone, 0.1% retinoid. Big buns and modified treatments. Original treatment formula is 5% hydroquinone, 0.1% retinoid, and 0.1% dexamethasone. The modified pigments is actually 4% hydroquinone, 0.05% retinoid, and 5% fluoxetine or even dexamethasone. Exogenous sucralosis and leukoderma inconfective, like concentrated tissues. Histopathology, there is increase in size of in exogenous sucralosis, banana shaped open fibers. But because homogenetic acid is derived of hydrocarbons.
accumulation, inhibition because of accumulation of homogeneous acid, which is what is the color of the acid? Why the ochre is what? What do you see on the histopathology?
In the dermis, we see yellow banana-shaped globules.
What is the dermoscopic findings? Very good.
We see the globules, pigmented globules either in reticular pattern or pseudo-reticular pattern. Firstly, we'll educate the patient regarding the avoidance of few factors like sunlight. And first line, we give them sunscreens.
Which sunscreen?
Physical sunscreen.
Physical sunscreens. Physical sunscreens, the problem with the physical sunscreens?
They form a white cast.
So cosmetic
Cosmetically.
compliance will not be there.
Yes.
So people will apply once and then second day they stop.
Classify sunscreens.
Or inorganic sunscreen, chemical sunscreen or organic sunscreen, UVA protector, UVB, and broad spectrum.
You have to tell each one month. Example.
UVA will be physical sunscreen is titanium dioxide, and UVB will be salicylates and power derivatives. UVA will be
Indian which, how much sunscreen, which HP? Indian skin, which sunscreen? Ideal. What is SPF?
SPF, yes, first of all, SPF.
Sun protection factor.
How will that?
How much?
How do you calculate?
The amount of UV radiation which produces erythema or after application of sunscreen, without application of sunscreen over 2 centimeters square surface area. So it is like protein actually.
Yeah. Which SPF sunscreen services?
At least 15.
No, 50 is after procedure.
What does you SPF tell you? Protection against what is the
UVA.
UVA or UVB?
In atmosphere, which is most
UVA radiation.
In that patient, what will you see? How much SPF?
At least 30.
But you see SPF or something else? For melasma, what?
Color of the skin or you decide about
What is PA plus? So in melasma, you look at PA plus or FPS? The PA is more important, but as well as melasma, not visible light as well as for sunburn, for skin cancer, there you see SPF. In India, SPF may not have it doesn't really matter. For we are more mother of humanity. You have to look at the PA, not SPF. What are the sunscreen and illegal sunscreen? Is that any other type? What are the hybrid sunscreen? What are hybrid sunscreen? That is not, that is broad. That is different broad, but not hybrid.
ideal sunscreen services.
Hybrid.
Which will be
Peace, take about peace, peace.
Peach, which do you use?
Which one you want?
based on whether it will be epidermal or dermal pigment. If epidermal, they can go for based on the melasma, epidermal, we use glycolic acid.
How much percent? How much percent?
If it is very superficial, we will use around 20 to 50%, and duration will be around 2 to 5 minutes. And if it is more, we can use 70% of the glycolic acid, and the duration can increase up to 10 to 15. Glycolic acid, TCAP, salicylic acid, gesnastic, lactic acid.
What is yellow pig?
Retinoic acid. Retinoic acid.
Is it laser? Laser?
India is
Expand laser, LASC.
light amplification by stimulated emission radiation.
So here which laser?
India laser, to switch India laser, and Ruby laser.
Oral medication. Huh? Anexamic acid. How do you use?
Dose of 250 mg, 12 to 16.
Before starting dynamic chemistry, what do you do? Complication, investigation.
Coagulation. In mixed melasma, what do you see in DCA microscopy? Classification of melasma, you know. DCA microscopy, what do you see? Mixed melasma. Because now they are considering all, no epidermal or dermal melasma. They consider every melasma as mixed melasma. So what do you see? Any pages?
Venereologists draw reticular dermis. What are those called? Venereologists dropping down into the dermis is one. Pendulous melanocytes.
Okay.
Thank you, Dr. Vivek and Asna Anju. Now I call upon Dr. Shruti and Dr. Yasin from Kakatiya Medical College.
Please introduce yourself.
Good afternoon, everyone. I'm Dr. Shruti. Dr. Yas.
Next slide.
Next.
Please describe the patient and give your diagnosis and differential.
Skin color and papular lesions with color.
Can you come?
With color projection.
Because the skin color is because the skin color. You want to say skin is pale color.
Pale.
Pale color. Skin color is described in different ways.
Yes.
Not medium. Pale color. Very
Pale
defined.
color, well-defined raised lesions with cauliflower projection. The surface has cauliflower projection. Multiple in number. Mucous surface. Warts. TBVC. Tuberculosis verrucosa cutis.
How do you differentiate between what and then clinically TBVC? Clinical.
TBVC, the lesion will be expanding peripherally.
Yes. Peripherally and
Central clearing will be there.
central clearing or one side?
One side.
One side, not side.
Expand from the one side.
Expansion at one side, at the other side there will be
Healing and scarring.
healing or scarring. Yes. Any deeper infections?
Sorry to interrupt. All the questions should be asked in mic because this is live streaming going on and we can't hear. Like question and answers to the pages.
I request you all to
Keep the mic close.
Closer to the mouth.
When varicose epidermal is also varicose.
Other varicose.
Any variant of lichen planus? Really?
Varicose
lesions. Variant diagnosis.
A variant of lichen planus.
Hypertrophic.
DL.
Any fungal infections?
Fungal.
So, what is the causative organism? Causative organism.
Human papilloma virus.
What is DNA, RNA, what?
It is a double-stranded DNA virus.
Tell me, number of the common words, general words.
2, 4, 7, 27, 57.
Types of words you tell, types of words.
Common words, periangular words, plain words, plantar words, anogenital words, filiform words, digit words.
Plantar words, how you differentiate from plantar words to other calocities?
Calocities. Okay, or cons.
Dermographics are present on fronds, absent on verruca. On
Paring of warts
We see
Central.
central part of wards. We see bleeding points.
Bleeding.
That is because of extravasated RBCs and thrombostatin.
You cannot see saccharide, pressure point, because this can occur anything. These are the three differentiated points.
And the pain
Pressure.
pain on later pressure. And,
Pain and lateral pressure. Where? And which place? What?
What's
What's on more painful when you
Plant.
have lateral pressure, whereas the con on vertical pressure.
Mr. Pedal.
50 to 55 nanometers. Nearly 200 times.
What is the incubation period?
Incubation period is from weeks to years.
Yes, 9 months. Yes. 9 years. Now, how do you get the wards from each person to other person? What are the modes?
What sort of transmission?
Also transmission might be into skin contact and through trauma, maceration, through nail biting. Person to person is through swimming pools.
Any occupation?
Yeah, occupation.
Manual labors.
No. Butchers wards.
Which type of virus can cause booster ward? 7.
What is mosaic ward?
What's like thick endophytic papular the collages to form mosaic wards.
Multiple patterns of college to form a bigger one. Histopathology?
Histopathology actually common and plantar wards. Hyperkeratosis is seen, acanthosis is seen, papillomatosis is seen, and a few coilocytes are seen. Papillary ridges, later ridges,
10-15 minutes. Then differential part into Piliform wards, differential diagnosis.
Piliform wards,
On face, it is taken face, or plain wards.
common site is piliform wards, face and necks.
Differential diagnosis.
Cutaneous form.
Cutaneous form.
Necrocorditis. Okay.
Necrocorditis.
Plain wards written? Plain wards?
Plain wards like cutaneous form.
Face. Any
Seborrheic keratosis.
trichoepitheliomas or seriomas.
Which type you have got malignant propensity?
16, 18.
13.
What is the vaccine which is
HPV vaccines are actually in India quadrivalent vaccine. It's not
what is the name of the vaccine?
Gadas.
A child, 1.5-year-old child comes with genital. How do you differentiate whether it's a sexual abuse or a
Vertical, mostly below 3 years we suspect vertical transmission. Vertical transmission, later 3 years we suspect sexual abuse. Anogenital wards. Clinical features we check for signs of hemorrhage or tears.
signs of abuse?
What are the areas in anogenital wards? What are the areas involved?
Anogenital wards, mostly in males, penis piscium, frenulum, glans penis, coronal sulcus. In females, we see labia, posterior portion of vagina.
Okay, then treatment.
Actually, treatment is based on the number of wards.
But in this case,
In this case, mostly there are multiple wards. We go for interlesional or vaccine. So,
the interlesion is every lesion we have to give.
Single lesion we can give MMR vaccine. And we can do electrocardiogram also.
Any cryo?
And we can do cryo also.
Cryo, what is the what it means?
Textbook they give first line, second line, and third line. Don't start with third line. Maybe you are practicing. Start with first line.
Tell about all topicals first.
Ma'am, topicals.
Chemical quality.
Chemical quality. We can apply salicylic acid.
How much percent?
12 to 26%.
Then
We can apply TCA.
TCA. How much?
TCA is 50% TCA.
50%. 100%
Then
Genital warts.
any other?
Podophyllatoxin or podophyllin?
Both, sir.
So which concentration, which one? Podophyllin is how much concentration? Podophyllatoxin, what is the concentration?
Podophyllin is 25% in compound nature of enzyme, and podophyllatoxin is 0.5%.
It is extracted from? Podophyllin is extracted from? How long we should apply and in a week how much time and
Podophyllatoxin, podophyllin is applied weekly once for 4 to 6 weeks. It is applied and allowed to dry. After that, wash off in 4 to 6 hours.
What are the complications?
Most common complication, headache, dizziness,
necrosis,
local irritation.
Cryotherapy, TCA.
Cryo, what is the nitrogen or what is the temperature?
Liquid nitrogen.
What is the temperature?
Minus 198.
Then carbon
liquid 9.
Any topical bifluorouracil, all those that we are using. Then you should tell about that.
You may more drivers, topical bifluorouracil, tretinoin, interferons, formaldehyde, hydrochloride.
What is the epidermolysis pressure very small? Epidermolysis pressure very small.
Sir, it's gene mutation, sir. It's if everyone go to gene mutation, and it's
Defect.
It's immunodeficiency, ma'am. But they are not prone. No, ma'am. No, ma'am. Only for HPV. HPV. It's
What are the type of lesions you see in India?
we see lesions face and neck are usually involved. Plain warts with pityriasis rosea and pityriasis versicolor.
Pityriasis versicolor, right?
Any syndromes? What?
So, Venus syndrome, Wiley syndrome.
Just it. I call upon Dr. Naeem sir and Dr. Ramdas sir to felicitate the chairpersons of faculty. Dr. Indira ma'am. Dr. D.V.S. Pratap sir. Dr. G.K. Prasad sir. Dr. Rajan Narasimha sir. Dr. Arna madam. Please join correct.
मैडम प्रोजेक्टर बन जाएगा
Sudha.
మన ఏం లేదా పార్టిసిపేషన్ बैक वो पीछे डाला चेयर पीछे डाला सही
Now I call upon Dr. G.K. Prasad sir and Dr. Ramdas sir to chair the sessions for histopathology. Yes sir. Session 3 starts. Dr. Himavarsha and Dr. Tejasvi from Medicity Medical College.
Good morning. I am Dr. Tejasvi and this is my colleague and friend Dr. Himavarsha. We are from Medicity Institute of Medical Sciences.
showing stratified squamous epithelium with keratinization, representing epidermis with underlying dermis. And here we can see 3 sections of low power, scanner, low power and high power. In case of low scanner view, we can appreciate the well-defined compact granulomas within the dermis with
in place of Dr. Yusuf Said sir, I call upon Dr. Nikat, Associate Professor of Shada Medical College, to chair this session.
So it's showing the atrophy of the epidermal meaty ridges. So in scanner view, we can appreciate the epidermis with the atrophy of the meaty ridges along with the compact organized granulomas present within the dermis, occupying the entire length of the dermis. In case of low power view, we can appreciate compact granulomas consisting of lymphohistiocytic infiltrate with the central portion of the section showing Langhans giant cell. In high power, the same is visualized. And my provisional diagnosis, and here few granulomas are abutting the epidermis, abutting a part of epidermis. So my provisional diagnosis upon seeing the histopathology report being tuberculoid Hansen's. Hematoxylin and eosis. Yes, sir. One is scanner, low power and high.
Why is you label it as tuberculosis?
Here we can see the well-organized granulomas along with the abetting of the epidermis, which is commonly present in tubercular Hansen's.
What are the other diseases, granulomas?
Madoji's granuloma, which is a type of, which is dermatophytosis, and in LGB it can be seen, and cutaneous TB like lupus vulgaris, and
dermal leishmaniasis and deep fungal infections.
Histoplasmosis and sarcoidosis.
Naked granulomas are the granulomas where the mantle of lymphocytes is absent. Sarcoidosis. Yes, we can appreciate the giant cell, Langhans giant cells, with the nuclei are arranged in horseshoe-shaped periphery.
Other types of giant cells, and where do you find them?
In skin, we have got 3 types of giant cells. One is Langhans. We usually see in tuberculosis leprosy and also as well as other forms of leishmaniasis. Second is Taunton giant cells, which are seen in xanthogranulomas or xanthomas. Third is foreign body granulomas, seen in foreign body reactions.
Histopathological pattern, there's a granulomatous come. You know the histopathological pattern of inflammation? Granulomatous comes in which category?
There are a total of 10 histopathological patterns. I
tell all the 10?
No. By histopathology, abutting of the epidermis of the granulomas. 1. And second is compact organized granulomas. And neural tissue, periamphitation, and ectoplasmosis. Perineal. Yes. Sure.
What is the picture you will see in reactors, type 2 reactors?
There will be edema in the granuloma. The granuloma will be loosened up.
ENL, we can appreciate acute inflammatory cells like neutrophils, and there will be negative staining for AFP, most of the cases. AFP is negative. AFP is not always. In ENL cases, it can be negative.
Vishnu's granulomas and where do you find it? Vishnu's. Granuloma activate?
Granuloma activate.
You will find granizone. What is granizone?
Granizone is a normal dermis which is present in the epidermis and the pathological changes in the dermis. No inflammatory cells.
Where do you find it?
It's seen in some
conditions. In the leptomatous score, it can be seen from BL to LL.
Where is which other conditions? In have granizone. Foreign body granulomas, have you heard about it?
Yes, foreign body granulomas. Here, we are BT type of cancers. Foreign body.
Any special stain done for lepromatous type? This is HP stain.
Yes.
Any other stains are used?
Like for our stain.
How do you define a granuloma?
Granuloma is an aggregate of macrophages, activated macrophages of the cells derived from them.
Various types of
Types of granulomas, we have
Can be divided into two types, K-shading and non-K-shading, and special type of granulomas are tubercular granulomas and sheeted granulomas and naked granulomas which are seen in sarcoidosis.
Neutrophilic, we can also have suppurative granulomas and neutrophilic, eosinophilic granulomas also. Granuloma annulate.
necrobiotic granulomas, where do you find it?
Diabetic, necrobiosis lipoid. Lipoid.
What is actinic granuloma? Actinic granuloma. What is the other one and what it is? Can be granuloma term coming in the dermatological conditions? Enumerate few conditions where you get granuloma. That is skin condition. Granuloma facial? Ocular granuloma?
Lupus miliaris disseminated facial.
Where other conditions were usually granulomas.
Thank you, Dr. Himavarsha and Dr. Tejaswi. Now I call upon Dr. Kota Sneha and Dr. Ridha Juveria from Kamini.
Introduce yourself.
Good afternoon, everyone. I'm Dr. Sneha from Kamini Africa. This is my Dr. Ridha Juveria. Here we can see 4 sections of histopathology. The first one is cross.
Hold the mic like this.
Neither.
First is the cross section, which is showing multiple nodules with the basiloid cells surrounded by the fibrocollagenous stroma surrounding. And
multiple nodules with the basiloid cells surrounded by the fibrocollagenous stroma. And it's
multiple nodules consisting of basiloid cells separated by fibromyxoid stroma and retraction clefts. In the third picture, we are able to notice the palisading arrangement of the basiloid cells at the periphery, and some retraction clefts are also seen in the retraction spaces are seen with nuvoid deposition. So our provisional diagnosis is nodular basal cell carcinoma.
What type of technique in biopsy? What type of biopsy technique in this? Shave biopsy. Very good. Clinical picture before going to this. How classical carcinoma appears?
It's present on the head and neck side, sir. In the face, we can see at the angle of the mandible to the preauricular fold, we can see pinkish to yellow, reddish color nodule with central adherent crest.
What are the predisposing factors for classical carcinoma?
Sun exposure, sir, ultraviolet radiation, mostly of UVB radiation and less UVA radiation. And in the skin types of Fitzpatrick 1 and 2, it's most common. Then we'll have ionizing radiation or arsenic exposure, and we can also have laser exposure, along with immunodeficiency individuals we can have. And any previous history of basal cell carcinoma or squamous cell carcinoma, there is a recurrence of BCC in those individuals.
Excuse me, identify yourself. Who is Sneha and who is
I'm Sneha, sir.
I'm Prada. Yes.
The morphological variants of BCC, clinical and histopathological. Give me 5 to 6.
Clinically, superficial variant is there, morphia form variant or sclerosing variant, and nodular variant or rodent ulcer, and pigmented variant, and fibroepithelium of Pinkus variant is there. And histologically, also we have superficial, nodular, basosquamous or metatypical, sclerosiform or morphia form, and micronodular, adenoid, basosquamous with sebaceous differentiation and infundibular system and trabecular.
What is the level of, what is the site where it arises?
Depends on, it arises from the epithelial structures, depends on the morphological variant. In nodular we see on head and neck. In the superficial one we see on trunk. And
It's the common side. The face where? What is it? Rodent ulcer? And
maxillary prominence, maxillary sinus prominence.
tears ulcer. Dropping of the tears, it can come. Okay. Where else we see such picture? Some histopathological DDs for this slide.
Trichoepithelioma.
That condition histopathologically.
in trichoepithelioma, follicular differentiation will be there, and CD10 marker will be positive. Immunohistochemistry wise, that will be positive in trichoepithelioma, negative here.
Tell me syndrome where you have multiple BCCs.
Nevoid BCC or Gordon syndrome.
What is the importance? To find out Gordon syndrome. So it's the systemic.
What is the main difference between dermal cell carcinoma and squamous cell carcinoma in histopathology?
In histopathology, squamous cell carcinoma, nest of keratin clumps will be seen, sir, with more keratinization picture. In basal cell carcinoma, only basaloid cells will be seen with the fibrocollagenous stroma with palisading at the periphery.
Cellular atypia seen in which condition? Cellular atypia.
Cellular atypia will be more in squamous cell carcinoma.
What is the treatment of Parisia?
treatment in the superficial basal cell carcinoma, the primary incidence, we can go with the topical primary 5-fluorouracil and 5% imiquimod. And in the nodular variants, we can go with the surgical management. We can get Mohs micrographic surgery, electrodesiccation, cryosurgery can be done. In the recurrence one, we can go with photodynamic therapy or radiation therapy can be given. In the resistant ones, we can go with sonic hedgehog inhibitors also.
Very good.
Now I call upon Dr. Sumaira and Dr. Suwaiba from Shadar Medical College.
Introduce your college and your name.
Good afternoon, everyone. I'm Dr. Sumaira from Shadar Medical College. Sumaira.
Good morning, everyone. My name is Suwaiba.
Please spell the name.
Very good, we got an opportunity to participate. Shada. Describe the field.
Okay, in the following histopath slide, we can see a remarkable epidermis, and in the superficial reticular dermis, we can see two components, the sclerotic stromal component and the ductular components. So these ductular components, they are lined by like cuboidal cells, 1 to 2 rows of cuboidal cells.
Let me point out the used by the same person who is describing you. That's true.
So there's a unremarkable.
Otherwise, you will confuse the same person to use.
So there's an unremarkable epidermis, and in the superficial reticular dermis, we can see two components: the fibrotic stroma and the ducts, the ductal component. So the ductal component, they are lined by like two rows of the basaloid cells, and they are in a tadpole shape. Like a few ductal components, they are elongated to form the characteristic tadpole or the comma-shaped appearance. They are arranged in a paisley pattern. And here we can see inside a little proteinaceous debris, eosinophilic proteinaceous debris. That will with an eosinophilic cuticle, and there are no, we cannot see any atypia, no cellular atypia or normal mitotic figures in this histopath slide.
Which part you have taken the biopsy? Which portion you have taken the biopsy?
Cheek or upper eyelid? Punch biopsy, sir. And the eyelid or the upper cheek?
Where? Upper cheek. Where? You only tell from which place you are taking.
Any special stain used, any special stain used?
No, is it downloaded picture or you are
downloaded? You should know. The area where it is taken from, how deep the biopsy tissue is taken. And staining method also you should tell first before describing the medication.
This is the etching stain, sir.
Always tell that special stain used also you must tell.
Von Giesen stain.
This one.
This is an HNE stain, sir. Special stains which can be used with
First tell what is your diagnosis? What is your
professional diagnosis is syringoma.
syringoma?
Yes, sir.
What are the classical cells? How they present? Appearance?
Tadpole-shaped cells, tadpole or comma-shaped cells. They are arranged in a paisley pattern.
From which cell the syringoma arises?
Eccrine gland, sir.
What are the DDs for it? DDs for this condition?
Histopathology, sir.
Histopathology.
The first one will be microcystic adnexal carcinoma. Second one, desmoplastic trichoepithelioma. And the third one, morphiform BCC, basal cell carcinoma.
So, idiopathogenesis for syringoma?
Pathogenesis, it has been mostly seen around the adolescence age group. So hormonal factors can be there, and there have been diabetic association.
Which variant? Diabetic association.
Clear cell variant.
Any role of autoimmunity is there in syringoma?
There are syndromes associated, ma'am. Down syndrome, Ehlers-Danlos syndrome, Marfan syndrome, Nicholas-Bloss syndrome.
Autoimmunity is also playing a role. What are the other synonyms for syringoma?
Syringosystoma, adenosystoma, and hidradenitis eruptiva.
What are all the variants, clinical variants and histopathological variants of syringoma?
Clinical variants, there's treatment Butler classification, classifying it into localized form, generalized form, which has multifocal and eruptive, Down syndrome associated, and a familial form.
Many more in Wheaton's histopathology textbook. It's a milieu form, plaque form, acral form, bathing trunk form, disseminated form. Okay? There are many more. You want to check.
Before going to proceed to treatment, what counseling you will do to the patient?
There might be a chance of recurrence. There might be scarring or hyperpigmentation with following the treatment. It's a benign condition.
That it is benign condition. Okay.
What are the other conditions occurring from the eccrine ductal tumors, other benign tumors?
Poroma.
Nearer. You're correct.
Poroma.
Do you have itching in syringoma? How do you treat it? Topical. Any latest oral drug is available for treating multiple syringomas? Do you know any name of any oral drug?
Recently, topical almendrol is being used.
Topical Janilast, the new drug.
How do you treat this patient?
Excision, laser, removal of cryotherapy, cryotherapy,
Can you keep the mic?
Nearer.
Yeah, tell the treatment, not.
excision, laser, cryotherapy, or microneedling radiofrequency, and cryotherapy curettage.
What are the common sites that they are affected?
Periorbital, vulvar, peri, axilla, and scalp.
That's it. They will arise. Very good.
All those treatment methods you use singly or in combination, more than one?
We can use simply also or take this. We can use single excision only or cryotherapy, or we can use a combination also.
Which is first combination? Which procedure you use first?
We can try TCA first, like with, after a few weeks, we can call them for quarterly, electro-quarterly. Combination.
But one thing you said excision,
yes, sir.
40-50, right? Excision.
Yes, sir.
You can't excision.
Yes, sir.
Another thing you said that you use carbon dioxide, what is that? Cryotherapy. The cryotherapy will be down the ice in Indian people.
No, sir.
What is the problem in their head?
Pigmentation.
Hyperpigmentation. It is due in the court of law.
How many selenomas you are treated?
5 to 6 till now.
How did you treat them?
But sometimes TCA and coordinatory. That's the only thing we have at our college.
Welcome.
Thank you. This brings to the end of this pre-lunch session. Now I call upon Dr. Ashok Rao Marjeti sir and Dr. Raja Narasimha Rao sir to do mementos. The chair. Sir, you also.
It's my brother. ఎవరు మేడం మీరు ఎక్కడ ఉంటే అక్కడ
Now I hand over my to judges.
So, after carefully examining the candidates, the prizes for the first session, first prize goes to Dr. Ramya Stuti. First section. That's what I said. Sir.
Systems
Second prize is shared by Nina, Mosi and Sita. Shared. Sorry, I am still not able to spell your name correctly.
Spelling.
Huh?
అంతే కదా అందరూ మంచిగా ఉన్నారు అందరూ అంతే అంతే కదా చెడ్డవని నలుగురు గుర్తుందా చెడ్డవని నలుగురు అంతేనా
So I now give my mic to Ashok.
In the second session, there was a great tussle. In fact, most of them did very well. We had a great problem to decide who's the winner, but there's just a very mild difference. And the first prize goes to Dr. Samina of Osmania Medical College. Samina. And the second prize goes to Dr. Yashashri, again of Osmania Medical College.
Okay. One more photo. Take the step.
So, the third session, first prize I will announce, second prize Dr. Ashok will announce. First prize. The first prize goes to Dr. M. Himavarsha. Medicity.
The second prize goes to Dr. Kota Sneha of Kamanini Academy, Hyderabad.
So we both congratulate all the best presenters or first prize winners. And we definitely say the others also have done exceeding the well. It's difficult for us to decide, but human error will be there, and then the judgment error will be there at times. So we have to be very careful in doing that, but still we have to. And I mean, because we are deciding factors, we have decided.
And if there is any error, it is only incidental, without any prejudice.
Yes, of course. So, President is also one of the selection that is judge council.
Thank you very much.
Yeah, the lunch is strictly for half an hour, so we have to gather by 2:15 to continue the post-lunch sessions. Please be quick. assemble here.
Then he noticed a single light-colored lesion with decreased sensation over outer aspect of the right arm, initially coincised and gradually progressed to attain the present size. 2 months later, he noticed multiple light-colored lesions over the extremities with a dry surface and decreased sensation, which gradually increased in size. After 15 days, he noticed
testicular sensation will be there. No? Normally also they will have testicular sensation.
past history. There is no similar history in the past. No history of diabetes mellitus, hypertension, bronchial asthma, tuberculosis, epilepsy or CAD. No significant drug history. Personal history is normal. Family history, no history of similar complaints in the family members.
Summarize in Delhi.
Summary, a 30-year-old unmarried male came with complaints of multiple light-colored and red-colored raised lesions with loss of sensation and dryness over few lesions distributed over the trunk, upper limbs, lower limbs and face with varying duration ranging from 2 months to 4 months.
So, what is your, by this way, what is your provisional diagnosis? What do you think?
My provisional diagnosis is Hansen's. If to classify on history, we would say it is multibacillary. And
as per the sequence of events, how did it present, and then what happened to him next? In that way, he would tell he had a single lesion, and then what happened,
initially, the patient had a single lesion. He had hypopigmented lesions followed by erythematous lesions and papules, not associated with pain and associated with loss of sensations. So this would suggest multibacillary leprosy, not with any deformity, in reaction most probably.
You need to say that initially, isn't it so that initially got a single lesion?
Initially started off as a
single lesion,
as towards
and then he has downgraded and he is going towards the lepromatous pole. Is it like that?
Might have started with the borderline tuberculoid and is now downgrading towards the lepromatous pole.
You said hypopigmented patches. No? What is the differential diagnosis for hypopigmented patches?
Hypopigmented patches.
Pradeep.
So we can think of early vitiligo, pityriasis vesicular.
You can project that picture, patient's picture. Next week.
In case of hypopigmented patches, the DDs are early vitiligo, P alpha, P vesicular, post-scar dermal leishmaniasis, then post-inflammatory hypopigmentation.
Okay, proceed with your examination.
Did you ask any history of treatment?
Yes, sir, we asked history of treatment. He was not on any treatment.
No medicine?
No medicine.
So persistent or they are transitory?
They were only present since 15 days and they were persistent.
Persistent, that's it.
Generation, patient is conscious, coherent, cooperative, well-oriented to time, place and person, moderately built and nourished with a BMI of 26. Vitals are stable.
Yes, proceed.
Cutaneous examination, multiple, asymmetrical, well-defined to ill-defined, hypopigmented, skin-colored to erythematous papules, plaques and patches are seen on the face, neck, trunk. As you can see, these are multiple hypopigmented patches are present over the trunk of the body. Even you can see them on the upper limbs. On the next picture, I will describe the other lesions. Multiple asymmetrical annular plaques with central clearing, well-defined inner borders and ill-defined outer borders sloping towards surrounding skin, overlying shiny wrinkled surface, measuring 1 into 1 to 7 into 7 centimeter over the trunk, upper limbs and lower limbs. Multiple well-defined hypopigmented xerotic patches measuring 5 into 5 to 9 into 9 centimeter are present over forearm, thighs and legs. Plaques over the face and trunk show elevated center and gradual sloping towards periphery. As we can see, over the back, we can see these lesions with central clearing, peripheral spreading. We can see few punched out lesions over the lower back, even over the lower buttocks. We can see few satellite lesions in this area.
They are almost tending to be symmetrical.
Yes.
Not completely.
Not completely symmetrical.
What's the other name for those punched out lesions which you are mentioning?
Swiss cheese appearance.
One more. Inverted saucer. Inverted saucer.
Korean cheese.
Okay.
Next slide. Here we can see xerosis over the lower limbs.
I have not seen any papules anywhere.
So papules are more over the face and the cheek.
What is not there?
Photograph?
The head to toe examination. Scalp and scalp hair are normal. Face, erythematous plaques and papules are present. Blink response is preserved. As you can see, these are red erythematous lesions over the forehead. Papules are present over the chin. Blink response is preserved. Corneal reflex is preserved. Nose and nasal mucosa is normal. Oral cavity is normal. Earlobe infiltration is present. Motherosis is present. Earlobe infiltration is visible.
How do you visualize the earlobe infiltration, the best plane? In which plane do you see? I mean to say, if you see from the front or if you see from the back, you get a better. Yeah. So you should have taken a photograph of the back also. Then you can see the helix having the nodules. You can see it very well.
Genitalia was normal, no tenderness over the testicles. Testicular sensation was preserved. No ulcer or deformity. Sensory examination, pain, touch and temperature sensations are decreased over the lesions. Sensory examination was normal over the other areas. Peripheral nerve examination, there was thickening of trochlea supraorbital, infraorbital, greater auricular nerves. There was thickening with associated grade 1 tenderness over the ulnar and radial cutaneous bilaterally. Common peroneal was thickened and posterior tibial was also thickened bilaterally.
Thickening, only thickened and tender. And if it's thickened, how much it is thickened? Both the sides equally or thickened on one side, not thickened on the other side? And what are the grades of this thickening?
Previous slide. There was grade 1 thickening in the...
What do you mean by zero?
Zero is no thickening. Grade 1 is thickening in comparison to the opposite side. Grade 2 is palpable with rope-like consistency and grade 3 is nodular or beaded consistency.
How much do you palpate for the nerve? What length should palpate?
You should palpate along the length of the nerve, above and below.
How much? Minimum. Minimum at least 5 centimeters has to be palpated. Minimum.
Did you palpate for greater auricular?
A greater auricular is actually better visualized than palpated.
Fine. So that is one nerve which is better visualized than second.
And for tenderness, ulnar and radial cutaneous nerve had grade 1 tenderness. That is
Ulnar and
radial cutaneous. Motor examination, there was no evidence of muscle wasting or
One minute. Go there. Please. Have you missed some nerves? I think you have missed some nerves. What are those which you have missed here?
Sural nerve.
Okay. What else? It's the audience, that's correct. Median nerve you missed, okay. And then forearm. Cutaneous nerves.
Superficial cutaneous nerve in the forearm.
how many
There
other?
are two. Which are those? Cutaneous nerves of the forearm. How many are there? Two are there. I said two. There are three. Median, intermediate, and lateral. Right? And then, of course, sural and other things.
Where do you palpate for the sural nerve? Yeah.
Between the two bellies of gastrocnemius and
Where? That means here
in the middle of the cup.
or lower end of the distal end. Between the like middle 1/3 and distal 1/3 of the junction of the middle 1/3 and distal 1/3 of the leg. Okay. And of course between the two heads of gastrocnemius.
The muscles tested, all the muscles supplied by the ulnar, median and radial nerve had grade 5 power on both sides. On the lower limb, the muscles supplied by the common peroneal nerve and tibial nerve also had grade 5 power. Facial nerve, there was lid gap only on light closure of the eye. Systemic examination was within normal limits. My provisional diagnosis is BT Hansen's downgrading to BL Hansen's with type 1 downgrading reaction without deformity, not on MPMDT.
Is this your provisional diagnosis? Do you want to stick to this? Can you repeat again?
BT Hansen's downgrading to BL Hansen's with type 1 downgrading reaction without deformity, not on MPMDT.
You mentioned some important lesions, no?
Yes.
Okay. Do you want to factor in that aspect here in the diagnosis? I agree with you partially about the diagnosis, not entirely. Yes.
BT Hansen's downgraded to BB and BL Hansen.
Okay. So what made you to think of BT Hansen's then downgrading to BL Hansen's? Justification for that?
Initially, the patient came with complaints of hypopigmented macules and patches, and there was loss of sensation over the lesions.
Okay.
And the lesions were asymmetrical. And first, the lesions were.
How many lesions were to begin with?
To begin with, there were three.
Single in the forearm.
Single lesions, actually, it is seen in tubercular TT type. And BT can contain up to 3 lesions, 1 to 3 lesions.
Okay. Another thing is what is the initial lesion? What is the characteristic of the initial lesion? The forearm lesion. Forearm lesion. What is it?
The initial lesions were more suggestive of BT.
How did it look like? Can you describe?
It was a hypopigmented lesion with loss of sensation.
There are
And
so many things.
there was central clearing and peripheral spreading.
What is the border of the lesion like?
Border was-
What is the hair? Was it dry? So many things are there. All those things that you mentioned.
It was a well-defined, it was a lesion with central clearing, peripheral spread with well-defined border.
All well defined. Throughout.
So,
Throughout well defined means it will become a tuberculoid.
a satellite lesion, there was a inner well-defined, outer ill-defined border and some.
No, the border itself is well defined and ill defined at places. Nah?
Yes.
And was there any satellite lesion?
Yes, sir, satellite lesion.
And you have to mention that. Nah? That will tell you that it was actually a hallmark of satellite BT. Yeah. But then you are not factored in the punched out lesions.
The initial lesion you have not pointed out in the slides, not described it at all.
The lesions over the back had satellite lesions
Initial
and
lesion. Initial lesion. You're asking.
shows the
It's not there. Go back. Go back.
forearm. This is the geography.
This is the punched out lesions. That's what I'm coming to. So this is the one what you are saying?
No,
This is the upper arm, na?
No, sir.
So that photograph is not there?
No, sir.
Okay. Like why this question? Can you explain why I'm asking this question?
So that we can tell what the initial.
That's okay. I'm talking about the punched out lesions or the inverted saucer lesions. Majority of the lesions are inverted saucer lesions in this patient. So what does it mean?
Inverted saucer lesions and punched out lesions can be seen in BL type of BL and borderline type of
Mid borderline. BB, mid borderline. So mid borderline is an unstable spectrum. Agreed. That can quickly upgrade or downgrade because it is highly unstable. Agreed. The lesions may have started like BT lesions to begin with, but the current spectrum, I feel it should be classified as mid borderline. What do you say? Yeah, mid-borderline. It shouldn't change. Without treatment, it shouldn't change because it's a very unstable form of leprosy, isn't it?
Because there are few papules or nodules are in the chin. It is going already there in DA. What I feel.
Majority lesions, sir.
Majority lesions are there, but there are signs of PL also.
Overall, yes.
Borderline itself is a borderline. That's it. It's a classification. The classification. What is the classification? Classify the enhanced disease.
From the Reddy Joplin classification, it is classified as tuberculosis.
Classification.
So there are lots of classifications.
More common. Okay, you go with the Reddy Joplin. Yes.
It is tubercular type, then borderline tubercular, then borderline borderline, it is mid-borderline, then borderline lepromatous, and it is lepromatous type.
It is classified according to which?
It is classified based on the clinical features, then histological features, then immunological features, bacteriological.
You have other bacillary and histopathology.
WHO classification.
Indian classification. Indian classification was keeps the thing into two polar and big borderline.
Because of how it started. But what we get to see here is the mid-borderline lesions. So that will be my diagnosis. Okay, mid-borderline downgraded to BF.
Did you do further test? It was down. Just see the face code.
On the chin, if you see, you can see there's nodules. Chin. More prominent. On the cheeks also you can see, but chin it's very prominent.
See, this supraorbital area is involved. Even insular. The nerves are also thickened. What is the nerve supply family? Which branch?
So we'll move on to the PG pattern questions which will be asked in the PG. There is always will be a difficulty in diagnosis. There is a lot of things usually we know. No two dermatologists will be diagnose one spectrum or whatever it is. So we move on to the
Because I want to say the nerve involvement is also part and parcel of this information. Mid-borderline when it's deteriorating to DL, it is through reactions and it is through.
Yeah, that's what they presented as downgrading reaction actually. How do you say it is a downgrading reaction? I say it's only BL, not BB as a sir. Actually, that the reaction is upgrading most of the times we talk, but you said it's a downgrade.
Actually, if the patient presented with reaction symptoms, actually that's going towards lepromatous. So it is a downgrading reaction.
The patient has not taken treatment, right? Has not taken treatment. In untreated patients, from mid-borderline, generally they downgrade. Okay, that's how it happens. A treated patient in the borderline spectrum, see, for the sake of first year treating, yeah. So the polar forms will not usually change their spectrum. Okay, the TTP and LLP will remain fixed. Okay, it is the borderline spectrum, especially BT, BB, BL, which will change the spectrum. Okay, so with treatment, generally there is a reversal of immunity. Okay, improvement of immunity. That's why we call it as reversal reaction, which is type 1 reaction, right? So in untreated patients, because there is no treatment given, the general tendency of a person who is having poorer immunity is to downgrade. So they will downgrade. That's what is happening in this case. So without treatment, he is downgrading to BL. Okay, and he of course has the features of reaction which makes us feel of downgrading reaction.
How do you detect the earliest involvement motor symptom or sign which you get? What is it? Would you like to do something that time only, or you want to wait the whole eye to get, the lid to get paralyzed completely? No. What's the earliest sign of facial nerve involvement, motor involvement? Which part of the facial nerve is involved most commonly?
Zygomatic branch of facial.
So what does zygomatic branch of the facial nerve supply? The lower eyelid. So when you try to close his eyes, the upper eyelid comes down and tries to compensate. The lower one will not go up. Understood? Okay, then what is the earliest motor symptom you get when there is involvement in the lateral popliteal nerve? Earliest motor sign which you can elicit.
Dorsiflexion and inversion.
Yeah, you can try. It is decreased power of dorsiflexion of the great toe. Okay? In the same way, if there is ulnar nerve involvement, what is the earliest motor sign you can elicit?
What and what?
Yeah. Sign.
Actually, the little finger will be in a subtle position of abduction. Simply contract.
How do you want to proceed with this patient?
We can do triples for this patient.
Okay. What is that?
Split skin smear. Split skin smear.
Yes, exactly. Okay, right. What do you want to do with that?
Then we can find a bacteriological index and a morphological index. And based on the bacillary index, we can decide the spectrum of
bacillary index. What is the principle of bacillary index?
Bacillary index, basically we are recording the both the density of the bacilli and the smears. It includes both live and dead bacilli.
Okay. Yeah. So it's a logarithmic scale. It is named after something, someone, no? But logarithmic scale. The same person, like Ridley-Joplin classification, bacillary index, different grades.
It is graded from 0 to 6.
Okay.
In 0, we should examine oil immersion field. There should be 1 to 10 bacilli in 100. 1 to 10, 0 contains no bacilli.
Okay.
Grade 1 contains 1 to 10 bacilli in 100 power field.
Okay. High power field, oil immersion.
Oil immersion.
Fine, next.
Grade 2 contains 1 to 10 bacilli in 10 power field. And grade 3 contains 1 to 10 bacilli in single field.
Okay.
Grade 4 contains 1 to 10 bacilli. 10 to 100 bacilli in single power field. Grade 5 contains 100 to 1000 bacilli in 100 power single power field. Then grade 6 contains greater than 1000 bacilli.
Or even global.
Okay.
Okay. If you find global, so there is no further need to count at all because that indicates it's a very high this one. So every log scale there is a increase by 10 times. That's what it means. There is a 10 times increase in the number of bacilli. It's not linear. It is exponential. Okay. Right. What is the morphological index?
Morphological index, we are measuring the percentage or proportion of solid staining bacilli, which is counted in single to 200 solidly stained red elements.
Name characteristics of live bacilli.
So, live bacilli will be uniformly stained, like there will be no fragmentation. It will be a single uniformly stained rod shape.
Tell me all the features if you can complete.
It will be uniformly stained with parallel sides not touching each other or not overlapping.
In global they will be touching each other, but what we count in MI is the single line. Okay, like the global doesn't mean they are dead. They may be live. That's not a criteria. But parallel borders, rounded edges, and uniform staining, and something more else you are missing. Audience can answer this. 5:1 ratio of length is to breadth. Okay, right. Some books have mentioned even 4:1, but you please remember 5:2. That's more correct. Okay, right. So that's the characteristic of single. Live bacilli. You count the number of bacilli fulfilling all these characteristics of live bacilli, and out of 200, you have to make it a percentage by dividing it into 2. Okay, that gives you percentage. Right? That's MI. But MI is not commonly done. You are aware of that. So BI is what is counted. Okay. So how do you classify based on BI? Possibacillary or multibacillary for the sake of treatment?
For the sake of treatment, possibacillary is when the AFB is negative and there are no acid-fast bacilli. Multibacillary when we get acid-fast bacilli. The treatment for both multibacillary and possibacillary is now the same, just the treatment duration differs.
It is not the same. WHO recommends the same, but we don't follow it in India. It is still not the same. Okay. Okay. Anyway, I'll take your answer partly. You are talking about WHO guideline which they suggested, but India has not implemented it. Okay. So what is that? The same treatment you were mentioning?
3-drug regimen of rifampicin, clofazimine and dapsone.
Okay.
Monthly rifampicin of 600 mg, clofazimine of 300 mg and daily dose of dapsone 100 mg, clofazimine 50 mg.
So for how many months?
For 6 months to be completed and 9 months for possibacillary and 12 months to be
You
completed.
said same.
Sir, the duration differs for the possibacillary.
No, it's not like that. See, the actual recommendation is PBMDT 6 months, MBMDT 12 months. PBMDT you have 2 drugs, rifampicin and dapsone. MBMDT you have 3 drugs. When WHO, what WHO is recommending now is they are asking us to make it UMDT, which is known as UMDT means uniform MDT. But dermatologists from India, we all opposed. We said it is not appropriate. That's why it is not implemented. The government program they want to implement it, but we dermatologists have not accepted that. Okay. The reason being, it's a under treatment for multivascular patients because we are already seeing a lot of patients not responding to even 1 year of treatment, which is FDT. FDT means fixed duration of treatment. Okay, right. So earlier it was 2 years, then it was brought down to 1 year. Now we are going back to 6 months. That is not going to be adequate. Okay. In TB cases, UMDT is a little overkill. We are giving one extra drug, but it is more on safer side. We are erring on safer side, so not a problem. But for MD cases, we are not supposed to follow that. Okay. But in evaluation, something more was left out. Histopathology.
To go for histopathology,
Right.
we would like to do a punch biopsy from the lesion and
Which lesion would you like to do a punch biopsy from? There are so many skin lesions the patient has. From where would you like to do? And from which area in that lesion you would like to do?
usually we take from the periphery.
Tell me from where now.
From the periphery of the lesion, but not
No, which lesion? There are so many skin lesions. Yeah.
the rheumatic lesion with irregular borders we can take.
The regular water you should take.
Irregular.
Regular water you will not take.
So we would like to get the downgrade.
Now you should take the biopsy from the latest skin lesion, which has occurred the earliest, and from there you can take from the edge of the lesion. But it should not include the normal skin. So that is the place from where you do the biopsy. Okay? If you do, for example, in the forearm, you will get BT leprosy. You do from somewhere else, you will get mid-borderline. You do from the recent lesion, probably you may get borderline lepromatous changes, isn't it?
Previously we used to take 6 sites, now 2 sites are also considered. Usually the earlobe and the lesion. So
If any patient does not have obvious lesions, which are the sites you will for?
earlobe, forehead, chin.
Anybody else in the
What is
audience?
an outer aspect of that?
Audience? Buttocks?
In case of males, we can take from left buttocks. In case of females, we can take from left thigh, left upper bottom.
Anything else also? It's more vessel. There are some more things. Did you answer? I think you answered. I did not.
Okay. Okay. What is the blade size you use?
15 Parker 15 size.
What do you mean by 15? What do you mean by 15? They will be 24, they will be 23, they will be 21. But what do you mean by 15? The length of the cutting edge of the blade is 15 millimeters. Okay? That's the meaning.
And we should, please, what should be the length of that incision that you made?
Length should be 5 millimeter and depth should be 3 millimeter.
And what do you get exactly after scraping?
We'll get first, if there is, usually it should not bleed. If we get blood,
What do you take?
serious fluid and that pulp.
You take tissue pulp, basically tissue pulp. There should be any bleeding.
Stain used for that?
A modified zeal.
Why modified?
It is
What is the modification made? Compared to the original zeal which is used for young tuberculosis, what is the modification made here? Is it the fixation or something else? Anybody from audience? Please. Concentration of sulfuric acid, that is 5%, not 20%. Because M. leprae is weakly acid fast compared to the M. tuberculosis. Okay. What else you can use instead of sulfuric acid? 1% acid alcohol. Okay, that also can be used. Hydrochloric acid. Hydrochloric acid. Alcohol, 7%. What do you use in biopsy to stain for the AFP?
Can you use 5-ferroxostate?
5-ferroxostate. So in histopathology, someone was mentioning in the morning, Grenz zone. Okay, when you start seeing the Grenz zone, there is a little bit of confusion in the literature also here. You see, like Grenz zone, some books have mentioned it is seen in Lepromatosis leprosy. Is that entirely true?
So it can also be
Seen in from where? Not in other diseases. In leprosy, where you start seeing it. In borderline tubercular leprosy itself, you start seeing that. After whom is it named? Grenz?
It's a German word meaning borders.
Very nice. That's correct. That's for international border. It is not a person after whom it is named. It is named after a land. See, if you see international border, I'll give one example. Wagah border, India, Pakistan. There are two gates, Indian gate, Pakistani gate. In between, you see a space. That space continues in the entire border. There are two fences always. So that land which is between the two borders, between the two fences, that is no man's land. That doesn't belong to any country. It's an international border. That is what is known as Grenz in German. Okay? So it is named after that zone. That is exactly how it looks between the epidermis and the infiltrated zone in biopsy of the histopathology of the Hansen's. Okay? That's why Grenz zone.
In the course of treatment, what do you expect to occur with you? What are the good things? What are the bad things? What can occur?
The good things, the patient, the lesions will improve. The first is the nasal stuffiness to improve. Then also we have to keep a close watch for upgrading reaction.
Did you tell him about anosmia or anything? You take the history?
Yes, sir. Only nasal stuffiness, he didn't give any. We have to keep a close watch for upgrading reaction, which could present with neuritis, and that has to be treated.
How do you test for quiet nerve palsy?
Sorry, sir.
How do you test for quiet nerve palsy?
By nerve conduction.
Okay. Anything else? Any bedside testing?
By SW fluids.
Yes, expand that, please.
Semis based
Next. Okay, fine. I think we don't have time. We will wind up.
In the lepromatous board, we have destroyed Hansen's. We have Lucio leprosy, Lazarine, Latapi leprosy, pure neurotic Hansen's.
What is facies leprosa?
Facies leprosa is more of a radiological finding where we get nasal spine.
So that is distinct from leonine facies. Okay. So that is consisting of
nasal and maxillary spine involvement, which leads to the flat nose and weakening of the teeth.
okay. Basically, what's the full name of this? Christian Muller.
Christian Muller.
And you should also, of course, you should know the other causes of leonine facies for everybody will be aware of that. Yeah, thank you. Yeah, please. Continue.
Dapsone is not used. What else you will replace? Propylene is not used. What else? Rifampicin is not. If the patient is sensitive, then what else you use?
Yeah, one is if the patient is sensitive to any drug. The other is if the patient is resistant to any drug. How to replace with the other regimens. Okay.
Okay, so tell me also one more thing. What is flu-like syndrome to rifampicin?
So flu-like syndrome, we can see in rifampicin in case of intermittent dose. In the flu-like syndrome, we can see fever, chills, joint pain, and usually it will occur after 1 to 2 hours of using rifampicin, and that can see up to 8 hours.
Good. Yeah, thank you.
Thank you, Dr. Neha and Dr. Pradeep. Now I call upon Dr. Sidra Rana and Juki Fatima Sultan from Deccan College.
Good afternoon, sir. I'm Dr. Juhi Fatima Sultan, and this is my colleague, Dr. Sidra Rana. We are from Deccan College of Medical Sciences.
Explain.
You can carry on. Can you take a pointer also and tell?
In the picture here on the left, we see that there are multiple erythematous.
First of all, tell it's male or a female.
The female, sir.
Okay.
And we see the multiple erythematous papules. Multiple erythematous papules and multiple pustules, which are grouped over the cheek area, and it shows a little bit of surrounding erythema and edema as well.
That's all. You can't say anything more.
We also noticed that the mandibular, the chin area, the mandibular area has multiple thick, dark hair growth, indicating hirsutism.
Anything else?
A few comedones, open comedones or black comedones, black hairs are also seen.
What is all that? Can't you see many depressed areas also in
Yes,
between?
multiple scars are also seen, sir.
Yeah. Okay. So what's the diagnosis?
So looking at the characteristic pleomorphic lesions and the presence of comedones, it seems like a case of acne vulgaris.
That's all. You said something else also.
And scarring with hirsutism also, sir.
Yeah, hirsutism. You should mention with hirsutism also.
Yes. Grade 3, sir. Most likely grade 3 because of the predominance of the pustules.
But what I feel is, I feel that there are some nodules also there. It's not only papules, there are nodules.
Yes.
So I think you'll go to grade 4 acne, not the grade 3. See some of them. Oh, show your pointer.
Yes, sir.
Show your pointer. Yeah, that these big ones, nodules surmounted by pustules.
Yes. In the picture on the right, there are more of the larger lesions which appear to be deeper as well, indicating nodules and a few pustules also. Yes, cystic lesions indicating grade 4 acne because of the nodulocystic lesions.
Nodulocystic acne. Okay, how do you proceed in this case? How do you proceed to treat this case?
Sir, since apart from the acne, we also see hirsutism, here it would be better to look into other complaints or any other symptoms and signs that the patient has and consider doing different investigations to look into the underlying cause for the acne and if any endocrine problem.
So what would you do, I'm asking?
Yes, sir. Investigations.
What you do see clinically, what you will ask, investigations, and how you come to an inference, and then the management starts. Isn't it?
Yes.
So clinically what you are looking for and what is investigation you would like to do.
Yes, sir. Firstly, the patient should be asked the history of any other signs of hyperandrogenism like hair loss or since when she developed the hirsutism or hair on the chin area. Apart from that, any irregular menses and any other signs of virilization, if at all present, should be asked, like deepening of the voice, a muscular habitus, breast atrophy, etc. She should also be asked regarding the duration of these lesions and if she has applied any topical agents or taken any treatment for the same. And
the leg would like to see?
yes, the posterior aspect of the neck, any darkening indicative of acanthosis nigricans should also be looked into.
Would you like to see her weight?
Yes, sir. Also in her examination, her weight should be seen and
BMI?
yes, sir. BMI.
Body mass index?
Body mass index should be looked into.
Next.
And signs of ovulatory dysfunction should be asked about in the history. Any irregular cycles, any increased duration between the cycles indicative of polycystic morphology should be asked.
Next.
The age of the patient is also significant, sir, since if this is an older patient and with persistent or adult onset acne, they should be looked.
By the way, what's her age? What do you think her age would be?
A young adult, sir, most likely.
You can't say, we can't make out.
So, what's the significant age cutoff? You are
Yes.
mentioning like older. What
Yes.
is that? Cutoff age.
Above 25 years of age.
So up to 25 it is?
Acne vulgaris or the physiological
After that you consider it as?
adult acne.
Adult acne.
Or acne tarda.
Acne tarda. And how is it divided into two different types?
So if the lesions were pre-existing or the acne has continued from before and beyond 25 years, it's persistent adult acne. And if it has started for the first time after the age of 25 years, that would be adult onset acne.
Okay, so you mentioned androgens as one of the important etiology for this.
Yes.
So what are the overall etiological factors for acne?
So the four major pathogenic factors in acne would be androgen-induced sebaceous dysfunction or hyperplasia and increased sebum secretion. The second would be the follicular hyperkeratinization and retention hyperkeratosis, followed by microbial organisms are also significant like Propionibacterium group and the inflammatory dysfunction. So Cutibacterium acne, yes, and the inflammatory cascade. Yes.
Okay. So you said inflammatory cascade. You are seeing like a mix of lesions in this photograph, like some comedones and many papules and pustules and all.
Yes, sir.
Which inflammatory factors do you associate these lesions with?
Sir, the interleukin-1 alpha seems to be the initial interleukin which induces the microcomedone formation and ultimately the macrocomedones which are formed from those. And the inflammasomes which are associated with interleukin-1 beta are associated with the papules, pustules and the further lesions. Also there is role of interleukin-2 and interleukin-8 and TNF alpha, interferon gamma.
Okay. So what is the mechanism by which the P. acnes or Cutibacterium acnes induces inflammation?
It will act to tolerate histopathology and upregulate the inflammation factors and the introduce chemotaxic factors. So there will be neutrophilic infiltration which causes phagocytosis of the Propionibacterium acnes and releases proteases which causes the breakdown of the follicular wall and lesions start developing.
Okay. So if you want to ask any predisposing factors in this patient, which predisposing factors would you like to ask? Sir was asking what else we'll evaluate. So you left out the complications. Okay.
And dietary factors.
Dietary factor, which diet you?
Patient should be asked about high glycemic index of milk and cheese requirement in the diet. There should be
How does milk aggravate acne?
the insulin growth factor minus more in milk, which causes increases sebaceous gland activity. Apart from that, there is low omega-3 fatty acids.
Any action on the hormones also?
So the iodine content is also insulin like growth factor production is also increased. Based on the age group, the acne can be classified as neonatal acne, infantile acne, mid-childhood or childhood acne, pre-pubertal acne, then the physiological acne vulgaris of adolescence, then persistent acne, adult acne, and senile acne. Then based on the various precipitating factors, there can be acne mechanica, there can be radiation acne, there can be acne cosmetica, acne medicamentosa, that is medication-induced acne, acne tropical acne. Pomade acne is a type of acne which is due to occlusion due to the thick pomade creams that are used in the hair to straighten them and make it manageable, and that causes occlusion. No, so African American races more commonly, and that tends to occlude the pilosebaceous unit and result in increased precipitation of acne.
Any other variants? I think there are a lot of other variants also.
Acne estivalis.
Okay, acne estivalis is what?
Acne estivalis is the one which is seen more on the trunk in the spring season and summer seasons.
Okay. Anything?
Acne fulminans, acne conglobata, acne excori, and
what is acne mechanica?
acne mechanica, sir, is due to the mechanical occlusion by different devices like helmets or turtleneck clothes.
What is McDonald's acne?
Junk food, probably.
You don't know. Junk food. No, it's not that. The people who work with this
hot humid climate.
no, not hot humid. In the kitchen, no ventilation. If you see the ceiling, it is full of oil. That thing comes on your face also. So it is seen first in those people. That's why it is known as McDonald's acne. Oil.
Oil.
But oil.
Detergent acne. Detergent acne, chloracne also medicine.
And one more thing, you didn't tell about ultrasound. For this case, hirsutism, ultrasound.
Ultrasound is very important
So,
to diagnose PCOS.
Which ultrasound do you do? You do para-abdominal or something else?
Preferably transvaginal will be get better results.
What is the criteria to diagnose?
Rotterdam's criteria, sir, for PCOD. It consists of the 2 out of 3 in the criteria should be fulfilled to be diagnosing it. First is clinical or biochemical signs of hyperandrogenism. Second is the radiological criteria via ultrasound, where there should be at least 12 or more 2 to 9 millimeter in size follicles or 10 cc volume of the ovary, 1 or 4. Recently it has also been suggested the number of follicles has been raised from 12 to 19 and now in 2021 to 25.
25 is the latest one.
Yes.
So what are the hormones you do?
So initially testosterone, free testosterone should be...
You do free testosterone, are they doing it?
Yes, sir. Total
It's
testosterone
such a
is
small quantity. So you do the extensive. What do you do? What do you do?
total testosterone levels, sir.
Free androgen index.
She also, yeah.
You do the free androgen index. You know the free androgen index? You should see the total testosterone and you should see the sex hormone binding globulin. Divide these two into 3.47, I think. Then you get something. And it should not be high. If it is high, that means basically your testosterone may be normal, but if the sex hormone binding globulin is less, then the effect of free testosterone will be more. So you have to balance both and see. You got it? Got it? Okay.
Differential diagnosis of
Apert syndrome, Harper syndrome, Sappho syndrome, backlash syndrome, and PCOS, Sappho syndrome, and Hayran syndrome.
the differential diagnosis is classical, but only few lesions are there in the face.
Corticosteroids, anti-androgens, hormonal therapy, and anti-cancer medications. Anti-epidermal growth factor inhibitors, anti-epileptic,
So tell me one vitamin which can cause acne. Suppose B12 you given high doses, especially the diabetics, people come with all the neuropathies and all. You get so if you want it, how will you? What do you tell them? What do you tell them? If you stop B12 for 10 to 12 days, then the acne goes away. If you wind up.
We are asking that. DDF.
Take the diagnosis. The various differential diagnosis could be either lesion-wise. In general, for the papillopustular lesions, rosacea, perioral dermatitis, folliculitis, folliculosis, lupus nephritis, disseminated facial. And for the comedones, differential diagnosis could be the dilated core of minor nevus sebaceous, also senile comedones or Fabry Ricochet syndrome.
Nevus sebaceous?
Comedones.
Okay, right, okay.
Nevus comedonicus, sorry.
Okay. Nevus comedonicus, yes. Nevus Gaddison is somewhere on the scalp. Okay.
Media, colloid medium. Scars seen can be divided into macular, hypertrophic, atrophic. In atrophic scars, the common ones in acne are ice-pick scars, box scars, rolling scars, and macular erythematous, macular hyperpigmented. Hypertrophic scars will be hypertrophic, keloidal, ridging scars, and papular scars.
What is ice-pick?
Ice-pick are V-shaped scars.
No, but what is ice-pick?
Ice-pick, what is that?
No. You climbed a mountain and you climbed. So you hit it into the ice like that and pull yourself up so that you don't slip. It's like this pointed with a handle. Okay. So that's the thing. The scar is deep like this.
What is the best corrective method for that? Ice-pick scars, last question. TCA cross.
What is cross?
Into the mic. Into the mic.
Chemical?
Construction of this.
You said restoration.
Okay, done. Yeah, thank you.
Thank you, Dr. Sindra. and Dr. Judy. Now I call upon Dr. Srija and Dr. Sindhu from SVS Medical College.
I'm Shrija. This is Sindhu from SVS Medical College. Here we can see multiple smooth, circumscribed patchy hair loss over the vertex region.
Patchy hair loss you cannot say. You should just say patches of alopecia. That's it, finished. Patchy hair loss, because patchy hair loss is one of those special skin regions. Now you say macular papular and all. Alopecia is loss of hair. Patchy alopecia is loss of hair, you not say.
Multiple alopecia patches over the vertex regions. And there is multiple hypopigmented marks.
Is this vertex or this is something behind the vertex looks like?
Above the occiput and parietal region.
You can say parieto-occipital region and the lower occipital region, but I don't see anything on the vertex. Is anything on the vertex? I don't know.
That's still beyond.
Okay, right, that's there. Okay, right, okay.
What's the diagnosis and differential diagnosis?
This is alopecia area. Differential diagnosis can be non-inflammatory type of tinea capitis and trichotillomania, sir. Friction alopecia, traction alopecia, and congenital triangular alopecia. Cicatricial alopecia, follicular plucking is not there.
Can it be secondary syphilis? Secondary syphilis?
Morty could be secondary syphilis.
So how would you proceed further? What's the next step? Now you're seeing this. What's the next step? How old is this boy? Is this boy? I don't know how old he is. Anyhow, okay.
If there's any scaling, KOH can be done, sir. And hair pull test should be done from the border. Dermoscopy can be done, sir.
But suppose that would you like to examine for something, simple examination.
For exclamation marks.
Hair, okay.
Exclamation mark, exclamation hair.
What do you mean by exclamation mark hair?
There is thickening at the distal end, thinning of hair in the scalp side, sir. Approximately.
There's another sign also.
Cordability sign.
Cordability. What do you mean by cordability sign?
There is a kink at the proximal end of the hair follicle at 5 to 10 mm on pressure, applying pressure at the terminal end.
Okay. So what these two go in favor of which condition?
Alopecia areata, sir.
Alopecia areata. Okay. Next, what is the other thing you can see do over here? Yeah. Okay, tinea capitis. What type of tinea capitis?
Non-inflammatory type of tinea capitis.
Okay. Non-inflammatory type. What do you get on the? You get what? Black dots. Black dots. Variety. Can you see any black dots? Can you see? Because the hair gets broken off at the level of the scalp, falls off, so you get black dots. It's not there. Okay. But is this scarring? No, it is good. Is this a scarring alopecia or non-scarring alopecia?
Non-scarring alopecia.
Why do you feel it's with this figure, now it is so close, magnified, why do you say it's a non-scarring alopecia?
There's no follicular flubbing, sir.
No,
No follicular.
The reverse, go ahead. Yeah.
We can see some follicular.
You can see
problems.
follicles. You can't follicular problems.
Lots.
In fact,
Clearly
follicular ostia are built so well.
Yes,
So it is scarring or non-scarring?
non-scarring.
Okay. Yeah, good. Let's assume that it is alopecia areata. Okay. What is the type that you are seeing here? Okay. What are the different varieties of alopecia areata?
Reticular and
Okay. You said Sisaico. That's the reverse of it.
Reverse of
Okay. Okay. You said perineoid also. Linear you said. Anything else? Any later variants? That is the reverse of that is Sisaico. Okay. Fine. So one more. Acute diffusing total alopecia. That is another rare variant similar to alopecia areata incognita. Okay. You said alopecia reticularis. Reticular alopecia also you said. Are there anything with respect to extent of hair involvement, scalp involvement? Are there any variants? Okay. Patchy is also known as alopecia localis because of that limited number of patches. Okay. Then. And subtotalis. How do you define subtotalis?
70% of scalp.
Yes, that's correct. So more than 70%, but not the entire scalp. Right. So, what is the prognosis in various types of alopecia areata?
In patchy type it is good, sir. In opiosis pattern it is poor prognosis, and in case of early onset of alopecia and associated with atopy and family history of alopecia, these are having poor prognosis, sir.
Okay.
And associated other autoimmune diseases, these varieties having poor prognosis.
Okay, something you were saying Ikeda's classification.
Yes.
Can you say that?
Ikeda's classification is of 4 varieties, sir.
Okay.
Atopic.
What are the most common?
Common type,
Common
sir.
type.
Next atopic and autoimmune and prehypertensive type, sir.
Okay, right. What do you mean by prehypertensive?
It is seen in
Mean by
parents are having hypertension, sir. They are predisposed to have hypertension.
So maybe we become hypertensive later.
Later. Yes, sir.
suppose it is alopecia subtotalis, totalis. Do they respond to same extent like your localized? You said that they poor response. So what are the treatments of choice for alopecia totalis?
Alopecia totalis, we can go for systemic corticosteroids, sir.
Okay.
And also
What the new something?
JAK
Yeah, what is it? So which one?
Stochastic.
Which one is approved for alopecia areata? Anything is approved? Baricitinib. Very good. Very nice. Baricitinib is approved for alopecia areata. Okay, FDA approved. But of course, you have tofacitinib. You also have ruxolitinib. Okay, along with baricitinib. Which receptors are inhibited by each of these drugs?
Tofacitinib, one is JAK1 and JAK3, sir.
Okay,
Whereas baricitinib, JAK1 and 2, sir. And ruxolitinib, it is JAK1 and JAK2, sir.
And also TYK also to some extent. Okay, right, fine, good. So topical tofacitinib is available?
Not in India, sir.
What is it we used to do for alopecia totalis before this tofacitinib came? Any topical? Anthraquin is one good. Contact immunotherapy. Okay. What are the agents which can be used?
BPCP, sir. That is
What is that?
cyclopropylone.
Very good.
And
You can give chance to her also.
acid,
Okay, very good.
and also dinitrochlorobenzene, sir.
Okay. Which one is outdated now? Why? Okay, fine. What is commonly used now? DPCP. Why not SAPI?
Because of its safety and its stability, sir.
Very good. Okay. How do you apply? Method of application. What is the protocol known as? Name of the protocol?
Apples.
Apples protocol. Okay. Okay. Good. Okay. What is the antigen? 9 treatments. 9 treatments. Topical treatment.
as a topical minoxidil and oral mini pulse therapy with the betamixone and
Topical steroids can be given, minoxidil can be given, and Cuba therapy can be given, and eczema phenotype, and
eczema laser and
intralesional steroids,
ILS
PRP can be tried.
mesotherapy.
You want to do PRP for
But okay, then how do you introduce steroids for alopecia areata? Yeah.
Yeah, I was coming to that question. It's very important question.
Very important.
Suppose the child is less than 10 years. About 10 years you will easily give. Okay? And sir, you will have to answer, sir, how will you give intradigital corticosteroid even for an adult? What is the method? How much dosage and all? Tell me.
So pediatric patients we can
Next, first come to sir's question. Adults, how do you give?
triamcinolone injection should be given.
How much percentage? Strength.
5 to 10 mg per
Same in all areas, site-wise and difference.
Base 2.5 mg per ml.
Okay, scalp.
5 mg.
Okay, 5 is better.
Okay. How much do you inject?
0.1 ml per size of
Per square centimeter. Per square centimeter. Okay.
And how do you inject? For example, this is here. Where is the needle point? Inside, outside?
Intradermal, sir.
Where, how did it point? For a keloid, it has to point inside, and for alopecia areata, it has to point outside. Otherwise, the whole keloid will go to the middle and it will cause atrophy. In keloid, you want atrophy. Here, you don't want atrophy. You got it? Understood?
Yes.
In children less than 10 years, is ILS indicated? Can be given. That's why I am telling you. Okay? Can be given how?
With xylocane.
Yes. Under EMLA, but that is not the first option. Okay? Because injection phobia will be there. Okay?
Then what the steroid you use?
Clobetasol diclofenac 0.05 per
yeah.
For children, it is mometasone puree 0.1% or fluticasone acetate 0.05%.
Are you sure?
Fluticasone acetate 0.05 for children.
Children.
Because Catechant says use corticosteroids for alopecia areata on the scalp. So also for children.
What is immune privilege?
Immune privilege is a site, lower part of the hair follicle site, sir. It, because of down regulation of MHC class 1 and there is autoantigens, melanocyte releasing hormone 1 and transforming growth factor beta that protects the hair follicles.
Okay, that is down regulated. That immune privilege collapse will be there in alopecia.
Why they can these people gray overnight?
Yes,
Could be
sir.
2-3 days. Why?
Alopecia, it affects hair follicle melanocytes. So, in case of gray, that means both pigmented and non-pigmented hair persons, when they got affected with alopecia, pigmented hair got affected, sir, and overnight only white hair will be there.
Is that known as?
Going white overnight, also known as Canitis subita, Mari,
Antoinette syndrome. Antoinette syndrome. Okay. Is there any counterpart of it when the lesions start regenerating after the treatment is used? Do they develop white hair
As the
initially?
first they develop, later they may become pigmented, sir.
Okay, so that is known as heterochromic hair. Okay. Acquired poliosis, another name for it. Acquired poliosis. That can be. Okay, fine.
So after you give these injections, what do you see? There's improvement. How do you know that there's improvement? What do you see initially?
First, hair fall decreases, sir.
Initially see villous hair, and then they get little whitish, then they gradually get terminal and pigmented.
Few questions to the audience. Trichoscopic features of alopecia areata. Sorry? Get a bit answer, please. Who wants to answer? Fast, please. Yeah. Yellow dots also. Okay, what do the yellow dots correspond to? Okay. And also the sebaceous gland, okay, because the follicle is empty, okay, right. Then black dots are also known as cadaver hair, okay. What is tapering hair? What is eye hair? Heard of it? No. Eye hair. Is it the chapter? If you have read the new chapter, you will know. It was there in some remote article, so that has featured in the book also. You please go back and read. I will not tell you. Okay? That's why. They'll have a surprise also when they see that chapter.
When you see the chapter, you'll be surprised. You'll see who the author is. Okay? What is the maximum dose of intralesional steroid you will give?
20 mg per sitting. Max. 20.
So how many 20 milligrams means? How much would be the volume?
Volume is 10 mg per ml, sir. So volume 1 ml has 1 mg, sir.
No, how much total means how many times you will have to drink?
20.
It is said
20 times. The 0.1 ml has 1 mg.
it is said that 5 basically you should give more than 3 ml of 5% as per Canada. Okay. But I know 20 ml it's a relative thing. Canada has Which congenital abnormality is associated with alopecia areata? Which congenital abnormality is associated with alopecia areata? Pardon? Huh? Down syndrome. Good. Everybody knows this. I think there's no need to say the diagnosis. Still, any audience person can get up volunteer to answer some questions you might like. Please focus that slide. Spotter. Yeah, this one. Spotter. Anybody volunteer? Quickly, please. If you want to answer, you can. Anybody? Audience. So that we had already asked, sir. I think there was nobody to volunteer for that.
From Chelmada, nobody came.
If any two people want to come here, they can. That's what we are all requesting for. Those who are not participated in the month since morning. Yeah. This is not exam. We are not going to fail you for this. But it's only going to be interactive and learning session. That's all. Okay, fine. I think we'll continue with the questions. If nobody else is coming forward.
I think you just ask the audience.
Audience, that's what I can do.
Audience will throw the questions, sir, and then ask.
So that was, what was that? Shall I ask people to get up? I will pick up and at least identify. Just identify. Linear? Yeah, please get up.
Can you stand up and tell, I am from this college, and then tell your name, your college, and then answer.
Dr. Neha Gavan from Gandhi Medical College. It's linear epidermal verrucous.
Okay. Or verrucous epidermal nevus, both same, linear. Okay, fine. What What is the distribution like there?
Flash point.
Flash point. Okay. So how does it result from? What is the mechanism there? Someone said?
Because of mosaicism.
Mosaicism. Yeah, Umul, please. Please get up and answer. What is mosaicism?
You identify yourself, please.
I'm Dr. Umul Khair from Deccan College of Medical Sciences. Mosaicism, that is mutation, it is presence of two different cell lines in a single individual, which occurs due to mutation.
That is two different cell populations arising from two different zygotes, which are fused together. Okay? So chimerism results in pigmentary anomalies. There will be pigmentary differences. Whereas mosaicism results in most of the blastoid nevoid conditions. Okay? What is the nevus? Anybody can give correct definition of nevus? Then we'll come back to blastoids again. Correct definition of nevus. One of the older editions of Rook used to have this definition. I think the new edition I was disappointed not to see that. So it is defined as benign, fixed growth or neoplasm, that is benign or non-neoplastic fixed growth which occurs at birth or soon after birth, resulting from genetic mosaicism. That is a complete definition of nevus. So I repeat, so it is benign, non-neoplastic, fixed fixed growth occurring at birth or soon after birth and resulting from genetic mosaicism. Okay, right. Blastoids we mentioned. What are the other?
It's linear,
Versus vegan? Inflammatory. Okay, fine. Okay, any other nevi? It's okay. Right, yeah. What are the patterns of blastoid lines? Yeah, please get up and answer. Someone is answering correctly. Please, sash-like and one more is there, no? Sorry? One more is there, which crosses patchy, which crosses the midline. Okay, that one type which crosses the midline also. Okay. Like I have two more questions. Right, I think sir is saying we can close here. Okay, we'll go on to the next session.
I call upon Dr. Nayaz and Dr. Farindra to present on genital ulcer disease, short case from Usmania Medical College.
Good afternoon, everyone. This is Amphani Kumar from Usmania Medical College, and my copy Niyaz. We are from Usmania Medical College. We are here to present the genital ulcer disease.
Just start.
Right, start. A 45-year-old male studied till second class, driver by occupation, resident of Airport, came with a complaint of raw area over the genital since 2 months. Next. 45-year-old male studied till the second class, driver by occupation, resident of Hyderabad, came with the chief complaint of raw area of the genitals since 2 months. Next step.
Is it Telugu speaking or Hindi speaking? Yes, ma'am. Telugu speaking? So what did he tell? Raw area means what did he say? Huh?
Full eye.
Full eye. Okay, right.
History of present illness. Patient was apparently alright 2 months back. Later, he developed tiny red raised lesions over the penis, which got eroded in 2 days, leaving raw area and gradually progressing to the present size, and not associated with itching, burning, or pain sensation. Next. No history of any urethral discharge, no urinary complaints, groin swelling, or no fluid-filled lesions, no history of skin rash or joint pains, or no history of fever, no history of receiving drug intake or applications of the medicines. Coming to marital history, marital life is 27 years, and they are blessed with one female child, and last sexual activity with female was 2 months back, and unprotected and phenovaginal. Coming to history of exposure is present. There is premarital exposure 27 years ago with two known females, unprotected and phenovaginal. Right? There is no history of extramarital exposure.
Just go back, please. Yeah. Premarital exposure. Read this one.
Premarital exposure 27 years ago, sir, with 2 known females, unprotected and phenovaginal.
Does it really matter now? Does it really matter? 27-year-old. It does matter. I tell you how it matters. That is one thing. Okay. What else it matters? It shows the promiscuity. That's all. But actually, scientifically cannot produce probably this kind of ulcer as of now. Right. But you said
there is no history of exposure at present.
I have a problem with that. It will not say no history of extramarital exposure. It will be denying history of exposure. That is what you can say. Okay, not history of exposure. The first sentence points towards the promiscuity, so you should always take it with a pinch of salt. And it denies.
Next slide. Past history, no history of similar complaints in the past, and known case of HIV since 25 years, with the latest CD4 count of 955, and on antiretroviral treatment, that is TRT regimen, and not a known case of TB, hypertension, or diabetes mellitus, or ischemic heart disease, bronchial asthma, or drug allergy. There are no history of blood transfusions or IV drug abuse. There is no history of major medical or sexual illness. And family history, wife is RBD positive and on ART since 10 years, and child is RBD negative. Check on general examination. General conditions like patient is conscious, coherent and cooperative. No pallor or icterus or cyanosis, clubbing or edema, and no lymphadenopathy, mental, submental or occipital or cervical or supraclavicular, axillary or epitrochlear. Vitals are normal. And local examination. Coming to inspection. Single well-defined ulcer present over the mucosal surface of the prepuce of size 4 by 3 centimeters, approximately, with a red granulation tissue over the on palpation, non-tender, ulcer is non-tender, with thickened area.
Have you actually measured?
Yes, sir. Approximately 4 by 3.
Is it 4 by 3 centimeters? 4 by 3 is what? Not that big on the photograph.
On palpation, no inguinal or femoral lymphadenopathy, and
palpation read once more, please.
Sir?
Palpation read once more.
On palpation, the ulcer is non-tender with thickened edges and bleeding on manipulation, and no inguinal and femoral lymphadenopathy. Doriflox and this is the
Dr. Ramdas sir and Dr. Subhashan Reddy sir to chair this session.
Just go one step back. Just go one step back. Give a sign. For the sake of everyone, again once more.
on inspection, single well-defined ulcer present over the mucosal surface of the prepuce, size 4 by 3 centimeters approximately, with red granulation tissue over the. On palpation, the ulcer is non-tender with thickened edges and bleeding on manipulation, and no inguinal or femoral lymphadenopathy. Dorifloxacin is first.
Dorifloxacin.
Dorifloxacin.
Also known as lapsing.
And this is the clinical measures showing the ulcer over the mucosal surface of the lips.
Describe the ulcer with a pointer.
There is an ulcer over the mucosal surface of the prepuce with well-defined edges and clean granulation tissue over the floor, measuring about 4 by
4 into 3, na?
4 by.
But that's too big. I think it's smaller than that. Yeah.
See, what is the size of gland pens, by the way? I mean, this is 4 by 3.
No, but where is the bleeding? I don't find any bleeding here.
On manipulation it is bleeding.
Okay.
Next. Perineum is normal and scrotum normal and display sensations are present.
Can you tell me what is perineum?
The area between the anus.
No. No. What are the boundaries of the perineum? No. It is from the pubic symphysis anteriorly to the coccyx posteriorly. On either side you have got the ischial tuberosities. So that diamond-shaped area is the perineum. Okay? So when you're talking perineum normal means that whole area is normal. How can it be normal? On the penis, penis is part of the female genitalia and the penis is part of the perineum. How can it be normal? It cannot be normal.
Scrotum is normal, testicular sensations are present, perianal area is normal, palms and soles are normal, nails are normal, oral mucosa is normal. Systemic examination, all systemic examination was normal. There was no organomegaly or any CNS symptoms. Differential.
First tell your provisional diagnosis and then differential diagnosis.
Provisional diagnosis we considered first as primary chancre because it is painless, 2 months of duration. Then we considered zoonoses.
That is differential diagnosis. Provisional diagnosis what?
Provisional diagnosis zoonosis.
What are the points? What are the points against primary chancre of syphilis?
Bleeding on touch, no inguinal lymphadenopathy on examination. You can say primary chancre.
So that is the order we have thought of. That is the order we thought of. First I think of mononosis, then penile malignancy, next primary chancre, or you want to reverse it?
First you have to mention primary chancre.
See, you have to mention He is also an HIV positive patient, no?
Yes, sir.
In provisional diagnosis only you say primary chancre in a patient, RVD positive patient. First should be primary chancre, then donorsum, then penile metastasis.
As far as the history of exposure, you have to just deny history of exposure because that cannot be taken as no history of exposure in the last 3 months incubation period. It's very much possible. And also, if there is a malignancy, the borders of the lesion are wrong. Like if you take a look at benign rather than malignancy.
What diagnosis? Your provisional diagnosis.
Our provisional diagnosis was first primary chancre in an RVD positive patient.
What are the points in favor of primary chancre?
Painless ulcer, Dory-Block sign present, no lymphadenopathy.
What is the type of induration you get?
We have button induration.
Usually, primary chancre heals within how many weeks?
6 to 8 weeks, it will heal without treatment.
It should heal without treatment.
Without.
But it is already 8 weeks.
It is not treated.
Why do you think it is not healed?
He said, beats are manipulation, not untouched. Manipulation means a hard pressure. Anything
Anything will bleed. Do not manipulate. Okay, that is okay. So, video test done?
Yes, sir. VDR test done.
Done.
VDR and PKH are non-reactive, sir. HBsAg and HCV are non-reactive. Zyme smear was negative for multinuclear cancers. All routine investigations were normal. On tissue smear, it was positive for the number of donor bodies.
That's right. Okay, nice. Okay.
Did you do a DGI?
No.
Why?
They don't have it.
It's okay. They would have facility. DGI was not done.
Not working.
Not working.
And that's good. Okay. So this is positive for donor bodies.
Donor bodies.
You can revise the provisional diagnosis.
Provisional diagnosis, donor.
Okay, donor analysis. So donor analysis, can it come without sexual exposure?
Very rare, sir. Usually sexual history will be history of exposure will be present, sir. Within the incubation period, they will get, sir.
What is the increase rate for this?
It is 1 to almost 180 days. It can up to 6 months.
the history of exposure of this thing is subjective. Actually, as he said, he might have denied.
It's denied.
Okay.
But here it looks like primary chancre, that discover lesion.
So it's exuberant ulcer of approximately 4 by 3 centimeter with thickened edges, which was bleeding on touch. There was no indication on palpation.
Usually primary chancre, ALS also and primary chancre also, donorsum also.
Yes, sir.
Usually this.
Leprologists will be present in syphilis and they will be absent in donorsum.
Both. Even only painful ulcer in only chancre. Soft sore. Here is the hard sore, primary chancre. In donorsum also, the painless ulcer. Injuries also is there. So what is the primary chancre is syphilis? What is the incubation period?
9 to 90 days, sir, for syphilis.
What is the Dory-Block definition?
Dory-Block, if an indurated lesion is there in the mucosal surface of the prepuce, on retracting the prepuce, there will be the prepuce will retract with a sudden flap. It is known as the Dory-Block.
Kissing girls also? Kissing girls.
Kissing girls is most commonly in childhoods.
That is chancre.
How you have done smear the tissue smear from donor body?
Actually, we have taken a tissue from the ulcer, then we have pressed it between the two slides, then we stained it and with the James stain, then we visualize it another at 10x and 100x. This is the picture in 100x.
Okay, very good. Well, is it gram positive or gram negative?
Gram negative, sir.
Can you describe this?
So it is on the slide showing keratinocytes with the number of intranuclear body eosinophilic.
Is the keratinocyte?
Macrophages.
Yeah.
Macrophages.
Yeah.
Macrophages with.
So what are these cells known as? These macrophages?
green bars or Donovan bodies.
Inside that you get these
Donovan bodies.
how do they look?
Bipolar or safety pin appearance will be there. So
Close to safety pin, not an open one. Close to safety pin. And now what you're seeing over here is it's a big macrophage with multiple bodies within that. And these are also known as Pund cells.
Pund cells.
So green black or Pund cells. What is green black sign?
It is seen in infogram.
Don't get mixed up with these two. Okay.
Right. When inguinal and femoral lymph nodes both are involved, we can see a groove between
Which was the venereal disease which was first discovered in India only? Who was the person who discovered it?
In India. That examiner will come, if he comes, he will ask Madras, any person comes from Madras?
Tajam and Rangaya are.
No. Donovan. This is name itself. Donovan says, scientist name Donovan.
Monograph.
What are the complications if we don't treat?
Stenosis is one thing, sir. And there will be amputation of the appendix and rectovaginal fistula.
Complications. Auto amputation.
Paraphimosis and stenosis of the urethra and lymphedema. It is due to the granulation. The lymph nodes are not involved, sir, but there will be a granulation tissue which will cause the swelling of the inguinal region.
The infection passes through the undersurface of the skin, just like Telugu soft and nail. Like that, it passes through the dermis to present a new bubo at a nucleus. That is pseudo bubo, not pure bubo.
Okay, what is the principle of DGI microscopy?
DGI microscopy generally, in case of light microscopy, the main source will be the light. In case of a dark ground microscopy, it will not allow the light, but only few rays of the light are passed through the microscope. This will get reflected from the organism, so that only the object present can be seen like a
dark background, light current, the organism.
So what is the main difference between a normal microscope and a DGI microscope?
Generally, treponemes are very thin.
What is okay? Why can't you see that Treponema pallidum?
It's very thin, sir.
Through a light microscope.
It's very thin.
What's the thickness? Just 0.25. It's 0.25 micron. So you cannot see it under the light microscope. It is too thin. Like a thin needle, you put away, you can't see it. Okay. But what I'm asking you over here is, what is the main difference between a DGI microscope and a light microscope? What's the difference?
The contrast is different. Here, all the light is filtered off.
What is the main, what thing you have to put into condenser? It's the condenser. The condenser is different. Okay. Then one thing is, you should also do a DGI. So how do you ask for VDR? How do you ask for a VDR? You have to ask in an investigation, do the VDR test. How do you ask for it?
Actually, first
you ask, do VDR test, you just write VDR and send it off, or you write something. What is prozone phenomena?
Because of antibody excess, the test will come negative, sir.
So what do you write over there?
Dilution in dilution. In dilution.
To do it in serious dilution. What is VDRL?
Venereal disease research laboratory test.
Where is it?
It's in
Where?
Pune actually. Check place. Okay.
So, what are the extra genital sites for granular venereal?
So it can occur around the mouth, on the breast, face, around the anus, on the hands. Liver also it can disseminate, and bones also it can go with blood dissemination, it can go to bones also.
Originally it was discovered by a dentist. First it was discovered in the mouth.
Is condom shanked?
Condom shankar, it will occur at the hilt of the penis or the root of the penis.
Shankar gauges.
Shankar gauges. Scabies. Sir?
One more name for it. Shankar redux.
Shankar redux, recurrence of the shankar at the same sites.
What is superficial balanitis of foul man?
It is seen in the syphilis, sir. Due to the inflammatory reaction of the treponema pallidum, there will be superficial erosive balanitis.
What is the mode of treatment for granular management?
Azithromycin.
Local management and systemic
Management means first investigation, treatment. Not straight away.
In investigations, tissue smear and biopsy can be performed. It is very difficult to culture them. It can be cultured in head-to cell cultures. It can be cultured. Recently, PCR is also being done, but serology is not available. Then coming to the treatment part, local measures can be done, soaking and saline soaps and maintenance of the hygiene of the genital region. Then coming to the systemic antibiotics, we can give doxycycline 100 mg BD for 3 weeks. The other drugs which can be considered is azithromycin 1 gram once in a week for 3 weeks. Then previously the other antibiotics considered were streptomycin, chlorinoxazole, tetracycline, minocycline can be given.
How do you record this?
No, tetracycline can be given before, but doxycycline can be after diagnosis.
After food. It can be given
After food, yes.
What is the azithromycin?
Before food, 1 to 2 hours before food.
2 hours not required, 1 hour before.
Maybe that's it.
Therapeutic paradox.
After treatment in the region increases, therapeutic paradox. If in syphilis
Generally,
And classical example is there, you can tell that.
Because of our treatment. It is present on the vaginal walls. After treatment, the vaginal walls will be hidden. No possibility.
Decrease in the size of the vaginal introitus and the
Complete so must be careful. Dilators should be direction. Because of our treatment, even penis also after treatment,
it can be adhered to the scrotum.
So that is called therapeutic paradox. Because of our treatment, we are creating how long treatment? We told only 3 weeks. That we have to until the lesion completely heals. It takes about 3 weeks or 4 weeks. Continuously cannot give doxycycline. So, what is the other modes of treatment, other treatments? The organism should go up. What other treatment? Streptomycin.
Streptomycin 2 gram IM weekly can be given, sir, for 3 weeks.
For 10 days streptomycin. After that, doxycycline. After that, some change in antibiotic. 10 days, 4 weeks cannot be continue doxycycline. Systemic effects will come.
Erythromycin.
When you go for surgical intervention.
Erythromycin, azithromycin.
Actually, on follow-up, we did a biopsy for this patient, sir. On the biopsy, taken from the ulcer showing nested sheets of pleomorphic round to oval cells with particular to hyperchromatic nuclei, moderate amount of eosinophilic cytoplasm, few cells showing prominent nuclei with keratin pulse. There is mild mononuclear infiltrate. There are mitotic figures 3 to 4 per 10 high power fields. If the impression came out to be well differentiated squamous cell carcinoma.
That is one of the complications. That's it. On one side is ulcer, granular venereum, other side cancer. Mixed picture will be there.
The final diagnosis is progressive to cornerstone carcinoma.
What did you do to him?
Sir, we referred it to the cancer hospital. They have done extended circumcision of this patient, sir. 1 week back, the patient got the surgery.
Circumcision?
As it was in profuse, sir, they did not go for partial penectomy. They have gone for a saving procedure, genital saving procedure. Notes the negatives. Actually, on CT scan, they were minor.
No lymph nodes, sir. No lymph. On CT also. On CT also no lymph nodes are present.
Locally invasive only.
Yes, sir. Locally invasive. Only the subcutaneous tissue. No involvement of the corpus histopathology of the diagnosis. In epidermis, we can see multiple neutrophils infiltration, which can form the microabscess, and in dermis, we can see the mononuclear infiltrate, in which we can see two types of bodies, either bipolar bodies or the septic in appearance.
This patient is associated with the HIV also.
Epidermis will be thickened, sir. In case of if it is taken from the margin, you can see the pseudoepitheliomatous type of infiltration.
Why is it on the pseudoepitheliomatous?
In case of epithelioma, there will be same.
The very important point is patient first is the STD psoriasis. That's why he is getting the HIV. STD patients more times prone to the HIV. Here, patient is associated with HIV also.
That will be considered.
That's why that occurring the HIV infection.
That's why probably he is more prone to get malignancy also. Isn't it?
The history is also short, sir, like 2 months for this.
Okay, very good. Well done. Okay.
Thank you.
Thank you.
Because there are no volunteers, we cancel the instruments and drugs. Now I call upon Dr. Anup Kumar Lahiri sir to give an expert talk on laser overview.
Hyderabad population was on road today. It was very difficult to reach this place. So I would like to talk to you about the lasers in dermatology, and since most of you are the beginners or going to start your practice, I'll just give you a basic idea. And in the end, if you want to know something more, you can always query. And I'll also ask you something which you know how much on the lasers. And the trend nowadays is the moment you pass out and start your practice. There are many types of lasers which one can start using, but the thing is that the lasers which are commonly used and the cases which you commonly get, it is preferred to have that lasers in it because the laser equipments are expensive. It doesn't come cheap. So try to get the lasers which will come into use for your day-to-day practice. Now, the definition of laser everyone knows is a light amplification by stimulated emission of radiation. The whole thing means that there is an external source of power which stimulates the media, which is the laser media, to generate excited electrons, which when comes back to its resting phase will release the energy which comes out as a laser. So that is what is the meaning of this whole sentence. Now, the lasers are classified according to the media from which it is generated. So if it is from the gas like carbon dioxide, it's a CO2 laser. From solid, it is like KTB or the sapphire for NDI, and liquid like the tunable dye. So depending on the media in which it is generated, it is also named. Second is also it is characterized by the pulse duration of the laser. So whether it's a continuous wave one or whether it's a nanosecond Q switch one or it's a picosecond. So they are again classified according to the wavelengths or pulse duration. Now, when we are using the laser, we come across these terminologies, and many of us we just go with the terminology without knowing what it exactly means. Like fluence is the energy that the machine generates and which is delivered per a square unit. That is, we take it as square centimeter. So it is given as joules per square centimeter. And again, power is the same energy which is delivered in a unit time. That is second. So the power and fluence are the two important things one should know about when you are buying a machine. Because the higher the power of the machine, the better is the results you can get. Like you get a 30 watt power machine in CO2 or a 40 watt power machine. So if you have a choice, go for a 40 watt. Irradiance is, just for the definition's sake, it is the same power which is delivered in a unit time. And we always keep hearing of the word TRT, that is the thermal relaxation time. Now what is TRT? TRT is the chromophore, the laser's chromophore or the target tissue when it gets heated. It has to cool down when the laser is stop hitting it, and that has to cool down to more than 60% of its temperature, what it had raised to, and that is the thermal relaxation time. The thermal relaxation time is directly related to the size of the target chromophore. The bigger the molecule, the target, the larger is the TRT. Like The TRT for epidermis is 1 millisecond, the TRT for a hair follicle is 25 to 50 milliseconds. So that's the difference because of the size of the target. So TRT is important. Why? Because when the laser you are using, if you tend to put your fluence or the pulse duration more than the TRT, you are going to produce collateral damage, or you can produce scarring, pigmentation and all. So your pulse duration or the total duration the laser that hits the molecule or the target tissue should be less than TRT to avoid complications. TDT is the thermal damage time. Now, say I'll give an example of a hair follicle. So in the hair follicle, your primary chromophore is the melanin and the bulb cells. And the secondary target is the isthmus, stem cells and the isthmus and the dermal papillae. So normally the TRT use which is common. These parameters are common for any type of lasers you are using, and you should be, once you know what this means, you know you can manipulate that to get your results. Now pulse width or the pulse duration both means the same. This is the time the laser is hitting your target tissue. So this pulse width, the longer the pulse width, the longer is the target tissue being hit by the laser. The shorter it is. So this calculation you can do according to the what results you want to achieve. And the pulse interval is the interval between these two pulse widths. So you are giving one pulse, as you give the second pulse, the interval between the first and second pulse is called as the pulse interval. Now you can play around with these things. You can increase the pulse width, and also if you don't want to get any collateral damage, you can increase the pulse interval also. You want more damage, you can decrease the pulse width, decrease the pulse interval so that you can get a run of pulses. So that you get the same fluence, but you give a time for the tissue to cool down. So there is less damage. So these manipulations you can do between the pulse interval and the pulse width. Frequency is mostly like if you have a larger area to do, you keep a higher frequency. If you have a smaller area to do, you can do a lesser frequency so that you can, like if you want to do a freckle with a Q-switch, you can put 1 or 2 hertz frequency. You want to do a large KFL macule, you can put 5 or 8 hertz, depends upon what machine you are having. And fluence, as I described, is the energy that is being delivered. Now, many times the machines don't give a numerical value to the fluence. It is given as some alphabets, like my machine has D1, D2, D3. So I don't know how much is D1 and how much is D2, but theoretically D2 is more powerful than D1. So that's how, depends upon what machine you are using, it will give you the fluence in different ways. Now the different lasers that we use in our day-to-day practice, these are the common ones. There are many other lasers which are available in the market, but we can't afford to buy all of them, and so our needs are mainly these things. They are the ablative or non-ablative lasers, fractionated lasers, pigment lasers, laser hair removal machines, and intense pulse light. I gave intense pulse light separate because it's not a laser, it's a light source. Now ablative lasers is carbon dioxide laser, one, which is the most likable and the most or the best laser which you can have in a clinic. If you want to have a choice of buying a machine, buy CO2 laser, which is the best one. You can do many things with it. It's a multiple workhorse for you. Now, RPMag laser is also an ablative laser, but it is much superficial ablation. See, if a RPMag laser is passed on the epidermis, it gives you about the depth of 3 microns. The same thing if you do a carbon dioxide laser, it is more than 30 microns. In addition to that, I'll show you a next slide, where there is the ablation, then there is a heat zone, and there is a necrosis, then there is a heat zone. So whenever you are doing that, you should keep into mind also your heat zone, that how much it is produced. This all depends upon the number of passes you are doing. So the more the number of passes you do, the ablation or necrosis comes to a standstill after some passes, but your heat keeps generating and there is more collateral damage. So that one has to keep in mind when you are doing more number of passes. So most common uses are in the acne scarring, any benign tumors of the skin, or for cutting the skin or debridement of a tissue. When you do in a defocus mode, you can get the debridement done, and rejuvenation. Like these CO2 laser is mainly can be used for rejuvenation because it can cause tightening of the collagen. It causes remodulation of the collagen, and the tightening will give you the rejuvenating effect. Now, ablative fractional lasers, example is like I told you, CO2 and Erbiumab. Then the next is the non-ablative lasers. Non-ablative lasers can be any of this infrared, mid-infrared range, like Erbium glass, which is 1540 diode, 810, or longer pulse more than 1000, or long pulse NDM is 1320. So these are all the lasers which are used. But in practice, ablative fractional laser is always better than a non-ablative fractional laser. The results are much better in the ablative one. Now, in the fractional lasers are different from the ablative laser which I told you before. The fractional lasers, here the single beam is fragmented into multi-small beams, and the main fluence is again broken down into smaller fluence. So like if you have 40 joules as a fluence you are giving, the beams are broken down into say 5 or 8 joules each. So the damage on that particular point is less. But then you can have number of beams like this. The number of beams can vary up to 2000. So the adjustment is there where you can put the number of beams, and these beams causes a column of necrotic tissue when it falls on the skin, and these are called as the micronecrotic zones. Now these zones, the number of this MTZ depends upon your adjustment. You can do more, you can do less, depending upon what you want to do. The distance between these zones or MTZ can also be manipulated so that you get less or more density. And the fluence is the depth with which these will go. The number of passes is important because when this comes in a particular grid pattern, you do one pass, it comes in one pattern, you can rotate and do another, like once you can do horizontal, once you can do vertical, so that more of the area is covered. And the idea is when you are doing a fractional laser, it's only about 15 to 25% of the area you are doing is damaged or burnt or ablated by the laser. The rest is normal, and the regrowth from the normal tissue happens, and that's why the downtime is very less in fractional lasers. This is just to explain you. So this is here, if you are seeing this is a CO2 laser. This is non-fractional one I am talking about. This black area is the necrotic area, and this is the heat zone. That is, this is the tissue area which is also damaged, but partially compared to the other area. Now this is a CO2 laser and this is Erbiumab. See the difference in depth with a single pass. And the other one, what I am trying to show you is the difference between a non-ablative and an ablative fractional laser. In an ablative fractional laser, the stratum corneum is damaged, whereas a non-ablative fractional laser, the stratum corneum remains intact. It's only the dermal tissue that gets heated up. And this is the ablative laser, how it looks when you pass the laser. I was talking about the distance between the microthermal zone, and this distance is also called as pitch. So if you see the pitch here is 1000, the gap is 1000, this is 750, this is 500. And you see it is becoming denser and denser. That means the distance between two dots is only 500 here and this is 1000. So this is how you vary the fractional laser in the number of dots. Now why this is important? Now the more the dots, the more it resembles an ablative laser. So you get more damage. So if you have a high fluence and you put more dots, then your damage is as good as an ablative. So the benefit of fractional laser is not good. Similarly, if you put a low pitch and a high fluence, you get results without any complications. So the general rule is always, it is inversely related. The pitch is larger and the fluence is larger. So the number of dots per square centimeter is less when the fluence is high. That is the setting you should always do. In case of scar or scar revisions, this setting is advisable, doing low density high fluence. Similarly, when you want to do rejuvenation, it has to be again high density and low fluence. So this inverse relation should always be maintained if you don't want any complications. Now the pigmentation, what we normally use in our routine practice is either NDI laser or alexandrite, and ruby lasers is now out of here, at least in the Asian countries, because this is mainly meant for Fitzpatrick type 1 and 2 skin. Now the most commonly used laser is the NDI laser, and the Q switch or the quality switch is, in this the pulse duration is the lowest, it is in nanoseconds, and now the newer machines are coming in picoseconds. So they are meant because the pigment chromophore or the target is very small, so the TRP is also very small, so that's why the pulse width is in nanoseconds. Now, what are the parameters you are looking for? Same thing as I said, it can be either a nanosecond or a picosecond, and in this there is, you cannot change the pulse duration. It is fixed. Pulse duration is usually fixed in these machines. It can be either 2 to 10 nanoseconds, in between that, or it will be in the picoseconds. Frequency is one which you can vary as per your requirement. If you want to do larger area, you have a higher hertz, and if you have a smaller area, you can do a single frequency. Now 532 and 1064. 532 wavelength doesn't reach very deep. It is meant usually for epidermal pigmentations like freckles or lentigens, or even for seborrheic keratosis you can do, whereas 1064 is the pigment when it is in the dermal zone. So you choose 1064 when you want to reach for a deeper pigment, and 532 for a superficial pigment. You can mix and match also in the same lesion, because same lesion can have both superficial and deep, so you can do both. And when you are doing both, do 1064 first followed by 532. Now this has again a fractional mode also, which reduces the damage, because 532 is very dangerous. You cannot do at a higher fluence or raise the probe above the skin, or do more than 2 passes. So 532, one has to be very careful, and in that we have also now got fractional, so you can be a little bit liberal with use of fractional Q-switch lasers. Most of the effect they are producing is by photomechanical or photoacoustic. That is, they break up the target chromophore into smaller fragments so that it is cleared from the body by the macrophages. So it doesn't evaporate anything like we are seeing in the dermatologic lasers. So most of the things we are using here is the pigmented lesions like freckles, lentigens. These are all we can use 532 in these cases. And tattoos. Tattoos are again depends upon when you are doing it. If it's a fresh tattoo, it is more deeply placed. If it is an older tattoo, it becomes more superficial. So you can have a mix and match of both the things. 532 here can take care of the red pigment, whereas 1064 will do for blue and black. So tattoos you need to use higher fluence to get the results, whereas for this pigmented lesions you can go for a lower fluence also. And the newer trend that is being done is the laser toning and carbon peel with these machines. Most of them who are having these machines are doing more laser toning and carbon peel than any of this clinical subject treatment. So laser toning is to lighten your tone. It is mostly used for like tan removal, or in case of like lichen pigmentosus, you can do that. Carbon peel is done to reduce the oily skin, like if you have seborrheic melanosis, the seborrhea is there, pigmentation is there, you can use carbon peel, this reduces that, it even shrinks the pore and gives a color improvement. The next is the hair removal. Now, there are different machines in the market for hair removal, and don't go by the marketing gimmicks that only diode is good, so purchase only diode. Diode machine costs you almost your many years of saving if you want to buy the present state. All machines will give you results. It only depends how many settings you are doing, what are your parameter manipulations. So it is not that if you are using intense pulse rate, you will not get results. You can get results with even IPL as comparable to diode. But maybe diode will need 6 settings, so intense pulse rate will need 10 settings. But in both, you will get the results. Now, the idea is like NDI, when they promote you, it's complications, epidermal and the target tissue complications. So when you get in multiple sets with a pulse interval in between, then you get the result without causing damage at a high fluence. Now interval between the session, this is important. The different area of the body has got different hair cycle rates, so according to that you have to set your interval for doing laser hair removal. Like for the face, usually it is 4 weeks, for the legs or extremities usually between 2 to 3 months. So the interval has to be set, there is no point doing every month in all the regions. Now intense pulse light, if someone doesn't have much cash to buy all the lasers, this is the best machine to buy. It can do multiple work. You can attend to acne, you can attend to pigmentation, you can attend to vascular lesions, you can attend to rejuvenations, you can do all with this. So buy a good company IPL, it will do all your work. Yes, the results are not immediate to be seen, but you will get results. Now there are glass filters which are fitted to the hand probe, which will cut off the wavelengths below some length. Whatever you want for pigmentation, for vascular, it's like you put vascular, it will cut off anything below above 500, which is not needed for it. So these are all the things which you can do with the intense pulse light. Anyone is doing laser among you?
Excuse me,
Are they personally using, because if the institute has and they are not using, doesn't make a difference. No one has a hands-on experience? Yeah. Which machine are you using? Which one?
Fractional CO2, sir. Future of 40 is the
Fractional CO2. So what are you doing in this?
my thesis topic, sir, it's fractional CO2 laser versus derma rolling and acne scars, atrophic acne scars.
Okay. Now when you are doing fractional laser in acne scars, you are using as a monotherapy or it is one of the modes of treatment?
One of the modes, sir.
And how do you set your parameter depending upon the scars?
Depending upon the depth of the scars, the parameters are set, sir, the energy and the pulse width and all. In different patients.
Just give a number what you do. Say you have a box scar, you have a superficial box scar or a deep box scar.
First we subsize it, sir, and then we subsize it, subcision,
Okay.
and we raise the scar, and in later sessions